Good morning, everyone. I am Dr. Shubhajit. On behalf of Organizing Committee of ISNACC 2022, I welcome you all to the second day of the 23rd Annual National Conference of Indian Society of Neuroanesthesiology and Critical Care. So now I'm going to start our today's first session. Our first session will be based on pain management in neurosurgical procedures. So may I invite our first chairperson, Professor Dr. Padmaja Durga Madam. Madam,
good morning, everyone, online, and a very happy New Year to all of you.
Ma'am, good morning, ma'am.
Good morning.
So, Madam. So, Madam is Professor and HOD at Nimhans Institute of Medical Sciences. Her area of expertise is neuroanesthesia, airway management, and critical care. She has received the prestigious Vaidya Ratna Award and Best Teacher Award from Telangana State Government. She has 15 Best Paper Awards at conference, including Jatin Mehta Award, COPS Award. Madam has 54 original articles, 8 review articles to her credit. She has delivered 84 guest lectures at various conferences. Madam is editorial board member of 4 national journals and has organized 16 conferences till date. Welcome you, ma'am.
Thank you.
Our next chairperson is Dr. Jayanta Mitra, sir. Sir, very good morning, sir.
Good morning to all. Very good morning to all.
Jayanta Mitra, sir, is additional professor at AIIMS Bhubaneswar. He has done his MBBS from Calcutta National Medical College, MD from AAMU. He has done fellowship in pain management from Scalp Academy, USA, and fellowship in emergency medicine from ACEE, AIIMS Delhi. He has total 50 publications to his credit, and his area of research interest is neuroanesthesia, critical care and emergency medicine, and medical education. Sir, welcome you, sir.
Thank you.
Our third chairperson of this session is Dr. Harsha Prasar. Sir, very good morning, sir.
Good morning, please.
He is Director and HOD of Neurocritical Care and Neuroanesthesia at Medanta, the Medicity. Sir has done his FRCP from Glasgow. He has done his fellowship in neuroanesthesia from Royal Victoria Hospital, Belfast, and executive leadership for healthcare professional from Cornell University, USA. Among his awards and achievements, ISCCM National Presidential Citation in the year 2020 and 2019, Neurocritical Care Society USA Presidential Citation in the year 2020. He is founder president of Society of Neurocritical Care India. He has received ISACON 2018 National Award of Appreciation and Chairman Award ISCCM Delhi in 2017. Appreciation Award towards JCI accreditation in 2016. He was National Coordinator of Synapse ICU study in the year 2018. Sir is also founder president of Neurocritical Care Society of India. He has numerous publications and book chapters to his credit. Sir, welcome him.
Morning, everybody. Thank you.
So, may I request Professor Padmaja Durga ma'am to kindly introduce our first speaker, Dr. Shobanna Rajan ma'am, please.
Good morning, everyone. And it gives me a great pleasure to introduce Dr. Shobanna Rajan. We'll be talking on multimodal analgesia for spine, where pain management has been historically opioid and an area of ongoing research where we are moving on to multimodal analgesia. Dr. Shobanna works in neuroanesthesiology at the University of Texas Health Science Center at Houston. And she's also one of the board of directors for SNACC and is currently the vice chair for ICPNT, that is International Council for Perioperative Neuroscience. And she hopes to continue her vision to contribute in this area. And she has also contributed extensively to education in neuroanesthesiology. She has received the Distinguished Educator Award for teaching at ASA in 2021. And to her credit, she has a number of publications in neuroanesthesia education and also a lot of review articles and book chapters. Over to Dr. Shobanna for her talk.
Hello, everyone. I'm Shobanna Rajan, Associate Professor of Anesthesiology at the University of Texas Health Science Center at Houston. I thank the organizers of the ISNACC for giving me this opportunity to present this talk on multimodal analgesia for spine surgery. I don't have any conflicts of interest to declare, and I have 2 recent articles which I published on this topic, and I'd like to share those 2. The first one was Opioid Alternatives in Spine Surgery, a narrative review, and this was published in Journal of Neurosurgical Anesthesiology, January 2022. And the other one was in Anesthesiology, and this was a randomized controlled trial on a multimodal analgesic regimen for spine surgery. So with this, let us go ahead and start. A 67-year-old female is to undergo a T2 to T6 spine fusion. She has had pain for some time now and is on oxycodone and tramadol at home, so chronic pain. Surgeons are considering neuromonitoring. Her preoperative medications included aspirin 81 milligrams, metoprolol, extended release, 50 milligram daily, and losartan. So the typical spine patient who comes to us with having been on multiple pain medications, maybe with a baseline pain score of 6 or 7 out of 10. So the questions that we need to answer are, is opioid-free anesthesia and analgesia feasible and appropriate for spine surgery? If so, what are the options? What are the potential strategies for preventing persistent post-operative opioid use? Is opioid-free anesthesia associated with equivalent or superior outcomes compared to an opioid minimization technique in the perioperative period? So let's discuss the relevant literature for each of these questions and emphasize what we do not know and prioritize the areas of future research. While considering multimodal analgesia for spine surgery, although it appears like a simple concept, it's pretty complex because of the following reasons. Because spine surgeries can range from like a simple, non-invasive, single-level disc surgery to multi-level complex spinal fusion surgery. They can range from minimally invasive options to long incisions. Some of the patients are already on heavy opioids preoperatively, while some may not be, and they may be opioid naive. Associated comorbidities are present, heart and lung conditions, frailty, especially in the elderly, and this puts them at greater risk for respiratory depression if we were to give them analgesics and opioid medications. So before we delve into this, just a small glimpse at what could be the mechanisms of chronic pain in patients coming for spine surgery. Well, these include neuroplasticity and sprouting of the primary afferent nerve fibers, increased release of neurotransmitters like the excitatory ones like glutamate, functional changes in NMDA receptors and ion channels. And that's why we have drugs which act on all these mechanisms like ketamine and the gabapentinoids, glial activation and release of inflammatory chemokines. And therefore, their NSAIDs are definitely beneficial. Now, this is from the Journal of Neurosurgical Anesthesiology, the article that I mentioned. And the whole concept is divided into preemptive analgesia, perioperative intravenous adjuvants, neuraxial blockage, regional blocks, and local anesthetics. And we will look into this one by one. And let's start with preemptive analgesia. So preemptive analgesia is basically analgesia administered even before the onset of pain, because the belief is that it prevents central sensitization, which is the activation of central neurons, and therefore their amplified peripheral response to noxious stimuli is decreased. So Usually, preemptive analgesia is based upon the synergistic action of the non-opioid agents given in lower doses, but at regular intervals. And this improves the continuity of pain control, reduces adverse effects, and facilitates rehabilitation. So the main agents that were looked into were the gabapentinoids, acetaminophen, and the NSAIDs, which most of the key studies looked at these three agents. So let's first talk about gabapentin and pregabalin. And everyone know the mechanism of action, which is inhibition of calcium influx via the voltage-gated calcium channels, thereby inhibiting central sensitization. Now, for gabapentin, most of the studies say the dosage range is from 300 to 1200 milligrams, usually 1 to 2 hours prior to surgery. And Pandey et al. Reported that the optimal dose is 600 milligrams, right in the middle of this. Pregabalin has better tolerability. It is more efficacious and has a superior safety profile than gabapentin. So pregabalin at 300 milligrams was used in this particular study and found to be pretty effective, especially in combination with COX-2 inhibitors or NSAIDs. Now, there has been a recent article in Anesthesiology regarding the use of the gabapentinoids. This was a big study, meta-analysis, and they found that the gabapentinoids was not associated with clinically significant, clinically meaningfully different post-operative pain intensity. Therefore, those patients who received gabapentinoids did not fare better in terms of post-operative pain. However, there was a lower risk of post-operative nausea and vomiting, but they still had more dizziness and visual disturbances. And therefore, after this article, there's a realization that gabapentin may not be the best way to go in terms of preemptive analgesia. As far as acetaminophen is concerned, it's a favorite drug for all of us and remains a cornerstone for multimodal analgesia. It provides a moderate analgesic effect without many side effects at the appropriate dosing, and its impact on opioid requirements may not be apparent during the initial postoperative period, but the pain intensity is really high. But during the later postoperative period, when the pain intensity is moderate, it can easily be given at intervals between smaller doses of opioids, and it has been shown to reduce the costs and also decrease opioid consumption. As far as COX-2 inhibitors, and there is a big yes to NSAIDs from literature, and there are these studies which compared placebo with paracoxib and found that there was a significant reduction in opioid requirements in the first 48 hours. And there was another meta-analysis also which proved that NSAIDs have significantly, when NSAIDs were used, there was significantly less pain. Like we mentioned in the beginning, we showed that slide where we said we said inflammatory chemokines also is one mechanism by which chronic pain is persistent, and probably using COX-2 inhibitors may be a good idea in this situation. However, using ketorolac, the main concern is not only bleeding, but also its negative effect on impact on spinal fusion rates. So 6 studies were reviewed by Lee et al. And this was comprised of 1,500 patients, and they found that ketorolac administered for more than 2 days or at a dose of more than or equal to 120 milligrams per day had significant adverse effects on spinal fusion and should be avoided. But however, if you use it less than 2 days or for less than 120 milligrams per day, it did not have a significant effect on spinal fusion. So maybe giving just like 1 or 2 doses to help with the initial phases may not be a bad idea, will not cause the adverse effects of abnormal fusion, etc. Now, smoking has an adverse effect on spinal fusion, and ketorolac compounds this effect. So let's next go to perioperative intravenous adjuvants. And in this group, we have the Nmda antagonists, which comprise of ketamine, methadone, magnesium, and then we have lidocaine, dexmedetomidine, and even naloxone. So as far as NMDA antagonists, ketamine has been the focus of a number of studies and has been in the limelight for some time now, has garnered a lot of attention in the recent past. And there are many of these studies where they've used ketamine versus placebo or ketamine along with other medications like dexmedetomidine versus placebo, and have found that ketamine is potentially beneficial in some of the spine cases. So the studies which are pro-ketamine are some of the studies which have shown that the use of ketamine as well as dexmedetomidine caused a significant decrease in rescue analgesic requirement in the first 48 post-operative hours. There are studies which are also against this. Subramaniam et al. In their study failed to demonstrate any beneficial effect of ketamine in major spine surgery. These patients received either ketamine bolus or placebo, and they found that there was no difference in pain scores or opioid requirements between the two groups. And one of the reasons they is that because they used a lower dose of ketamine, about 2 mic per kg per minute for intravenous infusion. Now, there's another study again, which is not in favor of ketamine. And this was a study where I was also a part of. This is a randomized controlled trial entitled Multimodal Analgesic Regimen for Spine Surgery. So there were two groups. There was the analgesia pathway group, and there were those patients who got placebo. In analgesia pathway, they got preoperative oral acetaminophen 1 gram, preoperative oral gabapentin 600 milligrams. And then these patients got intraoperative lidocaine infusion at 1.5 milligram per kg per hour and ketamine infusion at 5 mic per kg per minute. So which is the exact right dose for ketamine. And those patients with placebo actually just got normal saline. And this was a double-blind study, and the anesthesiologists as well as the research coordinators did not know whether the patient got the actual drug or the placebo. And they found that pain management within the initial 48 hours was not superior with the analgesic pathway. Opioid-related side effects were similar in each group in the first few post-operative days, and the quality of recovery in 3 months was not different. And so this negative study is also an important component in literature, because it shows us that ketamine is not as highly effective as we potentially think it is. Okay, what about methadone? I have seen a lot of people giving IV bolus methadone just to avoid other opioid analgesics, especially in those patients who have the potential for opioid addiction, or if they want to avoid intermittent opioid bolusing doses, they just give 1 dose of methadone for the case. There was a retrospective review of about 1,500 patients by Dunn et al., and they reported mild to moderate depression following a one-time dose of methadone when used for analgesia after spine surgery. Hence, if methadone is used, appropriate monitoring is recommended in the post-operative period. The next drug is magnesium, which is another NMDA receptor antagonist, and can be used as an analgesic adjunct. In a trial of 50 patients who got magnesium, and the dose was about 30 milligram per kilogram bolus over 10 minutes, followed by a 10 mic per kg per infusion. So these patients had significant reduction in opioid dosage in the post-operative period. Let's next talk about dexmedetomidine, which is an alpha-2 agonist. The studies prove that it is useful in reducing the doses of intraoperative opioids, but then it stops there. There was no change in the post-operative opioid consumption when compared with placebo in patients undergoing thoracic or lumbar spine surgery. we'll next talk about neuraxial blockade. So epidural analgesia has been the gold standard for neuraxial blockade, and there have been many studies which talk about the efficacy of epidural analgesia. There was one study by Schlenk et al. Who randomized patients undergoing lumbar spine fusion surgery to receive either patient-controlled epidural analgesia, that is PCEA, or intravenous analgesia for post-operative pain control. Now, although pain scores at rest and on movement were consistently lower at all times assessed in the epidural analgesia group, there was no functional gain in terms of increased walking distance by those in the epidural group compared with the intravenous analgesia group. Another randomized controlled trial was performed by Fisher et al., and he found that the overall opioid dose was lower in patients using the patient-controlled epidural analgesia as compared to intravenous PCA. And therefore, epidural analgesia does seem to have a favorable effect. The next is regional nerve blocks. And as you know, that the erector spinae block has become extremely popular now. It can provide analgesia in the cervical, thoracic, and lumbar regions. It avoids the risk of dural puncture and epidural injection of local anesthetics and does not cause urinary retention. Hence, this has become very useful. There are two studies, I think, both by Singh et al., who compared the effect of ultrasound-guided ESP block on 24-hour post-operative cumulative opioid requirements and found reduced opioid requirement and improved patient satisfaction in patients on the ESP group. And therefore, many hospitals are now including ESP blocks in the RAS protocols. Finally, we come on to the local anesthetics. Liposomal bupivacaine has been tried, but clinically, the studies have really not shown to be beneficial. The other thing is the dural sponges, and dural sponges dipped in morphine seems to be helpful in one of the studies. However, there was a trend towards benefit, that is decreased opioid requirement, but more studies need to be done to prove that this is really the case. So overall recommendations for perioperative pain management in patients undergoing complex spine surgery was published in the European Journal of Anesthesia. And they say that oral or intravenous paracetamol preoperatively has a grade D recommendation. Oral or intravenous NSAIDs or COX-2 specific inhibitors, grade A recommendation. Ketamine infusion, grade A. Post-operative recommendations, epidural analgesia with local anesthetics and with or without opioids, grade B recommendation. Oral or IV paracetamol, grade D. Oral or IV NSAIDs or COX-2 specific inhibitors, grade A. And opioids as rescue medication is a grade D recommendation. Now, oral gabapentinoids, IV methadone, erector spinae block, other blocks, IV lidocaine, IV dexmedetomidine, epidural opioids, IV magnesium is not recommended in patients undergoing complex spine surgery, according to this guidelines. So what are the strategies to prevent post-operative opioid use? The first step is a tailored and patient-specific scientific approach, and this is accurate preoperative risk identification. For example, patients having depression may be more prone to become persistent opioid users. The second would be to use proper multimodal analgesia in the perioperative period and minimizing opioid usage, not only in the perioperative period, but also post-discharge. And this would definitely be some of the strategies to prevent persistent opioid use in the post-operative period. So ultimately, our goal would be to have a patient with a pain score of 0 or 1 to 3 in patients with undergoing spinal cord surgery. Thank you again for this opportunity to present.
Thank you, Shobanna Rajan ma'am, for such a wonderful talk. All the attendees are requested to kindly put their questions in the chat box, and questions will be taken at the end of the session. May I now request Dr. Jayanta Mitra sir to kindly introduce our next speaker, Dr. Deepak Sharma sir, please.
Dr. Sharma's talk is the third talk, I think.
Sir, sequence is little bit changed. So now Dr. Deepak Sharma will be delivering his talk first, and after that, Pradipta.
I have his introduction. If you allow, I would introduce it.
Sure, sir. Sure, sir. Please, sir.
So, may I take the pleasure of introducing Dr. Professor Deepak Sharma, who's going to speak on post-craniotomy pains. Dr. Deepak is the immediate past president of SNACC. He's the chair, Neuroanesthesia track ASA. He's the scientific advisory board for the Association of University of Anesthesiologists. He's the education director at Cardiovascular Lab, University of Washington. He's the inventor of TCD simulator for training and assessment, has more than 100 publications, more than 120 invited lectures, more than 20 visiting fellowships in various prestigious universities, 5 editorial boards, and reviewer of 19 journals in anesthesiology, critical care, neurosurgery, stroke, and neurotrauma. The special interest and expertise in cardiovascular disease, TCD, ultrasonography, and traumatic brain injury. He is renowned globally for his advances in stroke care. May I please take the pleasure of inviting Dr. Deepak Sharma to deliver his talk.
Hello, everyone, and greetings from Seattle. Thank you very much for the kind invitation to join you all for the meeting. It is unfortunate that we are not able to meet in person given the pandemic, but it's wonderful to note that the scientific deliberations are on. As I was planning to attend the ISNACC 22 meeting in Kolkata, I walked down the memory lane and I was able to recollect some of the wonderful memories from the last ISNACC meeting we had in Kolkata about a decade ago. I relish and still remember the wonderful things about the scientific program as well as the beautiful city of Joy. I do hope that I will be able to see you all in person in not too long. So for today's agenda, here are the disclosures for my presentation, and none of this should impact the content of this talk. So what I'm going to do over my allocated time today is talk to you about the recent evidence for perioperative therapies for post-craniotomy pain. I'm going to focus primarily on therapies and medications that are utilized by the anesthesiologists in the immediate perioperative period and that target mostly the acute post-craniotomy pain. I'll then very briefly discuss institutional initiative that we have started here at the University of Washington regarding pain stewardship. And finally, I'll provide some practical recommendations for pain management after brain surgery. So looking at the incidence of moderate to severe post-craniotomy pain on day and 2 after surgery, as you can see here, it can range anywhere from 10 or 11% to as high as 80 to 90%. So this is certainly alarming. At the same time, very interestingly, if you look at the incidence of pain months or even years after surgery, you can see up to 20 to 40% patients can have pain up to 2 years after surgery, majority of them undergoing infratentorial craniotomy. So this is certainly a significant problem. For today's presentation, I'm going to focus only on the acute post-operative pain. And as we think about that, we do recognize there are certain risk factors for post-craniotomy pain. And these include a young age, female sex, and the presence of anxiety, depression, and pain preoperatively. In addition, the surgical approach can impact post-craniotomy pain. We do know that patients undergoing infratentorial craniotomy compared to supratentorial craniotomy tend to have a higher chance of having post-operative pain. Also, a temporal approach and suboccipital approach is a risk factor for post-craniotomy pain. It is believed that it's the surgical approaches involving the retraction of muscles and the bone work in this area that is primarily responsible for pain, as opposed to the intracranial lesion in that area of the brain. Now, while the post-craniotomy pain can be a very distressing and unpleasant experience, there are other significant implications of pain after brain surgery. And these includes nausea and vomiting, hemodynamic changes that can lead to intracranial hypertension, and in the worst case scenario can contribute to an intracranial bleed. Pain management can sometimes be very complicated and can lead to prolonged hospitalization, and all of this can lead to an increased cost of care. And finally, for those patients who have pain even months or years after brain surgery, the chronic post-craniotomy pain can be severely debilitating and can impact their quality of life. Opioids remain the cornerstone of pain management for surgical patients, including brain surgery patients, and a variety of opioids are available that are used variably across the world. We obviously use these medications perioperatively through the IV route in most scenarios, and there is an emphasis on patient-controlled intravenous analgesia post-operatively, which is often considered safer, although oral medications are also commonly used. Now, there are very few data comparing one opioid to the other for post-operative pain control in craniotomy patients, so it's difficult to make recommendations for one over the other, but I'm sure every institution has its own preferences. And it suffices to say that opioids are a cornerstone for pain management after surgery. But despite their effectiveness, there are certain concerns with opioids, and these include the sedation and pupillary changes that can impact the ability to perform neurological assessment post-operatively. Nausea and vomiting can be concerning, and very importantly, there is concern about respiratory depression, which can lead to CO2 retention and therefore intracranial hypertension. In severe situations, it can lead to apnea, hypoxemia, and significantly increased morbidity and mortality. So in general, there is a significant concern around the opioid use, or excessive opioid use, should I say, and there is a movement to more judiciously use opioids or avoid them when they are not needed. And that has led to the development of what's being referred to as the opioid-free anesthesia or the opioid-free analgesia. I personally feel that opioids do have a role, especially in the perioperative period, and they have to just be used judiciously. But interestingly enough, this group of investigators recently published this systematic review, and they found 4 studies looking at opioid-free analgesia during craniotomies. 2 of these studies looked at scalp blocks, and the other 2 studies looked at dexmedetomidine and acetaminophen. As you can see here, none of these techniques was found to be superior to the opioids. That said, effective perioperative pain management for brain surgery patients requires a multimodal approach that needs to incorporate not only a number of pharmacological approaches, but also non-pharmacological approaches. And the preoperative interventions one can think of include risk assessment, patient education, consultation with brain services in select patients, and the use of medications when appropriate. It is important to emphasize that patient education has to specifically address pain management. It is important to set expectations for pain control after surgery, and also talk to the patients about the side effects of the medications that might be used. Patient education can be delivered in a number of ways, not only through direct conversation, but also by means of written pamphlets, website information, etc. Now, let's talk a little bit about some of the medications that have drawn significant attention in the last few years. Most important of these is gabapentin, which seems to have been experimented with extensively. This is a study where 80 patients undergoing supratentorial craniotomy for tumors were randomized to receive either gabapentin or phenytoin for 7 days preoperatively and postoperatively. What the investigators found was that patients who received gabapentin required less propofol and less remifentanil during the surgery, but still had a prolonged extubation time compared to the patients who received phenytoin. Importantly, 2 patients required CT scan postoperatively to rule out an intracranial catastrophe because of delayed extubation, although no surgical pathology was actually found in these patients. Now, this is important to note because the exposure to CT scan has significant implications in terms of both patient safety as well as cost of care. In the study, if you look at the visual analog scores, the pain scores in patients receiving gabapentin were lower than the patients receiving phenytoin for the first 2 hours after surgery, and then the difference disappeared. During the same period of the time, patients who received gabapentin were more sedated compared to the patients who received phenytoin. Now, despite the fact that the difference in pain scores was significant only for 2 hours, the difference in morphine consumption was significantly lower in patients who received gabapentin for up to 48 hours after surgery. But I do want to highlight some of the side effects that were noted in this study. And in addition to the sedation and drowsiness that we talked about, this include other things such as dizziness, ataxia, fatigue, and others. So a significant side effect profile. So looking at the complex dosing regime for the study, this next study, which actually came from India, looked at the effect of a single dose of gabapentin in terms of pain control. But as you can see here, unfortunately, it found no advantage in terms of either pain control or opioid consumption. This study was recently published in the Journal of Neurosurgical Anesthesiology. It came from China. And in this study, the investigators randomized patients undergoing subtemporal suboccipital craniotomies to receive either gabapentin or placebo. Gabapentin in this study was administered in 2 doses. The first dose was administered the night before surgery, and the second dose was administered shortly before surgery. And with this regime, they found that pain at rest as well as on movement was less in the patients who received gabapentin compared to the patients receiving placebo for up to 24 hours. Again, in this study, they also found higher sedation scores in patients receiving gabapentin, although there was an advantage in terms of lower incidence of nausea and vomiting. Pregabalin has also been examined, and in this study published in Journal of Neurosurgery, patients were randomized to receive pregabalin or placebo the evening before surgery, 1.5 hours before surgery, and then twice daily for 3 days after surgery. And with this, the investigators found that the patients receiving pregabalin had lower pain scores in the neurointensive care units on the post-operative day 1, as well as on post-operative day 2, although the advantage seemed to disappear on day 3. So synthesizing all the data that we have on gabapentinoids, it seems that they do have an advantage in terms of lowering the pain scores, reducing the opioid need, and also reducing post-operative nausea and vomiting at the same time. But importantly, the dose regime is very complex. A single dose does not work. You have to give multiple doses over days. The concern with delayed emergence and sedation is still there. Dizziness and ataxia are common complications. And they have significant implications in terms of risk of fall and other issues, which are very concerning. In the end, it requires close monitoring, particularly in the perioperative period, and that can have implications both in terms of logistics as well as cost of care. So I would say gabapentinoids are not something I would recommend routinely for post-craniotomy pain control, but this is a group of medications that one might consider in select refractory cases. Next up, I want to talk about intravenous acetaminophen, which has drawn significant attention in the last few years. This meta-analysis includes 5 randomized controlled trials that looked at intravenous acetaminophen in patients undergoing craniotomy. And as you can see from the forest plot here, the pain scores with acetaminophen were lower. So preoperative IV acetaminophen is associated with reduced pain as well as need for rescue analgesia, as well as the dosage of analgesics. Interestingly, however, if you look at the individual 5 studies included in this meta-analysis, you will see that only one of these studies actually found lower pain scores with acetaminophen. With all others, there was not that difference. Also important to note that only in one of these studies was acetaminophen administered preoperatively. In all others, it was started at the time of skin closure during the surgery, and then it was repeated every 6 hours for about 24 hours in all these studies. So acetaminophen seems to be a useful adjunct for controlling post-craniotomy pain, although its efficacy as a primary or a sole agent is just not there. Also important to note that a single dose is not enough, and one has to give it for at least 24 hours after surgery. Also interesting to note that while the effectiveness of intravenous and oral acetaminophen seem to be comparable in general, there are no data to compare these two administration methods for craniotomy. Next up, I want to talk a little bit about dexmedetomidine, which has become very popular in neurosurgical anesthesia in the last decade or so. So this meta-analysis of randomized controlled trials looked at 21 studies that randomized studies that addressed dexmedetomidine in craniotomy patients. And as you can see on the forest plot here, in terms of post-craniotomy pain control, dexmedetomidine offered a cumulative advantage compared to placebo. At the same time, dexmedetomidine also helped reduce the incidence of post-operative nausea and vomiting and was associated with a lower incidence of hypertension and tachycardia. However, if you look at the individual studies included in this meta-analysis, it'll become very obvious to you that there is significant variability in how dexmedetomidine was used. In some of these studies, a bolus was administered, in others, a bolus was not administered. The dose regimes were very different. So there was a significant variability. And also important to note that most of these studies were done in patients undergoing supratentorial craniotomy. So one has to recognize certain limitations of the data that we have on dexmedetomidine. Typically, no plasma concentration data are available, and this is something that can potentially explain the variability in the clinical effect that we see with this medication. Also, in most of these studies, the patients received additional medications for prophylaxis for pain and postoperative nausea and vomiting, and therefore the advantage that we see in this analysis may not be solely the advantage of dexmedetomidine, but the added advantage of other medications. And finally, it is important to note the variability in the pain control management plans and the regimes in these studies. But that said, dexmedetomidine seems to be an effective adjunct for pain control, and it offers other advantages in terms of reducing postoperative nausea and vomiting and providing better intraoperative hemodynamic stability. And for this reason, this is an agent that has become very popular, including at my institution, where we frequently use it intraoperatively. Now, I assume that my previous speaker has already addressed the issue of regional anesthesia in neurosurgery, including scalp blocks for craniotomy. So I'm not going to dive into details here, but I do want to note that scalp blocks are commonly used for or routinely used for awake craniotomies, but they seem to be underutilized in general for craniotomies under general anesthesia. The data in terms of pain control with scalp block seems to be variable, with some studies having a positive effect and the others demonstrating the opposite. Here's one study from 2019 that compares scalp block with local infiltration with lidocaine and a control group. And you can see there in this study, there was an advantage in terms of pain control for up to 48 hours with scalp block. Finally, I want to touch briefly upon the non-steroidal anti-inflammatory drugs. There is certainly a concern about interference with platelet aggregation and therefore the risk of bleeding, which is why these drugs are not very popular in neurosurgical patients. But that said, there are at least 2 randomized controlled trials with diclofenac, one of them involving preoperative administration of diclofenac, and both of these studies found a reduction in pain scores and opioid requirement with no significant adverse effect. There's one study with ketoprofen, which did not find any significant advantage, and then 2 studies with COX-2 inhibitor pericoxib, which interestingly found contrasting findings on pain scores and morphine requirement. So non-steroidal agents are not big in terms of post-craniotomy pain control. They are not very popular, but they seem to be options that one can use in cases of severe or refractory post-operative pain. Changing gears a little bit, I want to talk about our initiative at the University of Washington, where we look at quality measures after surgery, and we have developed quality measures specific to neuroanesthesia that we refer to as PONS measures, or perioperative neuroscience quality measures. One of these quality measures is post-operative or post-craniotomy pain control. So what we do here is we routinely measure pain scores for our patients after craniotomy, and these pain scores are then displayed in the form of a dashboard routinely for the review. You see here this pie chart displaying pain score distribution for our patients after craniotomy for a random period of time, and at the bottom, the mean and the median pain scores are displayed as well. So what this allows us is the ability to continuously watch the overall patient experience in terms of patients' pain scores, which is important in addition to the experience of an individual patient. It also allows us the opportunity to compare and contrast the various medications and interventions that we use at our institution for pain control. In addition, we also carefully look at the data for side effects, and we watch for the incidence of reintubation after elective craniotomy. And what you see here is the reintubation avoidance after elective craniotomy. And so only 1 or at max 2% patients in our institutions were reintubated after elective craniotomy. And naloxone was administered in no patient in the last 3 years or so. And this indicates that opioids can in fact be incorporated judiciously and safely in perioperative pain management protocol for craniotomy. So to summarize, in terms of practical perioperative pain management, it has to involve a multimodal approach. It has to involve close communication between various teams, including anesthesiologists, surgeons, as well as intensivists and pain physicians where needed. In the intraoperative period, regional anesthesia seems to be something that is underutilized and can be utilized more often. Dexmedetomidine and acetaminophen seem to have fairly good advantages and are safe to use. And in fact, we use them very often at our institution. The data for other medications such as ketamine and lidocaine are limited, but they are options one could consider. In the post-operative period, I would say patient-controlled analgesia is very important, and this is what we advocate for at our institution. Opioids do have a significant role, although we try to taper them off as soon as possible. Non-steroidal agents can be used in select patients for refractory and severe pain. I haven't touched into the details of this, but non-pharmacological pain management measures and things like modification of head dressing are also important for effective pain management. With that, I would like to thank you all once again for the opportunity to join you for this meeting. Later this year, we are hosting the 50th year anniversary meeting of SNACC in Seattle, and I hope to see many of you in that meeting. Thank you very much once again.
Thank you, Deepak Sharma sir, for such a wonderful talk as always. So may I request all the attendees to kindly put their questions in the chat box, please. Now, may I now request Dr. Jayanta Mitra sir to kindly introduce our last speaker for this session, Dr. Pradipta Bhakta sir, please.
Thank you, Dr. Shobana and Dr. Deepak for the excellent talk. A very good morning to all. Namaskar. It's a pleasure to invite the next speaker, Dr. Pradipta Bhakta, a very good friend of mine. He is presently working as a consultant in the University Hospital, Waterford, Ireland. After finishing his MBBS and MD from Kolkata, he did his further training at All India Institute, New Delhi. He also worked some amount of time in Sultan Qaboos University Hospital, Oman. He has passed EDIC. He has more than 90 publications in his name. He has written 5 chapters in a book. His area of interest is in the regional anesthesia, mainly pain, intensive care medicine. So today he is talking on scope of regional anesthesia in neurosurgery. Over to Dr. Pradipta for his talk. Thank you.
Okay, sorry, just for some technical glitch. Wait a minute, I'll just share my screen.
Yeah, Pradipta, your screen is not yet visible, I think.
Let me check.
Yeah, please.
Hmm. Think not sure. Wait a minute.
Can you see in share screen, sir?
Yeah.
Share screen at the bottom.
Yeah.
Yeah. Share screen at the bottom. I'm doing that.
Yes.
On the share screen, sir.
The green one.
Yeah.
Then we select your PPT, sir, over there. Says PPT is open, sir.
What?
Is your PPT is open, sir?
Yeah, PPT is open.
Then share screen, then select the PPT, then share, sir.
Yeah. Trying to.
Hello.
Yeah, yeah.
Sir, can you see the button on Zoom? Can you see the Zoom screen?
Wait a minute. I'm coming now.
Can you see the green share screen on Zoom?
Yeah, I'm coming now. Wait a minute.
Start
Let's
screen.
go.
Coming, sir.
Are you able to see now?
Not yet. Yeah.
It's coming.
Yes. Yes, it's visible.
Sorry for I'm not that much technological advance, and it is about 3:30 a.m. in my place. Anyway, thanks for inviting me for this conference. Many thanks to Indranil, my junior colleague and during my post-graduation, and Jayanta, with whom I worked in All India Institute of Medical Science. We share same hostel, both Indranil and Jayanta. Today my topic of discussion is scope of regional anesthesia neurosurgery. As everybody know, most of the neurosurgical operation are being done by general anesthesia, mostly because of the preference by the surgeon, patient groups, and the fear of the anesthesiologist of failure also, and limited option of the regional anesthesia and neurosurgery. Definitely, neurosurgery has got great option or opportunity here, as Deepak discussed, not only as a component of multimodal analgesia to provide best quality of analgesia afterwards, but also it can be used as a sole anesthetic technique in some selected surgeries. More and more spine surgeries being done in sole regional anesthesia technique, including neuraxial techniques or paravertible techniques. But there are some surgeries being done in the craniotomy as well. Though AVEC craniotomy has been reported in literature with under sole regional anesthesia about 100 years or more ago. First, I think, used by Herbert Cushing, and then it's forgotten. And people then started using later on just because of the revolutionized neurosurgery options, and basically using epilepsy surgery, eloquent brain area surgeries, deep brain stimulation surgeries. So it is coming up more and more as a sole technique as well. Part of the regional anesthesia were used as a multimodal component of analgesia to provide a post-operative pain relief. As you all know, regional anesthesia possibly provide the best quality of pain relief afterwards. As for immediate post-operative pain relief lasting for up to 24 hours compared to other analgesic modality. And some neurosurgery, especially multi-level reconstructive spine surgeries, are quite painful, and pain can start after 4 hours of surgery to last up to 3 hours, 3 days of surgery, post-surgery, and that can lead to constant significant morbidity, and which can interfere with the mobilization as well. I'll be touching a little bit of part of different surgeries and scope with the brain surgeries as well as spine surgeries. So as we see, in neurosurgery, possibly the best option of using regional anesthesia is avoidance of general anesthesia wherever possible, or supplement general anesthesia to reduce the opioid requirement, sedative requirement. This has got other advantages like avoiding complications of the ARA intervention that induce hemodynamic stimulation, as well as post-operative nausea monitoring, opioid-related side effects, decreased length of stay on the hospital, and also economic benefit in the developing world. Also, definitely, the post-operative pain control is main problem, main advantage you can see. And so in some cases, gold standard definitely, or most of the time, you can see that major possibly mainstay of the post-operative pain relief is the opioid still now in majority. Even in opioid with component of multiple analgesia using non-opioid, sometimes pain relief may not be that adequate. And in complex spine surgeries, even PCA, which is the gold standard of the opioid therapy, can sometimes be inadequate, and patients feel significant pain in spite of using high level of PCA analgesia, and that leads to possibly chronic post-surgical pain, ultimately chronic pain. And also it has got problem with opioid-induced hyperalgesia and opioid dependence, tolerance. Of course, using regional anesthesia leads to early recovery of bowel function, improved tolerance to physiotherapy, improved overall pain score, patient satisfaction, and ultimately reduces the CPSP and chronic pain, progression to chronic pain. So closing a silent gateway to opioid use and dependence, possibly worldwide, as you know, it has been a possibly endemic to epidemic overuse or misuse of opioid unnecessary. And that led to development of several segments of opioid-free anesthesia or opioid-sparing anesthesia all over the world, with especially early recovery after surgery plan, ERAS protocol. This is the main reason that more and more people are shifting towards the multimodal analgesia or using regional anesthesia as a main option or analgesic option. So they use mainly to take care of the pain, regional anesthesia, allow surgery to be done without being unconscious, and lesser complication than general anesthesia or monitored anesthesia care. Either long-acting local anesthesia with or without adjuvant can be used, or even catheter technique. And latest option is the exaparal, which is the liposomal bupivacaine, which can be used, possibly can reduce the use of the catheter or even eliminate the use of the adjuvants. Or it can become a component of as multimodal analgesia, as I said, as you read. So again, benefits of opioid-free anesthesia or opioid-sparing anesthesia, at least I'd say better opioid-sparing anesthesia than completely opioid-free anesthesia in majority of the neurosurgical procedures. So stable hemodynamics intraoperatively decreases, as usual, opioid-induced respiratory depression, and as good control of acute postoperative pain lead to possibly less progression to the CPSP or chronic pain. Increase effectiveness of opioid administered postoperatively, and as well as reduced side effects of the opioid. That is the other advantages. So it can be applied to most surgeries, the RES protocol, and it can be integral component of different other surgeries that we know. As usual, there are drawbacks of systemic opioids, you all know, and most of them is the problem is the opioid endemic and opioid-induced tolerance and dependence. So what types that we can use in neurosurgery? As usual, I said, neurosurgery mainly involves the brain surgeries and then spine surgeries. Obviously, spine surgery has got more utility of the regional techniques, but even regional techniques can be used in craniotomy, mainly the scalp infiltration and scalp block. And in spine surgery, it can be neuraxial block like spinal anesthesia, epidural anesthesia, combined spinal epidural anesthesia, or paravertible block, even field block like interperoral block, and interfacial plane block is the newer addition to this after basically ultrasound guided regional anesthesia is the advancement in this area. So scalp infiltration has been used, I think, historically since I think Halstead, and then Harvey Cushing popularized it. Most of the neurosurgeon uses it before, I think, putting the screw on bar hole. They use mostly lidocaine with adrenaline, and some uses bupropion with adrenaline. Is mostly for providing analgesia before putting the scalp fixation. It has been found to be that beneficial little bit after surgery until up to 2 hours, but after that it is not found to be much of beneficial, and there is chance of local anesthesia systemic toxicity. The problem with the scalp infiltration is that it probably provides the analgesia to the incisional site, does not involve any other visceral component. So there remains the limited, and also it gets absorbed quickly. So efficacy is quite limited, and possibly whether exaviral or liposomal bupropion can add to this is a debatable question, needs to be studied. The next option is the scalp block, and definitely it is the one of the part and parcel or main component of the craniotomy surgery. And if it is only awake technique, then it has to be a effective technique, or even it can be used in the awake sleep technique in combination. Also, it can be used in both adult and pediatric populations. Both for, as I said, only sole anesthesia, but it requires very much patient cooperation and proper patient selections, and also can be used for post-operative analgesia. Mostly used by landmark technique, but now ultrasound guided techniques are coming very much in this area. So ideally 6 to 7 nerves have to be blocked, and mostly bilateral block has to be done. So they are basically anterior scalp is covered by the terminal branches of the trigeminal nerve, which are frontal nerve, maxillary nerve, and mandibular nerve. So frontal nerves are supraorbital, supratrochlear, and maxillary nerve is zygomatic-temporal, auriculotemporal, and then mandibular, auriculotemporal, and the posterior scalp is by greater occipital, lesser occipital, and third occipital comes lesser occipital or third occipital nerve comes, which is branch of the cranial nerve. So this posterior scalp is mainly supplied by the cranial nerve, and anterior is by the trigeminal nerve. So as classically described technique is you have to fill the supraorbital ridge, and then you can directly inject there without entering to the supraorbital foramen. And from the supraorbital area, you can just medially extend this to include supratrochlear nerve, zygomatic-temporal nerve by lateral border of the supraorbital ridge, and it has to be in a fanciful manner to cover the superficial and deep to the temporalis muscle. And the auriculotemporal nerve can be blocked in front of the tragus of the eye, above the temporomandibular joint. Greater occipital nerve can be blocked in the nuchal line, in the middle to lateral third of the nuchal line from the occipital protuberance, just lateral to the greater occipital artery, and then lesser occipital nerve is just behind the ear. It actually near to the mastoid, where the sternocleidomastoid muscle attaches. It just overlaps the muscle. It can be blocked in that area, or just lateral to the greater occipital nerve block. And then lesser occipital nerve usually requires your neckline, and mostly done by the ultrasound guided technique. So as usual, as I said, nowadays mostly ultrasound guided technique coming up. So you can see basically supraorbital ridge using high frequency. I think hockey stick probe will be better, or linear probe can be used, and supraorbital foramen can be seen, and a needle can be introduced near to the foramen, and then supratrochlear is by the side of the middle. It is difficult to see under ultrasound, and but can be tried. And then, as I said, zygomatic-temporal, you can see the superficial temporal artery, and that is the location where you can infiltrate on both sides. And then also greater occipital nerve, as I said, and the lesser occipital nerve by the side also, it can be blocked. And these are basically very difficult to see, but artery is your landmark where you can penetrate. So as I said, as I said, these are basically the nerve which actually requires quite a high volume of the local anesthetic, and has to be very careful to prevent the intravascular puncture. Or adrenaline addition is possibly helping here. And other component that are coming to us is the spine surgery, where scope of regional anesthesia is possibly more than cranial surgery. The neuraxial anesthesia has got a definite place, and it has been used quite extensively, and it is coming up more and more, which has been used possibly early 80s, and then it went out of vogue mainly because of the problem with the prone position using the spine surgery. Patient movement satisfaction is not that good, surgeons awareness, and use of neuromonitoring, where if you use neuraxial anesthesia block the nerves, neuromonitoring becomes very difficult. But afterwards, it is becoming more and more useful as a sole technique, as well as for providing post-operative analgesia as well. So spinal anesthesia can be mostly used and can be used in selected patients where 1 or 2 level surgery can be done. But any surgery lasting for more than 2 to 3 hours will be difficult for a patient, and especially if the patient is positioned in a jackknife position type of thing, that it becomes difficult for the patient to tolerate longer procedure. But otherwise, spinal anesthesia, most commonly used drug is bupivacaine. It can be used combination of the opioid, and it gives good post-operative analgesia and lasting for even 24 hours with opioid. And long-acting opioid can be used with a liposomal morphine. That is the another option. Again, surgeon can add to the top up of the spinal anesthesia, or even surgeon can add the opioid at the end of the surgery. Anything? Some sounds are coming. Okay. Yeah. So judicious selection of the patient is very important here, because as I said, patient participation, patient immobility is the important thing during the surgery. And definitely other option, as I said, epidural anesthesia. Epidural anesthesia mostly used here as a analgesia than the sole anesthetic technique, because the problem is that if you use single side epidural has got no benefit of a spinal anesthesia, first of all, and if you use catheter, it most of the time it interferes with the surgical area. Surgeon may not like it, and using an epidural catheter and then neuromonitoring postoperatively is a little bit controversial, but it has been used extensively for providing postoperative analgesia, both as a simple local anesthetic, bolus or infusion, or combination of the local anesthetic and opioid. Local anesthetic opioid has been found to provide analgesia lasting for about 72 hours and giving a good pain relief as well. A surgeon can put the catheter as well, or it can be put by before the surgery by the anesthetist as well, usually above the level of the spinal surgery. And that can provide good analgesia, but sometimes it is difficult, especially neuraxial anesthesia, when there are some problem, especially accepting the specific problem to the regional anesthesia. If the patient is having complex spinal procedure, already spinal instrumentation, or patient got severe spinal canal stenosis, or compromise neurological damage is there. So in those patients, possibly it is not very safe to use neuraxial anesthesia, but has been used as well. And combined spinal epidural anesthesia has been used, but the reports are very, very limited. though it can, there are, I think, few limited to the few case reports. So it is a very good option to combine both the advantages of the epidural and spinal, and epidural can be used in the postoperative analgesia as well. Coming to the paravertebral block, it has been used mainly for the thoracic spine surgeries, but has to be done in the bilateral area. It avoids some of the dreaded side effects of the neuraxial blocks, provides good amount of postoperative analgesia, and again, opioid can be used, again, catheter technique can be used. And ultrasound has revolutionized the paravertebral block, increasing the safety and reducing the complications. But again, reports or randomized control trials are very limited. So mainly used in the other surgeries like thoracic surgeries, but it has a role into the spine surgery as well. The main explosion of the regional anesthesia in spine surgery is the intrafocal pain block, and thanks to the ultrasound guided regional anesthesia, that led to discovery of several intrafocal pain block. So first of all, quadratus lumborum pain block. It is mainly used basically abdominal surgery. It has got very good visceral component. QLB 1 to 3, even 4 block has been, which is the intramuscular injection, has been reported. Provides a dermatomal block lasting from T7 to L3. It can be used in lumbar spine surgeries, and even catheter has been used to provide lasting analgesia for about 72 hours. Not only that the blockade of the ventral nerves is the mechanism, but also rich network of the sympathetic fibers around the thoracolumbar fossa is possibly the mechanism involved here, and this has got good visceral component. But the role of quadratus lumborum pain block, possibly in spinal surgery, is not that extensively studied in a randomized control trial. It is possibly superseded by other alternatives, which I'm coming later on. Raphael Blanco first described it in 2007, and then I think Jens Borglum published a new ultrasound guided block, which is with Samrock Science, and Michela Visoui published the first use of catheter. Then LA's local anesthetic is deposited close proximity to the quadratus lumborum muscle, and different type of block, which you can see QLB 1 to 3, depending on where you are injecting. Possibly QLB 3 will be the better for the spine surgery rather than QLB 1 and 2, which are mostly used in the abdominal surgeries. As usual, I said QLB 1 to 3, what you can do, and again, it can be done in the prone position as well, the QLB 3. Then other option is the retrolamellar pain block. It is basically coming up a very good way, but I think it has been superseded by thoracolumbar interfacial pain block. Retrolamellar pain block is the problem is that seeing under ultrasound, always seeing the lamina, injecting the needle and guidance, sometimes intrathecal spread is problematic. So that's why it is not very popular, but has been used to provide good amount of postoperative analgesia. As you see that when you start from the costal level, you see the ribs, and gradually if you move from lateral to medial, you'll be firstly seeing the rounded structure of the rib turning to the transverse process, then towards the lamina, where you can go from the craniocaudal direction to inject the local anesthetic, about 20 ml, and again a bilateral block is needed to provide analgesia. Again, what I've said that your ultrasound imaging is most important for the retrolamellar block. So it is possibly superseded by thoracolumbar interfacial pain block, which is possibly better rather than injecting directly near to the lamina, where you have a risk of injecting intrathecally. Again, it was initially classic technique was described from lateral to medial, where injection was done in between the multifidus or longissimus muscle. But again, later on, intrathecal injections was reported with complications. So it has been modified later on, where the injection is made between the longissimus iliocostalis muscle, where viewing this muscle interfacial plane is possibly easier ultrasound wise. Modified thoracolumbar interfacial plane block has been well studied in the spinal surgeries. It has been found to be providing good amount of post-operative analgesia, even lasting for about 40 to 72 hours. And catheter can be used. Again, there are several studies ongoing, even clinical trial registry in between comparison between retrospinal plane block and thoracolumbar interfacial plane block. Advantage of thoracolumbar interfacial plane block is that it's possibly only blocks dorsal lemma of the spinal nerve, which is mainly sensory, rather than erectospiny, where there are theories that it can block the ventral nerve, causing about motor weakness a little bit, which can interfere with the, again, neuromonitoring and postoperative early neurological monitoring, again, SSCP, MEP monitoring. So in that aspect, possibly thoracolumbar interfacial plane block is possibly a little bit better, but the drawback is that it is near to the surgical area, and you are injecting the local anesthetic. Possibly if you want a preemptive analgesia and before surgical intervention, you are injecting near to the surgical area, which can possibly interfere with the surgical asepsis, and surgeon may not like it. But again, it is a good option to provide analgesia, definitely. Again, this is the pictorial documentation. You can see the classic and then lateral technique. And then definitely erectospinal plane block, which is possibly taking over most of the regional anesthesia technique, interfacial technique. So it is basically easier to perform than any other interfacial plane block. It has got definitely landmark. So what we have to do just to identify the transverse process, which is quite easily identified, hyperechoic structure, about 3 centimeters lateral to the mid spinal line. And then with that, you inject needle and then just touch the transverse process and inject local anesthesia there. So definitely landmark, very less chance of intrathecal injections or even pneumothorax. About a retrospective study, about 250 or 270 cases reported only one pneumothorax, so which is much safer compared to paravertible block, or less other than thoracolumbar interfacial plane block. Is no report of any other neurological complications here. It's provide extensive visceral coverage as well. It blocks both dorsal and ventral nerve. Gives good post-operative analgesia. So it has been well studied in spinal surgeries to provide better analgesia. So it has been seen that it reduces about 76% of post-operative opioid recurrence in a retrospective study. Sorry. So first described by Mauricio Ferrero. He used as for chronic pain relief, and then later on several randomized control trial was published showing benefit of it. So again, it has been used in a thoracic spine surgery, showing quite reduced opioid recurrence and length of stay in the hospital as well. So ultimately, surgery is a team effort, but this is not the entire team. The surgeon is not the entire team. You have to include several other staffs which combinedly work, like preoperative period, post-operative physiotherapy, rehabilitations, and looking after psychotherapy. So balancing this way is possibly the way to go, rather than thinking only the intraoperative period. Most dangerous phase is that we have always done in this way. We have to be more flexible, adaptive to different techniques, different newer ways. Possibly in future, more and more techniques will be coming to cover up this one. Thanks for giving me opportunity to present this lecture. I'll be happy to answer any questions.
Session. Thank you, Pradipta Bhakta sir. So we are already running short of time. Over to our chairperson for the question answer session, please. We can take 1 or 2 questions.
Yeah. Dr. Shobanna, you have a couple of questions in the chat box. One of them is from Dr. Anil Parikh, who's a senior consultant from Mumbai. That is about, he wants to know more about the opioid-soaked sponges for analgesia.
Thank you for that question. I personally do not have experience with that, and mostly quoted from some very few studies. The studies that I looked at were used 1 milligram of preservative-free morphine, and the study is actually almost a decade old or slightly less than a decade old. Recently, in 2018, there was another study which talked about epidural sponges soaked in levobupivacaine and dexamethasone, and they also showed lower doses for opioids or less opioid requirement in the post-operative period. And I think more studies need to be done, and it's difficult to sort of recommend this mode of multimodal analgesia. That's what I would say.
And another personal question, what do you think about the role of the intraoperative pain relief on persistent post-operative pain, which is very common in spinal surgeries? And also, what's your personal cocktail for multimodal anesthesia?
Well, as far as for the first question, I would say that the current trend is to minimize the use of opioids and not necessarily go opioid-free. So finding out, like in the last slide I showed, finding out the preoperative risk factors for persistent opioid utilization and trying to avoid them, and then categorize those patients who could be under higher risk, as well as minimizing opioid usage and trying to use all these alternative techniques, and thus providing sort of multimodal technique might reduce post-operative utilization. And I think this itself would be a nice topic for a study in the future. Personally, I have worked in 1 or 2 places, and each of our hospitals have their own ERAS protocols. And most of the time, it's a combination of preemptive analgesia with acetaminophen and NSAIDs. Gabapentin is nowadays being avoided. Intraoperatively, although we did lidocaine in the past, especially at the Cleveland Clinic where I worked for a few years, after that study came out, we've not been using lidocaine that much, and mostly ketamine infusions for the chronic pain patients alone. And then some people use dexmedetomidine and plus minus sufentanil as well. Post-operatively, at a Cleveland Clinic, I've used epidural analgesia, where we used to run a 0.0625% of bupivacaine with fentanyl, and that we found it to be pretty effective. This is in addition to other opioids and acetaminophen as required. I hope it answers your question.
Yeah, thank you, Dr. Shobanna. There are some more questions which Deepak has already answered in the chat box, but for those who do not have an access to the chat box, probably Deepak, could you please repeat your responses to these questions? One of them was about repeating the scalp block. And also the question from Dr. Anil is about whether gabapentinoids have a age-specific adverse effects.
Dr. Padmaja, yeah, I answered the questions already in the chat box. I was looking at the timeline and we were behind, so I thought I would just do that in the chat box. But yes, there seems to be an increased predisposition to the side effect of gabapentinoids with older age. And they can selectively be used in younger patients, particularly those who have chronic pain issues. with the advent of ERAS protocols, it seems that several institutions routinely use gabapentinoids, but our institution, we have actively discouraged routine use of gabapentinoids in patients undergoing most type of surgical procedures. And particularly for craniotomies, we do not prefer these agents. There is a significant concern with the risk of falls related to visual disturbances, dizziness, and ataxia in the post-operative period, which is highly undesirable in patients undergoing both craniotomies as well as spine surgical procedures. So we actually limit the use of those agents.
And I think personally, gabapentin, though initial enthusiasm came up as a multimodal analgesia, I think recent several studies have found in acute pain, its role is very limited. And especially even I'm talking about patient with existing pre-existing pain like hip arthritis or knee joint arthritis, the role of gabapentin or pregabalin is really disastrous, and it's not showing any benefit. Ultimately, it leads to increased sedation and problem. So, though component cocktail of multimodal analgesia combining with every alternative, including ketamine, clonidine, magnesium, magnesium definitely failed. Ketamine, debatable, not much benefit. Dexmedetomidine, possibly yes. Clonidine, definitely. Paracetamol, NSAIDs, obviously. I don't think so. Other agents are having, lidocaine definitely has got some, but leads to sedation again. Again, our choice should be to limit the opioid, not to take away the opioid completely. Opioid has got definite role in acute pain. We just cannot go out of the opioid, but our option should be to limit the opioid and not to the take away completely opioid. But I don't think so. Other gabapentin or pregabalin is not having much role in acute pain.
Yeah, I think there's one more interesting concern that Dr. Manish has expressed about sedation in prone position when you're doing spine surgeries with sole regional anesthesia.
Yes, it's always been a concern since it has been used. That's why I said selection of the patient in the regional anesthesia is a important thing. So those patients, non-cooperative patients, or patients will be causing problem, and definitely with the neurological disturbances will not be a suitable candidate for spinal anesthesia. Using sedation in a prone position always remains a airway issue. You have to be ready always to secure the airway if you need to. So in those cases, possibly LMA or even ILMA will be options, but that remains a always dodgy, debatable issue. And you have to be very sure which patients you are using, what amount of sedation you are using. So this is controversial, definitely, but there are several studies, several large-scale studies, randomized control trial proving safety of small anesthesia over the general anesthesia. So it has been coming more and more. The concerns will remain. I think selected patient with single level or double level lasting less than 2 hours will be the candidate for spinal anesthesia. Using sedation in prone position is an issue. But I think with the advancement of the airway gadgets nowadays, it should not be that problematic, which used to be 30 years ago.
Thank you, Dr. Pradipta. I think this session has evoked a lot of responses and comments from others, but we will not be able to take them for lack of time. Do we have time to discuss them?
Thanks to all our chairperson and speakers for such an excellent session. So if the chairperson allow me, can I please close the session, please?
Yes, I think we have discussed extensively, though the question we can take later on. Thank you all. Thank you, Deepak.
Thank
you, Pradipta.
Thank you all the speakers. Thanks.
Thank you.
Thank you very much.
So we will now move on to our next session, which will be SNACC panel session. So in this session, may I now first invite our first chairperson of this session, Dr. Kj Chaudhary, sir.
Thank you.
Sir, good morning. Very good morning, sir.
Good morning.
Dr. Kj Chaudhary, sir, he's a senior consultant in neuroanesthesiology and pain management at Indraprastha Apollo Hospital, New Delhi, and chairman of Samvedana Hospital, Noida. He has done his MBBS in the year 1970 and MD from Delhi University in the year 1975. He was consultant in the anesthesiology department at AIIMS Delhi in the year 1978. He was chairman of the Department of Neuroanesthesiology and Critical Care of VIMNANS, New Delhi in the year 1995. Sir is co-founder and past president of ISNACC. He is the recipient of first Distinguished Professional Award by ISNACC. So welcome you, sir.
Thank you. Thank you.
So our next chairperson is our very, very beloved Professor Dr. Amna Goshami, Madam. Madam has graduated from Medical College, Calcutta in the year 1966. She joined West Bengal Medical Education Service in the year 1971. She has done diploma in anesthesia from Calcutta University in 1974, and she has done MD anesthesia in 1979 from Calcutta University. She was posted as RMO cum clinical tutor in the Neuroanesthesia department at Bangur Institute of Neurology, Calcutta in the year 1980. She gradually promoted to professor and HOD of the department in the year 1988. She started pain clinic at the institute in the year 1983 after having gained some expertise from Dr. S.S. Saini at AIIMS New Delhi. Along with Dr. Bibhu Kalyani Das Madam, she made effort to upgrade the department to a state-of-the-art one. In this endeavor, they got the patronage and help from Professor R.N. Roy sir, HOD Neurosurgery, and Professor M.K. Bhattacharya sir, who is a neurosurgeon. After retirement from the health service, Madam joined Park Clinic as a consultant neuroanesthetist, where she is attached till date. So she is also a coordinator of PDCC in neuroanesthesia at Park Clinic, and Madam was our past president of our society. Madam, welcome, ma'am. So our next chairperson, may I introduce our next chairperson, Professor Dr. Sanjay Agarwal, sir. Sir is a professor and head at AIIMS Rishikesh. He is AHA certified and ACLS instructor and ATLS instructor as well. He has more than 65 publications in national and international journals, and he was speaker and invited faculty for various conferences. His area of interest is aneurysm clipping, intraoperative neuromonitoring, and airway management. Sir, good morning and welcome, sir.
Good morning and thank you.
Sir, first, I would like to request Dr. Kj Chaudhary, sir, to kindly introduce our first speaker, Dr. Shobanna Vikas, ma'am.
Good morning, everyone. I am actually enjoying the conference, the beautiful lectures, good subjects, and very, very good speakers. So it's my pleasure to introduce Dr. Shobanna Vikas. And she is a Neuroanesthesia Fellowship Director at University of California, Los Angeles. And she has completed her postdoctoral work at the University of California, San Francisco, where her research focused on the underlying mechanisms and risk factors of perioperative neurocognitive disorders. And yesterday, Dr. Lobo also mentioned about her work. Incorporating her bench work and the advent of new and emerging technologies, Dr. Vikas seems to improve patient outcome after surgery by blocking and alleviating perioperative exacerbated inflammation and brain lesions. She has received multiple research awards, including from the National Institute of Health. Her research studies focus on vulnerable surgical population using MRI technology, extensive cognitive assessment, and her work is published in Anesthesia, Analgesia, the Journal of American Medical Association. And she is reviewer of editorial member of several high-impact medical journals. Dr. Vikas also is the Neuroanesthesia Fellowship Program Director at the UCLA. And may I request her to speak on the subject of perioperative. She is going to speak on taking brain monitoring to the next level.
Hello, I'm Susanna Bhakta, and I'm an anesthesiologist at the University of California, Los Angeles, and an assistant professor at the David Geffen School of Medicine. Today, I'm going to discuss how we can leverage brain monitoring techniques to improve outcomes. I have no conflicts of interest to disclose in relation to this presentation. So, let's start with an overview of our planet. So the speed of our aging population is increasing, and in most parts of the world, survival beyond the age of 65 is improving. It is estimated that 16% of the world population is 65 years older, and that this number will double by 2060. Although people 65 years and older represent 16% of the population in the United States, they account for more than 40% of the surgical procedures performed each year. And although improving function and increasing duration of quality of life are fundamental goals of treating acute conditions, this population is at increased risk of perioperative complications. The number of post-operative complications also increases with advancing age. The most common complication after surgery is post-operative delirium, that is a type of perioperative cognitive disorder. So perioperative neurocognitive disorders, or PND, is an overarching term for the cognitive impairment or change that is identified in the perioperative period. So maintaining brain health after anesthesia and surgery is not only important to our patients, but is an increasingly important patient safety imperative for the specialty of anesthesiology. For those that suffer from perioperative neurocognitive disorders, whether we're talking about delirium, delayed cognitive recovery, or long-term cognitive decline, we know that these patients are at an increased risk of death at both the 3 months and at 1 year. There's an increase in the duration of hospitalization, 3 times the odds of being discharged to a skilled nursing facility, and of course, increase the risk of long-term cognitive impairment and leading to cognitive decline. And if you want to talk about costs, just in the United States alone, it is believed that post-operative delirium leads to an expenditure of over $164 billion per year, and this is just in the United States alone. So the risk of PND is determined by the existence of predisposing factors, that is the patient vulnerability, and also precipitating factors, the ones that are related to the presenting illness or that occurred during the hospital stay. Advanced age has been consistently identified as a major risk factor for development of PND. And so the total risk will depend on the number of risk factors in each individual and, where applicable, their severity. So several different factors are implicated in the etiology of delirium. It follows that also distinct mechanisms or combinations of mechanisms are involved in PND pathogenesis. And this is a review done in 2013 by Emery Brown, where he points out that there is a need to improve strategies for providing anesthesia care, especially in the elderly adult. And he points out that using the electroencephalogram, the EEG, to track the brain, it could be a practical starting point for designing principled neurophysiological-based strategies for reducing the adverse effects of anesthetics on the brains of older adults. There is a dramatic reduction of the amount of anesthesia that we need as we get older. So there are several EEG monitors in the market that can somehow guide our anesthetic plan. And we're going to go now over what's evidence behind this. This is one of our first studies. It was done in 2005 by Terry Monk and her group, where they did an observational study of almost over 1,000 patients, and they found that multi-comorbidities, the cumulative deep hypnotic time per hour, so they were monitoring these patients with BIS, in addition to the intraoperative systolic blood pressures of less than 80 per minute, these were all predictors of 1-year mortality. And this study stimulated a completely new era of anesthesia. This was followed by several observational studies. This study done in 2009, they found a statistical relationship between low BIS values and 1- and 2-year mortality. Kate Leslie and her group has done a tremendous amount of work in this area. They're in New Zealand. The Be Aware trial looked into 2,463 patients, and they saw that the absence of BIS values less than 40 for over 5 minutes was associated with an improved survival and reduced mortality. The Be Aware trial done in Washington University, they looked into 460 patients going under cardiac surgery, and they saw that the association between the cumulative time of low BIS values and mortality. They followed 1 year later. They did a sub-study of the Be Aware trial in 1,473 patients that were undergoing no cardiac surgery, but here they found no evidence that prolonged periods of low BIS decrease the intermediate term mortality. So there's now conflicting evidence. This trial of this observational study of 760 patients also show that there were no changes in mortality in cancer patients when they were on prolonged periods of birth suppression. Willingham and colleagues in 2014, they did a multivariate analysis that did not show an association between EEG suppression and mortality. But when this EEG suppression was coincident with hypotension, they were strongly associated with mortality. And so it followed several small randomized controlled trials. The lead trial, for example, was stopped early because of futility. They were looking into 3 items: the low dose dexamethasone, light anesthesia, or glucose control. The Charles Brown and team saw that in 114 patients, it was also randomized to light versus deep anesthesia, that their mortality rate was equivalent. But when they took into consideration comorbidities, then the light sedation group had a reduce in their mortality. Short and colleagues saw in 2014 in this RCT that there was a difference of 10% of death at 1 year post-surgery. So we're increasingly seeing that probably it's not just the EEG, and we have to start looking overall to what we are doing. So Sessler and his colleagues in the Cleveland Clinic developed the concept of triple O. They performed a retrospective review of almost 25,000 surgical cases, and they saw that the occurrence of low MAPS, mean arterial pressure, during low minimum alveolar concentration, which is this group here, was a strong and highly significant predictor for mortality. And then when they combined with low BIS, the mortality risk was even greater. Of course, this was followed by a review from Duke of over 1,600 patients where they found no association between the duration of the triple O state and mortality. I do want to point out that they were looking at a young population with a mean age of 53 years old. The Michael Avedon group, they also did this retrospective study of almost 14,000 patients from where they combined 3 clinical trials, and they saw that the longer the patient stayed in the triple O state, the higher were their 30 and the 90-day mortality rate. So these observational studies, of course, were then followed by several randomized controlled trials. But we're talking, so far, we've been talking about overall complications and mortality, but let's go now a little bit, what's the evidence behind brain protection? So the CODA trial was a randomized controlled trial of 921 patients that were aged 6 years old. And they saw that EEG-guided anesthesia reduced anesthetic exposure and decreased the risk of delirium and cognitive dysfunction at 3 months of surgery. For every 1,000 patients undergoing major surgery, the anesthetic delivery titrated to the EEG prevented 23 patients from having POCD, cognitive dysfunction and 83 patients from developing delirium. This is another study. This was corroborated the same findings. They found that the intraoperative neuromonitoring was associated with a lower incidence of delirium and possibly by reducing extreme low BIS values. So therefore, in high-risk patients, this may give the anesthesiologist a possibility to influence one precipitating factor in the complex genesis of delirium. I really like this study as they optimized the anesthesia to reduce post-operative cognitive decline. So the authors randomized 74 patients already of 75 years old. And not only did they look into the EEG, they also monitor several oxygen saturation. And so the results of this RCT indicate the potential benefits of intraoperative monitoring of anesthetic depth and cerebral oxygenation as a pragmatic intervention to reduce PND. This is the Avidan group had done previously an observational study where they saw that EEG suppression was an independent risk factor for postoperative delirium. So the same group 3 years later did a huge randomized controlled trial of 1,232 patients who were 69 years old. And they saw that EEG guided anesthetic administration did not decrease the incidence of postoperative delirium. So this study triggered a lot of conversations in the field, and it was almost showing at the no use of brain monitoring. But I wanted to point out that the authors, the study did show a decrease in mortality of 30 days after surgical procedure. So the questions still remain unanswered. Kate Leslie just published this end of last year, 2021, and they did the balanced study. So they randomized 515 patients, also over 60-year-old, to light versus deep general anesthesia. And what I like to highlight is that they did blood pressure targeting. They wanted to prevent blood pressure from being a confounding factor. So this was very important. So to understand exactly the contributing factors, and they saw a decrease in the incidence of delirium. So the authors conclude, and I like this conclusion, it is unlikely that deliberately targeting light general anesthesia alone leads to clinical important changes in patient outcomes. Further research should address whether there are vulnerable populations to deep anesthesia based on factors such as age, genetic, and comorbidities. So there are several randomized control trials in the literature that look at the impact of several oximetry and the development of perioperative neurocognitive disorders. So let's just summarize a little. So the implications of an electric silent brain during surgery are not yet fully understood. It may still prove that for most patients, this will have no implications. But until this is fully explored, it is important to consider brain monitoring as a physiological variable in vulnerable patients, such as the older adult. And for there to be a change in the outcome, the clinicians must incorporate information from all available monitors to optimize care for the individual patient. So patient assessment should include evaluation correlation of the EEG data with the cerebral oximetry data, hemodynamic data, and other monitoring data within the clinical context. So brain monitoring should be looked as additive to this patient assessment, and so can provide to clinicians with valuable signals for their practice, observation, and care. So thank you very much for your time. I do want to acknowledge the NIH for funding my research, and thank you very much. For any questions?
Thank you, Dr. Susanna Vakas, ma'am, for a wonderful session. May I now request Professor Dr. Amna Goshami, Madam, to introduce our next speaker, Dr. Valpuri Luoma, Madam, please.
Dr. Valpuri is a consultant neuroanesthetist at the National Hospital for Neurology and Neurosurgery, University College London Hospitals in the UK, where he is the program director for the Neuroanesthesia Fellowship Program. He is a director at large for SNACC. Clinical interests include perioperative medicine and anesthesia for neurovascular and complex spine surgery. Welcome, Dr. Valpuri, and I'm very sure that all of us will thoroughly enjoy your talk. Thank you so much for participating.
Good morning, and thank you for the invitation and opportunity to speak at ISNACC. I'm Valpuri Luoma. I'm a consultant neuroanesthetist based in London in the United Kingdom. So we're going to discuss a topic that I'm personally really interested in. It's the importance of measuring outcomes after neurosurgery. The main focus today is going to be on complications and patient-reported outcome measures. So our aim as clinicians is to provide effective evidence-based healthcare that doesn't cause harm and is of benefit to our patients. Patient safety is at the forefront of this. Avidis Donabedian described a systematic approach for analysing healthcare systems using quality measures, and monitoring outcomes is one of these. It's integral to us continuously improving the clinical care that we provide and ensuring a culture of safety. So outcomes include all effects that healthcare has on a patient, both positive and negative, and importantly, a proportion of negative outcomes, such as complications, are preventable and can be mitigated against. So neurosurgical surgery involves high-risk procedures, which can have a significant impact on the future quality of life of our patients, and this is often due to the nature and location of their pathology. So although some of our patients may have fewer comorbidities when we compare them to those in the higher risk general surgical population, with an aging and increasing global population, along with recent innovations in neurosurgical treatment options and perioperative neuroscience, the number of patients who present for neurosurgery is going to increase. Safety and improving outcomes is a key element of our multidisciplinary practice, and currently there are few validated tools within our subspecialty for an ideal outcome measure or quality indicator. We need to ensure that we're meeting the needs of our patients and that we can mitigate against negative outcomes and experience. These can have a few impact on future quality of life and increase healthcare costs. So our first step is to quantify the neurosurgical morbidity. So the published incidence of complications is somewhere around 10% for all neurosurgical procedures, but clearly this varies globally and within the different neurosurgical subspecialties. So in this study, Rock et al. Investigated a 10-year neurosurgical patient cohort from the American College of Surgeons Quality Improvement Program database. They found that the incidence of complications was just over 13%, with the overall mortality around 2% for all patients. The complication rate was significantly higher after cranial surgery at around 20%, and these patients also had a 2.73 times higher likelihood of mortality. In this study, they used the dataset that was defined by the American College of Surgeons Quality Improvement Program for complications. In other studies, the results are similar, but we need to be aware that there's a multitude of different definitions for a post-operative complication, and this can be anything from a validated scale to composite outcomes. In addition, the morbidity or a complication that we as clinicians might consider to be minor may have a significant impact on patient recovery, and we can easily miss these. Valid comparisons of the incidence of morbidity or complications between the different studies is also challenging without standardization or risk assessment. So in addition to quantifying the risk, we need to understand the impact. So in this study, Munising et al. Demonstrated that postoperative morbidity impacts on long-term survival. They conducted an observational study of over 1,000 patients who are undergoing elective, non-cardiac, non-neurological surgery, and they measured the relationship between perioperative risk, inpatient postoperative morbidity, and long-term survival at a university hospital in the UK. They measured postoperative morbidity using the Post-Operative Morbidity Survey. They found in this study that prolonged post-operative morbidity of any etiology was independently associated with the risk of death for up to 3 years after surgery. And in particular, the occurrence of neurological morbidity was associated with long-term mortality. So this is clearly a significant impact for our patients. Their results are in keeping with other studies. Curry et al. Investigated outcome in 8 common surgical procedures, and they used, again, the American College of Surgeons Quality Improvement Program database. Their results were similar. They also found that the most important determinant of decreased post-operative survival was the occurrence of complications within 30 days of surgery, and this was independent of preoperative risk. Supporting these findings from non-neurological surgery, we know from our own practice and experience that neurological complications have a significant impact. So in this landmark study by Taylor et al., the incidence of post-operative hematoma that required surgery after craniotomy was just over 2%. The thing to note is that 1/3 of these patients had a poor functional outcome and nearly 1 in 5 died. We can mitigate against some of this risk with careful cardiovascular control. So all these studies demonstrate the long-term impact of surgical morbidity on our patients, their families and society, and they highlight how important high-quality care is. A proportion of these adverse events are preventable, and as clinicians, we can mitigate against the risk. To be able to do this, we need to have valid outcomes data and to act on it. So, an outcome measure defines the quality of care we provide and measures the effectiveness of an intervention. They can be simply divided into traditional or more objective outcome measures, such as complications, length of stay, or mortality, or patient-centered subjective measures, such as patient-reported outcomes. Ideally, anything that we do measure should be patient-centered or focused. So the data that we generate can be used for a variety of different things. We know how frequently outcomes are used in research, and the results are used to develop our evidence base for clinical care. We can use it for benchmarking between clinicians and institutions. In many countries, surgical registers exist and outcomes may be published. More locally or in our own clinical practice, we can use the data for service improvement using quality improvement methodology or clinical audit. The tools that are available are heterogeneous, as we've already discussed. It does mean that meaningful comparisons can be challenging without risk assessment, and globally, we know that our patient cohorts are very diverse. We expect that the majority of our patients are going to recover well, but we do need to be able to predict those who won't and to have the opportunity to discuss these risks with them and to mitigate against them. So, what are options for measuring outcomes? So the patient's neurological or neurosurgical journey starts when a decision is made to proceed with surgery and may end when their treatment is complete. Although, as we already know, the impact of the healthcare that they receive can last much longer. So we can measure outcomes at any point along this pathway, and it can include logistical, experiential, and events. So examples include mortality or length of stay, hospital readmission, and more recently, a development of core outcome data sets. So looking at mortality, it's not necessarily a true reflection of quality, although it's frequently measured. The risk of mortality is relatively low. We know it's around 2% if you look at all neurosurgical procedures, and it's therefore not necessarily a true reflection of quality. Similarly, length of stay, although it may be useful and is measured frequently, it should be taken in context, and it's not necessarily, again, a good reflection of quality when used in isolation. So, for example, patients may be at home before a complication occurs. This can result in an unplanned admission and a resultant increase in healthcare costs, along with the impact on our patient. Unplanned ICU admissions provide a measure of failure to rescue and can be used as a quality indicator. A thing of importance is that for all data, the time of collection is key to avoid missing information. So 30 days after surgery correlates with preoperative risk factors, complications and readmissions, and it may be unnecessary to collect data beyond this. We do use 30-day readmissions or reoperation and number of days alive at home up to 30 days after surgery. There's a huge number of different methods used to document complications. The definitions are varied, as is the reporting, and is really demonstrated by this systematic review on outcomes after spine surgery. As we've mentioned many times, it makes meaningful comparisons difficult. So one option is to use the Clavien-Dindo scale. This is a validated and reproducible method of recording complications. It's used in a large number of surgical specialties, and it was developed to standardize and allow meaningful comparison. The grading is based on the type of therapy that's required to correct a complication, and essentially it records any deviation from the normal post-operative course. It's recently been validated for use after neurosurgery. Sebok et al. Studied 156 patients undergoing microvascular treatment for unruptured intracranial aneurysms and demonstrated a significant correlation between the presence of Clavien-Dindo complications and neurological outcome, and it was also associated with a longer length of stay. In this study, adverse outcomes occurred in just over 13% of patients, and of note, in 10% of patients, they persisted to the 3-month follow-up. Although Clavien-Dindo grading is a commonly used tool, interestingly in the systematic review, it was only used in 2% of studies. So another option that we have is to record post-operative morbidity, which can be measured using the Post-Operative Morbidity Survey. This is an 18-item, 9-domain scale measuring morbidity during hospitalization that requires inpatient care and can impact on patient experience. The presence of morbidity correlates with length of hospital stay. So Grocott et al. Validated the tool in the general surgical population. It's since been adapted for use in other surgical settings, including neurosurgery. Most recently, an adaptation was used to measure patient outcomes after surgery for chronic subdural hematoma. The thing to note is the neurosurgical outcomes may differ from other subspecialties, and POMs may not identify all morbidity, for example, dysnotremias or the occurrence of new seizures. There is, however, still an association with an increased length of stay. There are few neurosurgery-specific models that are available for reporting complications. Ibanez et al. Developed a tool that's similar to the Clavien-Dindo grading, and there are some publications on tools which have been developed for morbidity and mortality conferences. To facilitate meaningful comparisons and improve development of our evidence base, there's now a move to develop consensus-based, agreed, standardized outcome measures and data sets or core outcome measures. So, core outcome measures are an agreed, standardized set of outcomes that should be measured and reported as minimum in all clinical studies and trials in a specific area of health or healthcare. So they can improve the quality of studies that are conducted, the subsequent guideline development, systematic reviews, meta-analyses. Within neurosurgery, they're currently in use in stroke, some spine surgical procedures, and traumatic brain injury. So the core outcomes measures index for low back disorders has been used globally and translated into many different languages, and is one that is used in spine surgery. There's also currently a core outcome measure set being developed for patients who are with chronic subdural hematoma. Within perioperative medicine, core outcome measures being developed using a Delphi method, and this includes all different areas such as patient-centered outcomes. The final core set was published recently by the Compact Group, and the recommended framework includes everything from mortality and long-term survival to both short-term and long-term recovery. So although this data set isn't specific to neurosurgery, it is equally applicable to us, and it provides an important framework which we can use to guide local data collection or plan future studies on clinical care. So in addition to understanding adverse events, we also need to understand what matters to our patients, their reported outcomes and experiences to provide high quality care. So patient-reported outcome measures, or PROMs, are designed to measure outcomes reported by our patients. They provide a more holistic view on the effects of illness or surgery. They evaluate healthcare outcomes, satisfaction, and quality of life. They've been used routinely in many areas of surgery over the last few years, for example, after joint replacement. The evidence suggests that the data results in better communication and decision-making and improved patient satisfaction. So a PROM can be generic or disease-specific, and it covers a variety of dimensions, such as functional status, quality of life. The compact group have recommended 3 for outcomes after in perioperative medicine. These are the Euroqual EQ-5D, the World Health Organization Disability Scale version 2, and a measure of days at home. So days at home 30 essentially measures the number of days a patient spends at home within 30 days of surgery. It's an outcome that's of importance to our patients, and it also independently correlates with long-term survival after surgery. Both EQ-5D and the World Health Organization Disability Scale are available in many different languages, and they're designed for use globally and in different cultural settings. The EQ-5D measures health-related quality of life using a 5-item metric and a visual analog scale. And the World Health Organization Disability Scale measures functional status within the last 30 days using a 36-item tool that covers 6 domains. They are both usually self-administered, but importantly for neurosurgery, they've been validated for completion by a carer on behalf of the patient. So although there's a large number of different PROMs that are in use, there are few available that are neurosurgery specific, and this is nicely highlighted in this systematic review. The majority of PROMs that have been validated have been in spine surgery, although there have been a few for brain injury and after cranial surgery. And importantly, both EQ-5D and the World Health Organization Disability Scale have been used in our patient cohorts. So Reponen et al. Conducted a study looking at PROMs in elective cranial surgery, and they found them to be a sensitive and specific indicator of in-hospital morbidity, and their findings are supported by other studies where a PROM may be a sensitive at identifying new neurological deficits. Due to the cognitive and functional impairment that may come with the pathology our patients experience, neurosurgery does present a challenge. Some PROMs instruments may be misleading as they're not validated for completion by a carer, and we need to take this into consideration when choosing how we are going to measure these outcomes. So another PROM that we can use is quality of recovery, and this is usually used in the immediate post-operative period to measure health status and outcome after surgery and anaesthesia. There are a variety of tools in existence, but the most extensively used and validated are the Quality of Recovery 40 and 15 scales, or the 9-item Quality of Recovery score. They're all patient-centered and contain a variety of items that gives a holistic perspective. From the neurosurgical perspective, the Quality of Recovery 40 has been used for both cranial and spine surgery. In this study, Leslie et al. Demonstrated its responsiveness, reliability, and validity in an elective neurosurgical patient cohort. They found that a longer duration of surgery, complications, and higher pain scores were associated with worse quality of recovery, and neurological deficits negatively correlated with Quality of Recovery 40 scores. A significant proportion of their patients required assistance with completion of the survey, possibly a reflection of their pathology. And importantly, the Quality of Recovery 40 score has been validated for investigator administration for patients, which is particularly relevant for us. So the thing to consider is, whilst we've got methods to collect the data, what can we do with it? So we know that outcomes are frequently used to determine, or outcomes are used to determine endpoints for research, and which is then used to develop our evidence base for care. There are a few standardized measures in neurosurgery, and given the evolving research and technology within neurosurgery, there's now a move to develop standardized outcome sets. So on a more local level, and something that I'm particularly interested in, the data can be used to drive local change and improvement using quality improvement methodology or improvement science. So for example, the use of blood products or infection are both common or more common complications after neurosurgery. We can review the adherence to infection prevention guidelines or patient blood management guidelines and identify areas to improve. Often a simple change has a significant impact. By way of example, my colleagues conducted a quality improvement project to improve the care that we provide patients with normal pressure hydrocephalus. These patients are often older, frailer, with multiple comorbidities and may have unique healthcare needs. The team used the Post-Operative Morbidity survey to measure the incidence and type of complications. Post-operative mobility and functional status was found to require some additional support, and in collaboration with our specialist occupational therapy and physiotherapy teams, they developed a dedicated pathway for our patients, resulting in safer discharge home. Another example is this project from the USA. They used quality improvement methodology to reduce the incidence of post-operative infection from close to 7% to less than 1%. So, in summary, we as clinicians aim to deliver safe, effective, and value-based healthcare. We need to meet the needs of our patients. We know that neurological surgery carries a higher risk of morbidity. This can result in worse outcomes longer term and may have a continued mortality risk after hospital discharge. So to facilitate continuous improvement of the clinical care that we provide and to develop our subspecialty, we should measure outcomes, ideally those that are standardized and focused on a patient-centered approach. Finally, thank you for listening and again for the opportunity to speak at ISNACC. It's been a privilege for me.
Thank you so much, ma'am, for a wonderful talk. So we'll be taking the question at the end of the session, and all the attendees are requested, they can put their question in the chat box. So may I now request Professor Dr. Sanjay Agarwal, sir, to introduce our last speaker of this session, Dr. Amy, ma'am, please.
Good morning. And it is my privilege to now introduce Dr. Amy Hoffnegle. She is an associate professor of anesthesiology at University of Florida. She is a medical director of quality improvement and patient safety, medical director for neuroanesthesia, associate residency program director. She is a member of SNACC educational committee and as well as a member of SNACC scientific affairs committee. And Dr. Amy will be talking about on managing crisis in neuroanesthesia, the role of cognitive aids. Dr. Amy, please.
Hi, good morning. I'm Dr. Amy Hoffnegle, and today I'm going to be talking about managing crises in neuroanesthesia and the role of cognitive aids. Think back, when was the last time that you had a patient with a venous air embolism? How about a patient that had a seizure during a craniotomy? Given the rarity and severity of these events, many clinicians would have difficulty following through on all of the appropriate steps during the crisis. Today, we're going to explore how the checklist has evolved in healthcare, specifically within the realm of the operating room. So to start, what is a cognitive aid? So quite simply, a cognitive aid can be defined as any external representation that supports cognitive processes demanded by a task. In healthcare, these include things like checklists, emergency manuals, alarms, reminders like hand hygiene wall posters, and mnemonics, such as Miss Maids, which you may have learned back when you learned how to set up an OR. Many of us do follow cognitive aids in our daily clinical practice. For example, how many of you can recite your institution's timeout flow by memory? This is the most frequent cognitive aid we as anesthesiologists use daily. We use this to fit patient information into a structured pattern to ensure that all team members have a shared understanding and complete essential tasks such as antibiotic dosing. More complex cognitive aids allow clinicians of different practice levels to approach unfamiliar clinical situations in a structured framework. These may be a step-by-step read-do list for a new resident, or for the advanced practitioner, they may serve as a double check to ensure that all contingencies have been addressed. For all of us, they help prompt us to complete all of the tasks in the setting of distractions that are present in an emergency. The concept of using reference material during emergencies is a century old and was perhaps first described by Dr. Babcock, a surgeon with a strong interest in resuscitation, back in 1924. In his paper, he addressed the fundamental concepts of an emergency checklist, and he recommended that fixed emergency routines be posted on the operating room walls and demanded training on these routines for all staff. Checklists for routine operations are typically meant to provide us with a standard baseline and serve as a memory aid for complex or lengthy sequences of steps, even if we perform these regularly. A good example for us as anesthesiologists is the FDA machine checkout that was approved in 1993 as the complexity of our anesthesia machines grew. Many of us will have been following this checklist, perhaps without even realizing it. Additionally, Provost et al. In 2006 introduced a simple checklist for providers while placing central lines. This was done in 109 ICUs in Michigan in the United States, and he demonstrated a sustained near elimination of central line reductions when adhering to this checklist. Finally, one of the largest studies on checklist use can be seen with the WHO Safe Surgery Checklist Study. In this study, they detailed the results of a pilot with nearly 8,000 patients, from patients in hospitals in both rural and urban settings across 8 countries with differing levels of income. Impressively, after successfully implementing this team-based checklist, post-operative mortality was reduced by 47%, and post-operative complications fell by 36%. Now, when looking at emergency checklists, these are designed for use in non-routine situations. During a clinical event in the OR, the anesthesiologist must remember many detailed steps. We must take immediate action just when our stress level is at its highest, distractions are at their greatest, and our ability to recall information may be diminished. The necessary knowledge may be in your brain, but it does become a challenge to retrieve unless you have significant experience with that exact crisis. Now, it's almost impossible to give a talk on the use of cognitive aids and checklists without comparing medicine to the aviation world. And in real time, for my fellow space nerds, we've just been following the commissioning and launch of the James Webb Telescope. It's been fascinating for me to watch as they're commissioning and hear them and see them use these checklists in real life. Not unexpectedly, NASA has a very strong interest in behavioral psychology, and they published numerous studies in this field. In 2004, Mark Stahl published a 176-page review of literature addressing the effects of various stressors on our cognition. The study examines the relationship between cognitive appraisal, attention, memory, and stress related to information processing on human performance. Not surprisingly, he found that a negative impact on memory and attention when individuals were under stress. In 2001, Atal Gawande's The Checklist Manifesto provided the global introduction of the Safe Surgery Checklist. While this is perhaps the highest profile cognitive aid in healthcare, there were several other notable publications in this same year, namely the Anesthetic Crisis Manual, soon followed by the Stanford Emergency Manual, and the Harvard Operating Room Emergency Checklists. With the introduction of these checklists into practice, we began to see literature reporting on their efficacy in practice. In 2013, an extensive study was published in the New England Journal of Medicine by Aragon et al., and it examined the utility of surgical crisis checklists in OR team-based simulations. The study population included 17 teams, and these teams were comprised of anesthesia staff, OR nurses, surgery techs, and a mix of real and mock surgeons. And what they found was that the use of these checklists during the simulated crises resulted in nearly a 75% reduction in failure to complete critical management steps. When the checklists were not used, there was a 23% rate of missed critical steps. With the use of the checklist, they decreased this to 6%. And interestingly, 97% of the participants afterwards said that they would like to have the aides present in the operating rooms so that they could refer to them in the event of a real emergency. Another simulation-based study examined anesthesia trainee performance during a simulated episode of local anesthetic systemic toxicity. So Neil and colleagues took 25 anesthesia residents and fellows and put them through simulated last scenarios. Individuals were randomized to either have the ASRA last checklist or to not have a checklist. all of the group was rated on 7 preemptive and pre-diagnosis parameters before they were randomized for the checklist. And after randomization, they were evaluated on 21 management and treatment parameters. What they found was that there was no difference between the group's performance pre-randomization. So when nobody had the checklist, everybody performed the same. But individuals with the checklist performed an average of 16 of 21 tasks appropriately, compared to only 8.8 of the 21 tasks when they didn't have the checklist. Also surprisingly, those that were in the checklist group demonstrated significantly better knowledge retention at 2 months post-scenario. So what do we know about the best design for emergency cognitive aids? Well, they must be specific to the problem at hand, be clear on treatment goals, be concise, and most notably, they need to have a consistent format so that providers quickly know where to look for the specific information. So in this example, you can see that each event has a brief description of the emergency, followed by stabilization steps, drugs to give, and treatment options. At the end are common causes and a differential diagnosis. So note that each section is under a color-coded heading, which is consistent throughout the manual. This standard format facilitates what we call sampling, which many of us use when we're using a cognitive aid. For example, you may be reasonably sure of the initial stabilization and treatment plan, but you're unable to remember the exact dosage of a medication. This format allows you to quickly find the information that you're looking at. You don't have to be able to read all of the text in order to provide immediate treatment. And if initial treatment fails, you're able to explore different information, focus your treatment, and explore your differential diagnosis. So hopefully I've now convinced you that cognitive aids have a place in your OR during emergency management of patients. But how and when should you be using them? So emergency manual use can broadly be divided into 3 categories: before, during, and after a critical event. Most frequently in clinical practice, they are used before critical events, with the occasional use during or after the event. And it has been shown that the use of cognitive aids when used before and after a critical event significantly increase their effectiveness during future events. So practice makes perfect. Now, we typically use our emergency manuals for rare and refractory events. For rare events, such as a seizure during a craniotomy, a cognitive aid reminds us about important details, such as specific medication doses and crucial priorities. However, when we have a refractory event, such as when a patient is not improving despite treatment, we can use these cognitive aids to further delineate our practice. Take, for example, something that you may see not infrequently in your operating room, like the loss of evoked potential monitoring. Very quickly perform the usual steps. But if the signals aren't improving despite these best efforts, you now have a failure to respond. And this should trigger both calling for additional help and using a cognitive aid. And once extra help has arrived, it's recommended to assign one person to read the cognitive aid to assist the leader, which can dramatically influence the delivery of best practices to patients during crisis. Emergency manuals can also serve as an excellent teaching tool, or as a use for a debrief tool after event. I like to use them while having a resident talk through a what-if scenario with me in the operating room. Typically, I do this in our more routine cases. I'll be like, okay, so what would you do now if the patient became suddenly hypotensive and hyper and lost end-tidal CO2? And then we pull out the mnemonic and we talk through what we would do. Alternatively, it's good to review them prior to the start of your case. For example, if you're preparing for a large spine fusion and you think that there could be significant blood loss, a quick review of the cognitive aid can ensure that you are ready to manage the event if and when it should arrive. Despite data showing that we improve responses in critical situations by using cognitive aids, getting us as clinicians to use these emergency manuals when needed can be very difficult. And we do know that simply making and distributing these emergency manuals is not enough to actually improve patient safety outcomes. So, what are some of the barriers that make clinicians not use the emergency cognitive aids? The problems often reported include poor design, inadequate introduction and training, duplication of other safety checks, poor integration with existing workflow, and cultural barriers. We know that each medical setting has its own culture and workflow, and our emergency guides must be tailored to fit these needs. In 2018, Puri et al. In a study proposed the following framework for the checklist life cycle, starting with conception. And with the conception, you need to take into account your operating situation. You then determine the content and design, then do testing validation, introduction, training, and implementation, and then ongoing evaluation, revision, and possible retirement of the cognitive aid if it is not meeting the group's goals. Once you as a group have decided which cognitive aids best suit your practice and have tailored them to be institution specific, you are now faced with how to best get your group to use them in practice. The first step is to introduce them and allow ample time for questions and feedback. The second, more complex, is to get people to buy into the use of the aids. In order to get buy-in, you need to get people to train with the cognitive aids. So simulation studies and literature from other high-stakes industries have underscored that any helpful resource is only beneficial during emergencies if it's already familiar to you as a clinician. Without prior training of it or exposure, clinicians do not think to use it, and they may actually push it aside without even seeing it. And helpers are much less efficient in finding information. This phenomenon is known as inattentional bias. In 2015, a publication from Kohlhaber Fiber showed that when teams were trained in the simulator for even just 15 minutes regarding why and how to use cognitive aids effectively, both use and correct management actions increased significantly. A brief familiarization with the concepts and format of the cognitive aids made all of the difference, and clinicians then enthusiastically asked to make this training more widely available. So not all of us have access to simulation. A different way to introduce this might be in departmental meetings or at grand round M&M reviews, where you examine the situation that happened and then go through the tool about what steps could have been taken and how the cognitive aid could have improved your management. There are currently 2 crisis manuals that are specific for neurosurgical emergency management. The 2018 Neuroanesthesia Crisis Management Manual is a booklet of 17 cognitive aids relevant to neuroanesthetic emergencies. The 2019 SNACC guidelines are presented as a review article detailing the literature used for each aid, and the aids themselves are available for download, printing, and distribution. And I've included the QR codes to the download for both presentations here. In conclusion, embracing the use of these tools often represents a cultural change, accepting that cognitive aids may serve many roles in increasing our response to critical situations, and that our reliance on memory alone can lead to lapses in patient care. In order to do this successfully, we must undertake team training to review the emergency protocols, improve our communication, and familiarize clinicians with checklists. These are a powerful tool to enhance survival from OR critical events. I thank you for your time. I sincerely wish that we could have all been together live so I could get to see some of your beautiful country. But thank you again for having me, and I will take questions at the end with the panel.
Thank you so much, ma'am, for a wonderful talk. So we are already running short of time. So may I request our chairperson to take over for a few question and answer session, please.
I would like to put a question to Dr. Valpuri. That is, are the cognitive dysfunctions directly proportional to the age of the patient, irrespective of the nature and duration of the surgery? And what is the reaction of the patient and their relatives when they are made cognizant about them before the surgery? This is something which is becoming a foxing problem.
I'm sorry, could you just repeat the beginning of the question because I just missed it? I'm sorry.
Is it directly, are these changes in the cognitive function directly proportional to the age, whatever the surgery may be, whatever the duration of surgery? The older the patient, are they having more cognitive dysfunction?
from our experience, we've had some, we noticed in the older patients that we definitely get an increased incidence of delirium after surgical procedures, particularly, for example, in cohorts of patients such as those with normal pressure hydrocephalus. I think Dr. Vakas could also answer some of this aspect from her experience.
Also, is there any difference in the incidence of delirium in both surgical, neurosurgical and non-neurosurgical patients? There was a slide, but I am not still clear whether the prevalence is same in both neurosurgical and non-neurosurgical patient, or handling a brain doesn't make a difference.
So I'll try to answer these questions. So regarding the difference between neurosurgical, neurosurgery and non-neurosurgical procedures is there are no convincing studies that shows that are looking at the incidence of delirium and post-operative cognitive dysfunction. And this is due to the confounding factors of a direct insult of the surgery in the brain. So there is almost no way of distinguishing if it's the surgery itself or the lesion that led to the surgery that is causing this new cognitive dysfunction, or that has somehow disrupted any of the synapses in the brain. So it is in most studies, I would like to say 99% of the studies are in non-neurosurgical procedures because of this confounding factors. There is a difference, very big differences in the studies is cardiac versus non-cardiac. Regarding neurosurgery, the only studies that normally are looked are the ones that are done into the spine procedures. And this comes a little bit, there's a question that talks about.
Now, let me just continue with this one. Thank you.
I hope I answered.
Yes, yes. And the other thing is I discourage neurosurgeons not to ask for too much of low blood pressure. And we sometimes give them wrong answer. Oh, okay, the blood pressure is so-and-so. So it is very difficult to change the attitude of old neurosurgeons. And because a lot of literature says that the blood pressure, if it is low for a time, then the cognitive dysfunction even can start after a few weeks also. So I discourage neurosurgeons to not to ask for too much low blood pressure than allowed. Thank you.
Yeah.
Sir,
Yeah, that's the theory behind the triple O, to avoid triple O. Although, as I showed, there were some studies that have shown that triple O made no difference whatsoever, but there were some convincing studies that seemed that blood pressure does have an impact. And I think we have to stop looking at things as it's this or it's that, it's A or B. I think we have to look at our patients as a whole. There will be patients that are very susceptible to very low blood pressure, and most likely patients that are going a neurosurgical procedure will be put in the vulnerable population.
Right. Thank you. If there is no more questions, can we close
I
this?
think there are 2 or 3 questions are there in the chat box.
It can be answered in the chat box itself, so that you are not.
Okay, okay, sir. If you allow me, can I please close this session, please?
Yes, please.
Okay. Thank you so much. Thanks to all our chairperson and speaker for such a wonderful session. So I'm concluding this. All the attendees are requested to visit our stall, please. So now we are going to start our next session, which is Professor Malathi oration session. So in this session, may I welcome our first chairperson, Professor Dr. G.S. Uma Maheshwara Rao, sir, please. Sir, good morning.
Morning.
Welcome, sir. Sir was head of the Department of Neuroanesthesia at Nemours. He was Dean of Clinical Neurosciences at Nemours. He received B.C. Roy Award for the best medical teacher. He has about 140 international and 40 national publications to his credit. and he has given lecture to about 200 lectures in various national and regional platforms. He has also participated in the development of an indigenous critical care ventilator, that is Nmda. Sir, welcome. So may I now welcome our next chairperson, Professor Dr. M. Radhakrishnan, sir, please. Sir, good afternoon, sir.
Good afternoon.
So, sir is currently professor and HOD of the Department of Neuroanesthesia and Neurocritical Care at NIMHANS, Bengaluru. So he has got around 19 years of clinical experience. He was past treasurer of our society. His interest is neuro-intensive care and neuro monitoring. He has got around 45 publications in various peer-reviewed journals. Welcome you, sir. And may I now welcome our third chairperson for this session, Professor Dr. K.R. Madhusudan Reddy, sir. Sir was professor of neuroanesthesia and neurocritical care and former HOD of the Department of Neuroanesthesia and Neurocritical Care, NIMHANS, Bengaluru. He has got around 27 years experience in neuroanesthesia and neurocritical care field. He has got various national and international publication and presentations. He was former member of Ethics Committee, Clinical Neurosciences at NIMHANS and Departmental Scientific Committee Chairman, and he was reviewer in JNAC also. Welcome you, sir. So may I now request Professor G.S. Uma Maheshwara, sir, please, to say a few words about Professor Dr. Sundar Malathi, ma'am.
This is the 19th Malathi Memorial oration that we are conducting in the SNACC conference. The Department of Neuroanesthesia and Neurocritical Care at NIMHANS owes its existence to Dr. Malathi. Dr. Malathi was a full-time neuroanesthetist appointed in 1963. She had she laid foundation for modern neuroanesthetic practice as early as 1963 itself. For the first 10 years, she worked alone day and night, attending to the elective and emergency neurosurgical cases, and regular neuroanesthetist posts were created only in mid-70s. She created neurocritical care unit at NIMHANS as early as late 1970s. The unit looked after not only neurosurgical patients, but neuromedical patients with, who required intensive care, such as GB syndrome, myasthenia gravis, status epilepticus. As early as 1970s, she equipped the department with state-of-the-art equipment like Siemens ventilator, Youngstown ventilator, Becton-Dickinson monitors, Lacetone, precordial Doppler, blood gas analyzer. All these, imagine, in 1970s, she equipped the department. A stickler to discipline, she carried out the department in a perfect manner. Her commitment to the patient's safety is unmatched. After a relentless service to neuro patients, she took voluntary retirement in 1983. After spending a couple of years in Middle East, she returned to India. She reached her heavenly abode in 2003. NIMHANS is forever grateful to her human services. We respect Dr. Malathi. We remember her on this occasion.
Thank you, sir. Thank you so much, sir. May I now request Professor Dr. Radhakrishnan, sir, to please introduce our speaker, Dr. J. Chaudhary Hemphill, sir, please.
It's a great honor and pride for me to invite Dr. Claude Hemphill on behalf of NIMHANS and the ISNACC Society to deliver today's Malathi Memorial Oration. Dr. Hemphill is a Chief of Neurology and Director of Neurocritical Care at San Francisco General Hospital. His research focuses on advanced neuromonitoring, informatics, and management of intracerebral hemorrhage. He is a founding director and past president of the Neurocritical Care Society and is a member of the editorial board of Neurocritical Care. His work has been funded by the National Institutes of Health to study intracerebral hemorrhage and to conduct clinical trials for various neuroemergencies such as traumatic brain injury, status epilepticus, and stroke. He is the co-chair of the Neurocritical Care Research Network and the Curing Coma campaign of the Neurocritical Care Society.
Now I invite Dr. Hemphill to deliver the oration.
Intensivist at the University of California, San Francisco. And I'm deeply honored to have been invited to provide the Malathi oration at this year's ISNACC meeting. My topic is optimizing outcomes for patients with intracerebral hemorrhage, a journey in progress. And whenever we think about our own professional journeys, it's very important to recognize our mentors. This is a photograph provided to me by Dr. Indranil Ghosh of Dr. Malathi from 1983. And she is clearly an important mentor for neuroanesthesia. And this wonderful quote, "There is something exciting about neuroanesthesia. Once you're in it, you are there forever." And so I wanted to take a moment to recognize my mentor, Dr. Daryl Gress, who's currently at the University of Nebraska in the United States, but trained me in neurocritical care at the University of California, San Francisco. And a couple of quotes that have always stuck with me from Dr. Gress are, "Doing nothing is doing something," which really means if we choose not to implement the therapy, especially in a challenging situation where we have limited evidence for or against that therapy, we need to really be justified that by withholding that or not doing that, we're doing the right thing. And then be ubiquitous and you become indispensable. Be present, be valuable, and you'll make a difference. So my journey in intracerebral hemorrhage begins back when acute stroke treatment was starting to become available. And this was a very exciting time. And I was a junior faculty member at the University of California, San Francisco and San Francisco General Hospital. And there was so much excitement about TPA, tissue plasminogen activator for acute ischemic stroke, because we hadn't treated very many patients and the data had just come out and the US FDA had just approved this as available for therapy. And I remember a case early on when I was at San Francisco General Hospital, and a patient came in within about 2 hours of onset of stroke, and they clearly had stroke symptoms, and they were in the emergency department. And I said, "We've got to get this patient to the CAT scanner because I think we may be able to deliver treatment if this is an ischemic stroke." So about 20 people gathered around because they hadn't really seen this before. There were nurses, there were doctors, and everybody helped to get this patient to the CAT scanner. And then when we got in the CAT scanner, we placed him in the CT scanner, and the CT tech started the study, and we were all very excited. And the scanners at that time were pretty slow, and you saw one slice come up at a time, and everybody was really interested because they wanted to deliver acute stroke treatment, and they believed in it. And so I remember watching this, never forget, as the CAT scan slice came up, and the white was present, showing that this was an intracerebral hemorrhage, not an ischemic stroke. And the entire room let out a, kind of a sigh. And I looked down, and I looked back up after about 2 or 3 seconds, and everybody was gone, except for the patient, the CT technologist running the CAT scanner, and me. And I thought, what's going on here? Everybody was all in and interested in treating my patient. And then when they saw it as an intracerebral hemorrhage, they all left. And I recognized that my patient still needed treatment. But this was an opportunity because people weren't paying attention to intracerebral hemorrhage. Now, when we talk about intracerebral hemorrhage or ICH, we know it's about 10 to 15% of all strokes, but has a disproportionately high risk of death or disability. And there are many different causes of intracerebral hemorrhage, and sometimes people get very interested and excited about vascular malformations, which are secondary causes, but really we need to focus on hypertension as the most common cause. And here we're talking about spontaneous intracerebral hemorrhage, not traumatic intracerebral hemorrhage or hemorrhagic conversion of an ischemic stroke. Cerebral amyloid angiopathy, use of anticoagulant medications are both relatively common causes, but really let's focus on high blood pressure. And the reason this is important is even if you work in the operating theater or the emergency department or the critical care unit, we've got to make sure the message is out there for our patients that we've got to prevent this from happening in the first place or prevent it from happening again. So long-term treatment of high blood pressure is the single most important way to prevent ICH from occurring. So even when we think about acute treatment, let's make sure we're thinking about ICH prevention. Biggest thing we can do to make a difference here. And there are many typical locations for intracerebral hemorrhage, and several of them are typical for hypertensive ICH, which is usually due to damage to the deep penetrating arterial blood vessels. But lobar ICH may occur, especially from arteriovenous malformations, coagulopathy, or cerebral amyloid angiopathy. And one quick tool that we should all be able to do is calculate hematoma ICH volume using the ABC/2 formula. It basically approximates the volume of a spheroid. So I want you all to be able to do this because, as we'll see, this is really key as we communicate about and treat ICH patients. So take the slice where you think it's the largest area and take the longest diameter. Then take the longest axis on the other side. And then we're going to count the number of slices times the slice thickness where you see a significant amount of hemorrhage. There's this little bit of a correction formula here that we used. But let's say A is 6 centimeters, B is 3 centimeters. And let's say we see it on 10 slices that are ½ centimeter each. That's 5. So 6 times 3 is 18, times 5 is 90. Divide that by 2. This is a 45 cc right basal ganglia hemorrhage with interventricular hemorrhage. That's very powerful information. But now let's think about what are we missing and what can go wrong in ICH? Why did people walk away from my patient? They were nihilistic. They figured there's nothing you can do. Lack of understanding of the disease. Well, there are a number of different things that we want to focus on. And we're going to hit some highlights today in talking about the journey of ICH management. First of all, how do we communicate? How do we predict and think about things that influence outcome? What are the mechanisms of injury and how does this drive us to select potential treatments and test those treatments? And what if so-called nothing works? What if trials are neutral or negative? Then how to really standardize and export best practices? Well, the first thing we can do is make sure we're communicating in a standard way. So we developed the ICH score, which is now the most commonly used ICH baseline severity scale. Now notice I did not say prediction model. This is a way to communicate. Take the different factors that are generally associated with outcome that are available at onset, and we can add them up. And it's a simple communication tool that allows us to all be on the same page about our patients. Because the higher the ICH score, the more likely someone is to die and the less likely they are to be functionally independent. However, be very, very careful because we never want to try to use these exact numbers to prognosticate outcome. We want to use this as a general baseline severity score. And there are many other scales out there. You can use something besides the ICH score, but use something in order to standardize communication. When we think about brain injury and ICH and mechanisms of injury, like in most neurocritical care diseases, there's primary injury and secondary injury. And for ICH, there may be perihematomal injury, hematoma expansion, cellular toxicity of blood products that leads to this so-called neurohemoinflammation. So I want to hit some very specific areas that have been important on the ICH journey in understanding evidence of what works or how we need to identify things that may or may not work. This is a bad ICH, but when it expands like this, it's fatal. And in fact, when I was early in my training, I was taught that this was an uncommon complication. And if it happened, there was probably an underlying arteriovenous malformation or coagulopathy. But it turns out that that's not true at all. This happens all the time in regular ICH, even without anticoagulants. And when it happens to a significant degree, it dramatically decreases the likelihood of favorable outcome. Now, we don't really understand the cause. Elevated blood pressure may be a factor, but this has been inconsistent across studies. But what we do know is that hematoma expansion worsens outcome. So if we were able to impact on that, we think that would make a difference. But the factor 7 trial, which was now published, I think 14 years ago, demonstrated that giving recombinant factor 7A to non-coagulopathic ICH patients has a strong and clear impact on the biology of the disease. It absolutely decreased hematoma expansion compared to a placebo. The problem is it did not change mortality or functional outcome on the modified Rankin scale, which is that most commonly used stroke outcome scale that we use in order to assess functional outcome. There was a slight increase in arterial thrombotic events. And the question is, what happened here? So one of the problems probably is going back to those ICH outcome predictors. If we take a person who is in good condition, who has a small ICH, maybe preventing that from getting bigger can make a difference. But if we already have a very elderly person who's in a deep coma, taking them and preventing their ICH of 70 cc's from going to 100 cc's may not make a difference. There was an imbalance in randomization, and the problem didn't seem to be a direct benefit or a direct result of arterial thrombotic events like subendocardial heart attacks. But when you looked at this other group, of this subgroup of patients who are younger, with smaller hematomas, maybe it would actually make a difference, but this was a post hoc analysis. But I want you to hang on to this, because this theme of impacting on the biology of the disease without necessarily resulting in clinical outcome is an important lesson as we think about the journey of ICH. And I think this does inform on future approaches to ICH clinical trials, and I'll get to that a little later. What about blood pressure in ICH? You know, we said 65% or so of cases are due to high blood pressure. What about acutely elevated blood pressure in the patient right in front of us? Well, it depends on how you define it. If you define high blood pressure as greater than 200 millimeters systolic or all the way down to 140, but if you'll see, depending on how you define it, most patients come into the hospital with an ICH and an elevated blood pressure. So this idea of what to do about blood pressure comes up very often. And in fact, if I go back to my early teaching, once again, when I was in training, I was taught that we may not want to lower the blood pressure in these patients because we have a hematoma, and at least some animal models suggested that around the hematoma, there was an area of vulnerable brain, and if you lowered the blood pressure too much, you might cause further brain injury. But in fact, when this has been looked at now many years ago, especially in patients using advanced imaging with MRI and PET scan and SPECT scan, there does seem to be an area around the hematoma of decreased blood flow, but it's probably not ischemia. So the bottom line is ongoing ischemia in this perihematoma region is not common or the major mechanism of perihematomal injury. Could it ever happen? Maybe, but it's not the major problem. And this has really made folks emboldened about the idea of lowering blood pressure aggressively and testing that. So there have been several very large clinical trials. The INTERACT-2 trial, now published almost 9 years ago, had almost 3,000 patients, and they tested lowering the systolic blood pressure to 140 or 180 millimeters of mercury for the first week after acute ICH. Most of these patients were enrolled in China, but they were from other parts of the world as well. And when they looked at the outcome on this modified Rankin scale, what they found is that although it wasn't quite statistically significant, there was a little bit of difference. Lowering the blood pressure more aggressively may actually make a little bit of a difference in these patients. But there was no difference in hematoma expansion. So you have to look at this data and say, does it actually work? And is it a clinically meaningful effect if the difference in these, almost 1,400 patients in each group, this really is an important treatment. This was tested in another clinical trial called ATACH-2, and this one was done really focusing on the intensive care unit environment using intravenous nicardipine to get that blood pressure down fast and keep it there for at least 24 hours. So it was ultra early. And what they found is, yes, indeed, we can lower the blood pressure. We can lower the blood pressure and effectively do that. And you see actually here in this left-hand side graph that there was a good separation between the intensive treatment target of 140 group versus the standard treatment target of 180. But what you also see is the average in that intensive treatment group was actually at 120 or even lower. But on the right-hand side, we see the distribution of scores on the modified Rankin scale. And just as a reminder, 0 is normal, 6 is dead, 3 is able to walk but still has moderate disability, 4 is more significantly disabled and unable to walk. But there was no difference in outcome. So what we found here is there's a difference in blood pressure, but no difference in outcome. And in fact, in the group that got more aggressive blood pressure lowering, they had worsened kidney function, acute kidney injury. So there was some harm, at least to a non-central nervous system organ. So blood pressure in ICH, this has been challenging. We can treat the blood pressure, but what we're probably seeing here is that one size does not fit all. Just saying we're going to take all the ICH patients and we should put them at 140 probably isn't the answer. Now, there have actually been sub-studies of these clinical trials and others that have found some interesting things like blood pressure variability, maybe lowering the blood pressure quickly, but then letting back and it bounces back up and then lowering it again. That could potentially be bad. An early achievement of an aggressive blood pressure goal, maybe that's actually going to be better. There's a meta-analysis suggesting that maybe it does impact a little bit on hematoma expansion. But a lot of questions remain about blood pressure. Is it really effective? Is it a matter of balancing harm and benefit? And maybe it's a matter of picking the right patients. Do we do this based on their medical history or advanced things like testing cerebral autoregulation and brain tissue oxygen tension? I think that what we're seeing now with the blood pressure issue is it represents this struggle between pragmatic generalizability. Would really be great if we could just have a simple treatment to give to everybody that's very, very effective versus targeted treatments to patients that might actually benefit. The challenge of figuring out how to get the right treatment to the right patient because one size doesn't fit all. And this is a recurring theme in intracerebral hemorrhage. So what about surgery? This is a big question, and this comes up a lot as well. So the first big clinical trial was called STITCH, over 1,000 patients. And it really did not specifically test surgery versus no surgery. It tested whether a policy of doing surgery early versus not was better. So patients were randomized on this, quote, uncertainty principle, which meant if the neurosurgeon knew that the clot needed to be taken out, they should take the clot out. If they didn't know, or if they knew it shouldn't be taken out, they shouldn't take it out. And if they weren't sure, they could randomize. Well, that's not a very rigorous way necessarily to do a clinical trial, although it does often mirror clinical care, but it leads to a lot of heterogeneity. And as many of you know, STITCH did not show a difference in mortality or functional outcome. Interestingly, 1 out of 4 patients in the non-surgery group in STITCH ended up getting surgery. So it really wasn't a surgery versus no surgery trial. In fact, think about your patients. Do 1 out of 4 of your intracerebral hemorrhage patients actually get surgery? Not necessarily in our center. We do it sometimes, but not in 1 out of 4 patients. So unfortunately, we weren't able to make a lot of conclusions about surgery from STITCH other than maybe early surgery is not harmful. STITCH 2 looked at lobar intracerebral hemorrhage because there was a suggestion that maybe if it's surgically accessible within a centimeter of the cortical surface, these patients may do better with surgery. And really the same thing was found. There was no difference in outcome. About 1 out of 5 patients in the non-surgery group got surgery in a delayed fashion. But they did an interesting thing, and they had this so-called poor prognosis score, that they developed from the first stitch trial. And they try to look at if a patient had a poor prognosis versus a good prognosis, did surgery make a difference? Now, personally, if a patient already has a good prognosis, I don't know why I'd be doing surgery anyway. So it's only the poor prognosis patients that I would consider it. So it is interesting that in Stitch 2, the poor prognosis patients seem to benefit from surgery. So maybe there is something there, but it's hard to know. So when we look at the 2015, which is the last published American Heart Association intracerebral hemorrhage guidelines, although there is a new edition hopefully coming out this year, there's a lot of different potential recommendations. But one that goes to the top is not really talking about those supratentorial ICH patients that were studied in Stitch and Stitch 2, but what about cerebellar hemorrhage? And the idea that cerebellar hemorrhage really is a surgical emergency. But interestingly, a group from Germany brought together several different cohorts and published this large multinational, multi-center observational cohort where they did propensity matching and looked at cerebellar surgery. They actually found decreased death, but they didn't find decreased severe disability with cerebellar hematoma surgery. One thing that's interesting, though, when we think about this, is they didn't really test whether surgery was done well or correctly in Stitch 2, or this observational study. They just tested whether the patient was taken to the operating room or not. Hang on to that. So what does all this tell us about intracerebral hemorrhage when we think about surgery and blood pressure lowering and hematoma expansion? What it tells us is that we can impact on the biology of the disease of ICH through surgery, through prevention of hematoma expansion with these medications, or even control blood pressure. We can impact on the biology, but we may not impact on the functional outcome of ICH patients across the whole. So one of two things is happening. Either affecting disease biology does not matter once a patient has had an intracerebral hemorrhage. There's nothing you can do once they've had the stroke. Doesn't matter. It's an untreatable disease. Either that, or we're not treating the patients that are most likely to benefit with these interventions. We're applying them across a whole bunch of patients, some of whom may benefit, some of whom may not benefit, some of whom may be harmed. So what do we do when we aren't finding a treatment of clear proven benefit? Well, this comes up, and people ask that question. And I've had my own residents ask this many years ago and say, if there's no treatment, does it matter what you do? Be nihilistic. Doesn't make a difference, right? Well, we wanted to test that hypothesis by asking the question, do patients who are treated in hospitals that overall are kind of nihilistic, nihilism meaning a lack of aggressive intervention, not believing we can make a difference, doing nothing. Do they do worse, regardless of other factors, or does it not matter? So the formal hypothesis we had is we looked at the use of do not resuscitate orders within the first day. Is it associated with outcome, adjusting for hospital and patient characteristics. And the reason we picked do not resuscitate orders is it's very common that patients with intracerebral hemorrhage pass away because we limit care. Sometimes it's because we withdraw care. Sometimes it's because we limit care in other ways. And there are many different cultures around the world, and many different cultures may use medical do not resuscitate orders and so forth differently. But the idea of care limitations and saying, well, you know, we're going to not treat this patient as aggressively because we don't think it's going to work out well, that's pretty common across all cultures. So we looked at a large California database in the United States with about 8,000 patients, 234 hospitals, and tried to look at whether early care limitations in the form of a do not resuscitate order in the first day were common, and whether they impacted on whether the patients lived or died. Now, that's not functional outcome, which is the most important thing, but you have to survive in order to get better. And what we found is that about 40% of patients died in the hospital, but about 1 out of 4 patients was made to do not resuscitate within the first 24 hours. So this was really common. And that there was a lot of heterogeneity. Different hospitals did it differently. So when we looked at an individual patient's risk of death in the hospital, what we found is that there are a number of different factors that influence that. Older age, intubation or mechanical ventilation, which is a sort of a proxy for whether the patient's in a coma, but the hospital do not resuscitate rate. This is not whether that individual patient was DNR. This is how often the hospital used it. So we adjust for all these sort of things, and we say that even if you're treated in a hospital, even if you're treated so-called aggressively in a hospital that generally is non-aggressive, your odds of dying are increased. So what does this mean? Well, it's not the do not resuscitate order. This is really acting as a proxy for overall aggressiveness of care. Even if there's not a clinical trial showing that a specific treatment for ICH is going to solve all the problems, aggressive care really impacts on outcome. And what we found is if we look at the hospitals that had the most use of DNR versus the least, they also did fewer surgeries and fewer angiograms, but it was less expensive and the hospital length of stay was shorter. So it is without a doubt less expensive to let people die early after ICH. But that's really not what we're here for. So we did do a study because we wanted to look at whether this mattered with functional outcome. So we did a study in about 5 centers in the United States of 109 patients, and we wanted to follow people progressively. And we wanted to see if there was a self-fulfilling prophecy of poor outcome because, as indicated by whether aggressive care had less 30-day mortality than was predicted by the ICH score from before. And if so, are these patients just all ended up being severely disabled? So what we found is if you look overall, there was a predicted 50% mortality in the entire group and only about 20% died. And for each ICH score, there was a lower mortality than predicted. Now, higher ICH scores were worse, but there's a self-fulfilling prophecy of poor outcome if you're not aggressive. So what happens to these patients? So this is the modified Rankin scale, and we talked about this before. But what you see is that of the patients that did not die, about half of them had outcomes where they were able to walk or even be independent that were not expected, that were not predicted. But about half of them had a modified Rankin score of 5, which is bedbound and very severely impaired. So that's interesting. Not everybody we saved did great. About half of them did, because I think with a severe ICH, if patients are able to walk in the future, most folks consider that an acceptable outcome. But not all of them did. So what does this mean? This means maybe some people are better off with the intervention of not being nihilistic, but some people are not better off if you believe, as some people do, that being bedbound and unable to care for yourself, needing total care might even be worse than death. That's certainly a point that is maybe up to the patient and their family. So what does this mean? Does this mean that the treatment is not beneficial? I don't think so. What it means is that because some people are better off with it, and some people are not better off or maybe even worse, the task is figuring out in which patients an intervention of any kind is beneficial and in which it's harmful, and getting the right treatment to the right patient. And I think the other thing we have to do is understand the outcomes that are meaningful to specific patients and their families. Just because we do a clinical trial and say the outcome, a good outcome is a modified Rankin score of 3 or better, doesn't mean that's what our patients think. So let's take a step back and think about what works. I started this talk discussing acute ischemic stroke, and the world of acute ischemic stroke has fundamentally changed and been advanced in the last half a dozen years. And so let's look at this and take a lesson. Here's what we do now. We don't just give TPA to everybody and say we're done. We do an advanced stroke CT. And if a patient comes in with a left middle cerebral artery clinical syndrome, and we see that there's a cutoff with a middle cerebral artery occlusion and a CT perfusion study that shows the blood flow is down and shows that the blood volume is preserved, but the mean transit time is down. This tells us there's mismatch, and that's salvageable brain tissue. When we take the patient to the angiography suite, and we're able to find that middle cerebral artery occlusion, and we're able to put a stent retriever up there and pull out the clot and restore the blood flow. And here's what the clot looks like. And remember, this is what the very first generation retrievers look like. You can't get these anymore. Okay? This is not what they look like anymore. They've been developed over the last decade, more than that. And now we have 8 clinical trials that show embolectomy is effective. You have to have an infrastructure to do this, but it's very clear, and this has just completely changed the way we approach acute ischemic stroke. And this is precision medicine. Select a patient with a specific disease pathology that can benefit and deliver a highly effective targeted intervention for that problem. The right treatment for the right patient, not one size fits all. So let's think about this with regard to intracerebral hemorrhage. So I had the good fortune to publish a viewpoint piece several years ago in collaboration with Gentle Shrestha, who's a friend and colleague in Kathmandu, and Jose Suarez at Johns Hopkins, where we really tried to say, let's shift, not just for ICH, but neurosurgery in general, we've got to shift our mindset to think about how we can better deliver precision medicine. So we think about optimizing outcomes. There's probably going to be a balance between precision medicine for individual patients. The problem is it's expensive and complicated. It's often challenging to know the right target, but we may be able to deliver the right treatment to the right patient. Versus a simple standard approach across all patients. The problem is one size probably does not fit all, and we may miss treatments that are best for specific treatments. But this is more practical to implement broadly. And I think we need to think about how we can keep both in mind and perhaps do both. A recent clinical trial, a couple of years ago, the MISTY clinical trial, tried to look at minimally invasive surgery in patients with intracerebral hemorrhage. And the idea was put a catheter in the clot and instill TPA to try to get the clot out over the first couple of days. And they had a detailed, standardized approach where they were very careful and very rigorous. Here's about 5 of the highlights of that. And what they found is they definitely decreased mortality, but they didn't improve overall functional outcome. And I remember when this was published, and I had a number of colleagues say, well, see, this doesn't work. It doesn't really improve patients. It saves lives, but leaves them severely disabled. Let's move on. There's nothing that's going to come out of this. But wait a minute. when the MISTI group went back and looked at whether there was a functional outcome benefit based on surgical performance, what they found is if there was excellent hematoma evacuation, there was less intracranial pressure in the surgical group, and there was better functional outcome. And that greater surgeon and site experience was associated with better hematoma evacuation. So the more training someone had, the more experience someone had, the better they did. And you know, this is really interesting. This should not be surprising. What is surprising is that the expectation of doing a surgical procedure well has not been part of surgical trials before. It's just been surgery or not. Well, that's not true with embolectomy. Just because you take an ischemic stroke patient to the angio suite, if you don't get the clot out, they're probably not going to make a difference. So what happened in embolectomy is it took years of many more people getting trained how to do it, better devices, better selection of patients. The first embolectomy studies, there was recanalization about 50% of the time. Now it's expected well more than 80% of the time. So that was the ischemic stroke journey. And it makes me wonder whether this is really an important lesson for the intracerebral hemorrhage journey. And let's think about patient selection. So when I look at my patient and I look at that CAT scan like was at the beginning, I don't actually know what's going on with the fiber tracts in the circuit of the brain. I'm making my best estimate, but now there are actually a number of small studies using advanced neuroimaging, in this case, diffusion tensor imaging, and they showed that if you have a patient who has in this case, basal ganglia hemorrhage, you can't tell just by looking at them whether their corticospinal tract is still intact, and the reason they're paralyzed on that opposite side is because of pressure on the corticospinal tract from the hematoma, or whether the corticospinal tract has been cut in half by the hematoma. And the reason they're paralyzed is it's dissected through. But it sort of makes intuitive sense that if the corticospinal tract were intact, the patient's more likely to improve. But if it's dissected, maybe not. So this could be an important lesson in patient selection. And here's an example of a patient from San Francisco General from about a year or so ago, in which we had this left basal ganglia hemorrhage, and they were paralyzed on their right side. And we did an MRI scan, and a standard MRI shows the hematoma, but not much else. But if we do diffusion tensor imaging, we can actually see that the corticospinal tract on this patient is completely intact all the way from the cortex through the subcortical region to the brainstem. And this is early on. But the idea that these are patients where maybe surgery would make a difference because their brain has the capacity to recover, that's very intriguing. Obviously, this is expensive and advanced imaging, but it's getting at the biology of the disease. And there are actually multiple ongoing minimally invasive ICH surgery clinical trials now with various devices that are also trying to improve patient selection. We're going to hear more about these in the coming years. And remember that FAST clinical trial using recombinant factor 7A that showed an impact on the biology of the disease, decreased hematoma expansion, but did not show an improvement in clinical outcome. Well, now FASTEST is a clinical trial that's being started in the United States to really try to look at these patients who are younger, can be treated earlier, and may potentially benefit from keeping hematomas from expanding. So the trial's just getting started. It's using recombinant factor 7A, and we'll see. Targeting to patients that may benefit. Now let's talk for just a few minutes and switch gears from the precision medicine to a broader approach, because we also want something that we can implement broadly for patients. And Adrian Perry-Jones and his group in the UK published a really interesting idea of an intracerebral hemorrhage care bundle. They call it the ABC bundle. And it's for acute ICH patients. And what they found is that the ABC bundle, when implemented, dramatically decreased risk of patient mortality. And their bundle is urgent anticoagulation reversal with the proper agent, aggressive blood pressure lowering, and neurosurgical referral for patients with good pre-intracerebral hemorrhage before pre-stroke function who seem to have severe either coma or posterior fossa ICH. This does not mean they got an operation. It means they brought the neurosurgeon in to the case. And the ABC bundle was associated with lower risk of death, more aggressive care, but there was an increased admission to critical care. There's an increased resource utilization. And that is something we have to realize is if we're going to treat patients aggressively, we're going to use more resources. And thinking about other components of good ICH care, we mentioned coagulopathy reversal is important. We've got to remember venous thromboprophylaxis is very important because we've got to avoid secondary complications, whether it's a deep vein thrombosis or pulmonary embolism, inadequate nutrition, or infections or cardiac dysfunction. So these are important aspects of good care as well. And I don't want us to forget rehabilitation therapy and the importance of that because it really is key in our patients. So remember that there are guidelines out there. I refer you to these. There are other guidelines from other parts of the world besides the American Heart Association. These are probably the most commonly used. But understand and use guidelines. Have a standardized order set in your hospital for ICH patients, whether it's for coagulopathy reversal or all the general aspects of their care. Consider performance measures. Track your data. Are you doing what you think you're doing? And how are your patients doing? And get trained. Here's an example of a program called Emergency Neurological Life Support. And I know in prior years, ISNACC has sponsored courses. And this ENLS has an intracerebral hemorrhage module, but other aspects for acute neuroemergencies as well. So even as we think about precision medicine, a standard care approach for ICH is really important. And one thing is getting everybody at the hospital on the same page before that ICH patient comes in. Have a hospital or IC intensive care unit committee that works together and plans ahead. Review the evidence-based published guidelines and have a standard patient care order set in your hospital. What is your bundle? Track your compliance and patient outcomes, and be very careful about prognostication, especially predicting negatively early about ICH, because there's a lot of uncertainty, and we want to avoid the self-fulfilling prophecy. And this has really come to light even more in the last 2 to 3 years in studies that have looked at these advanced ways of looking at consciousness, or what's called CMD, cognitive motor dissociation. And that's a patient who's not responsive to your clinical exam, but they are responsive when you do advanced imaging or advanced EEG. And here's a paper from Korea from 2019, where they really found that diffusion tensor imaging of the reticular activating system in patients with intracerebral hemorrhage was key to their recovery. We can't see that on exam. And then Jan Clausen and his group at Columbia University in the United States, where they found the patients who had this cognitive motor dissociation, they were responsive on EEG, but they weren't on the clinical exam. They were much likely to recover. So we've got to be very careful. And I think that these new advanced approaches are really getting back to assessing specific mechanisms of coma and recovery in individual patients, not just a clinical description of the current state. And this is important for ICH patients, probably for traumatic brain injury, subarachnoid hemorrhage, all these different neurocritical care conditions. And so I do want to make sure you're aware of the Curing Coma campaign, which is an initiative started a little more than 2 years ago by the Neurocritical Care Society to really try to get at this underpinning of can our patients with impaired consciousness recover? And what can we do to help them recover? And this is really a question that comes up for all of us that work in the intensive care unit environment and probably the operating theater every day with these neurocritical care patients. And the two major arms of the Cure and Coma campaign are really to fundamentally move the science forward, but to then build a community, not just of scientists, but those of care providers and those that are going to implement new approaches. A paper was published 2 years ago now looking at the scientific pillars of trying to understand the underlying endotype, not just the phenotype of what patients look like, and move us forward with biomarkers and proof of concept clinical trials across this care continuum. And I'm going to say that everybody has a role to play in the Cure and Coma campaign. So if you're a consciousness scientist looking at advanced neuroimaging, you have a role to play. If you take care of patients at the bedside as a physician or nurse, and you struggle with this issue of what can we do to improve their outcome, and how do we know how they're going to do, you should be part of the Cure and Coma campaign. So I want to invite you to join us on World Coma Day. It's a 24-hour virtual day where we're going to hear about science, patients, ICUs, rehab units, research units that are working together on this. And here's how you sign up. Just go to cureandcoma.org. It's sponsored by the Neurocritical Care Society. So I want to conclude by getting back to that idea of optimizing patient outcomes from intracerebral hemorrhage and the journey that we're still on. I will say that the field of ICH is much different than it was when everyone walked out on my patient in the CAT scanner those many years ago. And that's good. That's important. And we've learned some lessons. One is that communication and standardization is key. Calculate hematoma volumes, use a baseline severity score as part of your evaluation, something like the ICH score. Nihilism is an ineffective treatment strategy, though. Even if we don't have that perfect treatment, aggressive care makes a difference. But one size really does not fit all patients. And I think the major advances in acute intervention are most likely to come from using a biologically effective targeted intervention in patients selected with a specific disease pathology that can benefit from that intervention. And that may be high-tech. It may not be high-tech so much. That's our job to figure this out. But as we're moving through this together, even in the absence of a treatment of proven benefit, remember, good care makes a difference. This is the art of being a physician, and it matters. Thank you very much for letting me be part of the meeting, and I wish you success on the rest of the meeting and the year to come. Thank you.
Thank you so much, sir, for an excellent oration. So since this is a customary that there will be no question answer session in an oration, so may I request Professor Dr. Madhusudan Reddy, sir, to say a few words and conclude the session. Thank you, sir. Sir, you are not audible, sir.
I just want to thank you for letting me be part of the meeting. Thank you.
Thank you for the exhaustive, well-informed lecture about this optimizing the outcomes of intracerebral hematoma. As you said, no one size fits all. Whether you want to operate or not operate does not influence the outcomes at present. So probably as an anesthetist and intensive care physicians, we have to optimize the ventilatory support, blood pressure monitoring, intracranial pressure monitoring, and osmotherapy, fever control, seizure prophylaxis, and nutritional supplementation. And probably some more research and more exhaustive research in future may help in improving these outcomes. And this was a very good lecture, and you have covered everything regarding this intracerebral block. I'd like to thank you again. Thank you, sir.
Reddy, sir, can you please show the medallion and certificate of to Dr. Hemphill, sir?
It is there on the. It's there.
That is wonderful. And I just want to thank you again. It's been such an honor to be part of this. And I always love the ISNACC meeting. It's just very, very insightful.
Thank you, MPhil sir. Thanks to all the chairperson. So if I am allowed, can I conclude this session, please?
Yes.
Thank you, sir. Thank you so much. So our next session will start after 15 minutes, and that will be on neuropalliative care and neurorehabilitation station. And may I request Dr. Inattentional Ghosh sir to kindly moderate this session, please. And there is another announcement. May I request all the attendees to kindly visit our stall. So there is another announcement that Department of Neuroanesthesiology and Critical Care, AIIMS New Delhi, they will be organizing 3rd annual conference of Neurocritical Care Society of India, that is NCSI 2022, and AIIMS Neuroanesthesia and Neurocritical Care Update 2022, which will be held at JLN Auditorium, AIIMS Delhi. So this is the first flyer. So may I request everyone to kindly register, please. Thank you.
Thank you, Shubhojit. This is Dr. Indranil.
Hello, sir. Good morning.
I am morning. So I will request all the attendants, and the delegates to just wait for 6 minutes, and we will start very, very important session of neuroanesthetic care and neurorehabilitation. Thank you. Hello, am I audible? Hello.
Yes, sir, you are audible.
Okay, so we will start the session in a couple of minutes. Can you show the first title slide of the next session? Hello and a very good morning to the delegates. I welcome you to this session number 10 of the present conference. As you can see, the name of the session is Neuropalliative Care and Neuro Rehab session, which of course all of you will agree that it is a very important part of the multidisciplinary team which exists in caring for patients with neurological impairment. So I'll request the organizers to show us the slides of the chairpersons. We have 3 very distinguished chairpersons for this session: Professor Dr. Shushma Bhatnagar, Professor Dr. Umesh Padani, and Dr. Sucharita Chakraborty. I'll start by introducing Shushma Madam. She needs no introduction. She is a professor and HOD of the Department of Onco-Anesthesia, Pain and Palliative Medicine at IRCH Hospital, which is a part of All India Institute of Medical Sciences, New Delhi. She is a chairperson of COVID services right now. In fact, just before the start of the session, she called me up and said she's busy with the COVID activities. So she will join us a little late. She is the founder of Cancer Treatment Center Project for Pain-Free India. She is the president of Indian Association of Palliative Care. She is a convener of DNB Palliative Medicine and National Board of Examinations, founder of DM Onco-Anesthesia and MD in Palliative Medicine at AIIMS Delhi. She is a founder of 2 very important policies, pain policy and end-of-life care policy at AIIMS New Delhi. President, as I said, of Indian Association of Palliative Care since 2018. Recipients of many awards, namely Leadership and Excellence Awards among SAARC countries in 2012. President of ISP Award for Excellence in Clinical Research or Practice or Policy Changes in Pain Management in the Developing World. Teaching and research experience of hers is around 31 years. The research interest of Madam lies in cancer pain management and palliative and end-of-life care. And she has innumerable 336 publications, and she has attended around 320 or more conferences as chairperson and respected speaker. I welcome Shusha Madam. Can you just show the slide of Professor Badani? Dr. Umesh Kumar Badani is a Dean and Professor and Head of the Department of Anesthesiology, All India Institute of Medical Sciences, Patna. He is a medical graduate from Jamshedpur MGM Medical College and did his post-graduation in anesthesiology from Darbhanga Medical College. His areas of interest remain in pain, palliative care, regional anesthesia, and medical education. He has been a teacher in the undergraduate and postgraduate level, and examiner at the level of MD anesthesiology. He is a trainer of basic and advanced life support and reviewer of national and international journals. He has got around 10 international and 39 national publications. Welcome, sir. Our third chairperson is our joint organizing secretary of this conference and my senior in my undergraduate medical college, Dr. Sucharita Chakraborty, consultant neuroanesthesiologist at Fortis Hospitals, Anandapur. So we have got three excellent speakers in this forum. Professor Dr. Roop Gursahani, Dr. Abhijit Dam, and Dr. Suparna Ganguly. So Dr. Roop Gursahani will start the first session. In absence of Dr. Sushma Madam, I will take the responsibility of Roop Gursahani, sir. He is a consultant neurologist at PD Hinduja Hospital, Mahim and Khar, Mumbai. He is in the board of directors of International Neuropalliative Care Society. He is a trustee, Forum for Indian Neurology Education, member steering committee of ELICIT, which is the End of Life Care in India Task Force, which is a joint initiative of Indian Association of Neurology, ISCCM and IPC. So over to Dr. Roop Gursahani, sir, for the first topic on decision-making in devastating brain injury. Thank you.
Hi, I am Dr. Roop Gursahani from Mumbai, and I'm going to be speaking to you about decision-making in catastrophic brain injury. I'd like to begin by thanking Dr. Amy Hoffnegle for inviting me to speak to you. And now we are looking at situations in which individuals who are otherwise normal are hit by almost anything, whether a clot, a truck, or a bomb, and precipitously decline in neurologic function. And in earlier times, without current standards of neurocritical care, would almost certainly have died. But because of our management, some patients, of course, do improve, though with disability. I'm going to be speaking of examples from these situations. They are primary, ischemic stroke, hemorrhage, traumatic brain injury, other CNS pathology, and secondary, such as global anoxic injury after cardiorespiratory arrest and resuscitation. But broadly, we need to distinguish between medical versus traumatic causes of catastrophic brain injury. I'll do this through three patients. The first was this girl who had a freak road traffic accident and effectively was admitted brain dead. Now, brain death is almost always due to catastrophic brain injury, where massive increase in intracranial pressure compromises circulation, the mean arterial pressure is exceeded, and finally cerebral circulatory arrest leads to rostral to caudal death of the brain, and eventually involvement of the medulla leads to loss of the respiratory tract. To determine irreversibility, the waiting period depends on etiology, and a minimum of 24 hours is taken as necessary for post-CPR, though that has not been validated. And obviously, an adequate waiting period before assessment makes waiting period between assessments redundant, but we still do have to do them usually. To determine brain death, you must first have a known cause of catastrophic brain injury confirmed on neuroimaging, or else imaging findings compatible with cerebral circulatory arrest, which means severe brain edema and loss of gray-white differentiation. Confounders such as metabolic, toxic, and so on have to be ruled out. A clinical examination should confirm both coma and loss of all brainstem reflexes. And then we go on to the standard apnea test. And I'm not going to go into the details of how that is done. But just to point out that it is a clinical test and does not require family or surrogate consent. It is now becoming worldwide consensus that although we may make reasonable efforts to notify patients' authorized decision makers, we don't require their consent to initiate this evaluation. And it's important because it cuts short all confusion. I'm just leaving this here as a possible reference that you could look at. The World Brain Death Project published multiple papers in JAMA last year, and they're all well worth a read. So this girl, well, once the prognosis was explained to her parents, it took them a couple of days to decide, and now she lives on in these transplants that were performed later that week. But we have another duty, and that is to de-link brain death determination and organ donation. So brain death determination without organ donation means foregoing life support, and organ donation without brain death in patients with catastrophic brain injury would mean donation after cardiac death, and I'll explain both of these. So if organ donation is not possible if refused, can you declare brain death and withdraw life support? Yes. In the Aruna Shanbhag case, this has been explicitly decriminalized way back in 2011. Even the MCI Code of Conduct says that provided you follow the provisions of THOTA, you can perform this withdrawal. And the only case that I know of is a hospital was fined 5 lakhs for keeping somebody who was brain dead on the ventilator. Kerala was the first, but 3 state governments have passed government orders, Kerala, Karnataka, and Gujarat, that brain dead patients can be taken off life support. For us as clinicians, it all depends on who is paying. If it is the family, well, then you have to often accept their decision. But if it is the state, a public hospital, then it's the doctor's responsibility. But if it is third party or insurance, remember that you are the one who's going to be caught in between. What about organ donation without brain death? That's called donation after cardiac death. It has to follow the dead donor rule. The donor ideally should have asked for this, and the surrogate should confirm. Extubation is performed in the OT with harvest team on standby, and after the heart has stopped for a deemed irreversible period, which varies from jurisdiction to jurisdiction, organ harvest begins. Earlier, only kidneys were being accessed in good condition, but the boundaries are now being extended. Even the heart is now available. A white paper, of which I was also part, will be appearing next month on the prospects for DCD in India, in the Indian Journal of Transplant. The next patient is this lady who was recently diagnosed hypertensive and came in with this massive intracerebral hemorrhage. And on seeing the scan, in fact, I suggested leaving her alone and just moving to comfort care. But the family was insistent, and as the husband put it, he said, I want her back home. Now, when you manage patients with severe injury in the first week, the initial prognosis is uncertain, and you have to beware of self-fulfilling prophecies, which is very typical of intracerebral hemorrhage. Hospitals that have a withdrawal policy definitely do have higher mortality with intracerebral hemorrhage. You have to consider the possibility of neurosurgical salvage, and this is a surgery of decompressive craniotomy. Though there has been a fair amount of argument about the ethics of having people survive for long periods with disability. And hence, my rule is a time-limited trial of full intensive care therapy for 24 to 72 hours, which usually satisfies economics, ethics, and common sense, and understanding that the surgical decision is not the final point of decision-making. Because foregoing life support can happen even after that. When we look at people who come in medical coma, this is not traumatic coma. This would mean individuals who have a GCS of 8 or less, and this has stayed steady for longer than 6 hours. I would think about 50 to 60% of them do not survive. And varying proportions come out with mild or no disability, but that's actually a minority. And how do you predict this in the initial stages? The most accurate, of course, etiology, depth of coma, duration, and so on matter. But what matters are the signs that you can elicit, which suggest that the upper brainstem is involved. So loss of any brainstem reflex is important. Absence of motor response is important, but also a motor response that is abnormal, either decorticate or decerebrate. And both of these, far more than neuroimaging electrodiagnostics, actually mark a tipping point with much lower probability of an independent outcome. So in addition to that, we also have to use comorbidities, permanent organ dysfunction, and age to put together our prognosis in these patients. When you are making these decisions, remember that there will be prognostic uncertainty about the level of future disability, but also about the patient's ability to adjust to the new disability, or for families, the likelihood that the patient is going to be permanently cognitively impaired and no longer able to participate in decision making. We also have to think of the focusing illusion. As normal individuals, we are likely to imagine that the quality of life of this individual is likely, of this individual who has survived with disability, as very poor. Whereas that individual may have adjusted to his deteriorated circumstances and now is maintaining a better quality of life than we expect. This is called the disability paradox, and our lack of understanding is the focusing illusion. So how do you make these decisions? Rather than evidence-based, these have to be preference-based decisions. And the hierarchy of preference-based decisions are patient's known wishes, above substituted judgment, above what are termed best interest decision-making. Patient's known wishes ideally should be recorded. The substituted judgment should also be a documented healthcare proxy, but otherwise from the surrogate hierarchy, and I'll be speaking about that. And best interest decision-making also we'll come to a little later. Now, when you explain substituted judgment to family, you have to explain to them that we are asking them to tell us what the patient would have wanted or thought. And they ideally should also be aware of the prognosis. Now, the problem with lay people understanding prognosis, they usually begin by expecting the best. They expect their patient to recover, which is not, and they don't have the same knowledge that we do of the outcomes of these individuals. When we explain it to them, remember that they do want prognostication with compassion. They do not want false hopes. So on these two, they are concordant with us. But where they are discordant with physicians is, physicians prefer qualitative explanations for prognosis. We understand that uncertainty is a natural part of this prognosis, and we are not willing to use prediction scores. But surrogates need explicitness, and they prefer numeric estimates of prognosis. So how do we do this? This was a study on anesthetists in Australia, and they were given 3 cases together with the scans, and they were asked to imagine themselves to be the patient, whether they would want a decompressive craniotomy for yourself. And after they had voted, they were given the outcomes on these cases, which are predicted from what is termed the crash trial in numeric terms. And you can see, given this numerical outcome, changed their decision substantially. And these are doctors. So when you communicate prognosis, you have to give estimates from the literature, use MRI findings, and use pre-morbid functional status because nobody is going to go out better than they arrived. We communicate best case, worst case. We use definite statements only for never be normal or brain dead. Otherwise, we give ranges. So less than 10% chance of being able to stay alone at home. Only 70% chance, there's a 70% chance that she may not be able to recognize you. And these are heuristic estimates, which at least with experience, most of us, if at all, are on the optimistic side. The maximum uncertainty is in traumatic brain injury in younger patients, and here one has to be really careful. You put this estimate together with what the patient is expected to have wanted to get to setting goals of care through shared decision making. This lady underwent a decompressive craniotomy, a PEG, a tracheostomy, and 6 weeks later and 6 months later, both were out. So this was obviously a good result, and if we had gone ahead with withdrawal, that would have been a self-fulfilling prophecy, right? Except that, let me tell you a story as it went on. 3 years later, she was wheelchair bound, almost completely dependent, sad but not depressed. And as her husband put it, she kept asking me, why did you have me operate? And he himself was, in fact, he was more depressed than she was. 6 years later, he passed away. This was last year due to COVID. They were well off. But the problem is that she is now, there's no one to take care of. So who decides when the patient cannot? Ideally, this should be an advance directive and healthcare power of attorney, and these are now valid and enforceable in India after the 2018 judgment. The Supreme Court has put down a complex procedure, but nobody stops you from making your wishes known. The surrogate decision maker still is by convention. Normally, it should be by legislation, but we can follow the AIMS end-of-life care guidelines, since AIMS is a statutory body, and they put down this surrogate hierarchy. It's important to note that even the Human Organ Transplant Act doesn't have a surrogate hierarchy. Of course, for those without a nuclear family, it may be very difficult. The next patient is this individual who came into us with basilar artery occlusion, thrombectomy failed, and was stuck on the ventilator. Now, we need to begin a conversation of neurologic prognosis by day 3, definitely by day 10 to 20. This consists of the family meeting, where you have to ensure relevant participation, especially whoever is paying. You have to figure out whether how comfortable the surrogates are with taking decisions. Then you ask their permission, deliver information, and check their understanding, what we call ask, tell, ask. Uncertainty has to be explained together with impact of decisions. We've already spoken about eliciting patient preferences. We have to consider our own bias. The surrogate bias is typically towards optimism. As a team, we have to have consistent communication. And if there is consensus required, use time-limited trials in which you define an intervention, define the duration of the intervention, the desired outcome, and what you plan to do after that. These conversations about the long term should typically occur after 2 weeks have passed or when the patient needs a tracheostomy. Because this fork in the road leads to reassessment, either support in the hope of improvement or de-escalation to palliative care. And this may be harsh news for families, but we have to provide sufficient details and help them through it. So this individual, there was family dissension, except for the wife. Everybody else wanted to withdraw, especially the people who were shelling out the money. So eventually the tracheostomy and PEG got placed after 19 days because the wife prevailed. He stayed for a further 4 weeks, but eventually passed away 3 months later. So you have to beware of colleagues who may want the tracheostomy done quickly so that the patient can be moved out of the ICU. Unfortunately, that may saddle the family with a decision that they are still not prepared to take. And to help them take this decision, you have to frame this decision as a withholding decision rather than a withdrawal decision, because although withholding and withdrawal are equivalent, to the layperson, withholding is easier. So how we explain that to them is that the extubation, which means the removal of the endotracheal tube, we explain as a medical necessity. But we explain to them that putting in the tracheostomy or to withhold it is going to be the family's decision. And once they understand that the withdrawal part is not their emotional burden, they are able to take these decisions with a more cool mind. The due process for foregoing life-sustaining treatment includes consensus amongst the treating team, amongst the surrogate decision makers. You have to confirm the hierarchy and complete documentation. And if you look for documents, you will see that the AIMS Delhi end-of-life care policy gives you enough forms. So does Blue Maple from Manipal, and the government itself has already supported this with the ICNR DNR white paper, of which I was a part. As I said, rules for declaring death by neurologic criteria are now beginning to be, are probably going to be valid for the whole country. And so at this moment, although this legal scenario is still in flux, remember that the ethical decisions can be taken. When we do this palliative extubation, the family is assured that the patient will not suffer any symptoms. Extubation is performed in the ICU, symptomatic management is instituted, and then the patient is moved out if he or she survives, say, beyond about 4 to 6 hours. If you look at these patients, as they go past this stage, when do they reach a stable state? For traumatic brain injury, I would give it a period of up to 12 months. But for non-traumatic coma, it would be a maximum of about 3 months. And as they improve, brainstem functions return. So for instance, breathing, swallowing, and eyes open. That is the persistent vegetative state. In the minimally conscious state, they may also fixate gaze and follow simple commands. It's important to distinguish between these two, because what stage they reach at 90 days gives you an idea of what stage they will eventually reach. If somebody stays stuck in the persistent vegetative state at 90 days, then it is very unlikely that they will recover beyond this stage. And in this group, only one patient reached that level of being left alone at home for 8 hours. Those in the minimally conscious state did somewhat better. If this individual needs withdrawal of clinically assisted nutrition and hydration, which means after the persistent vegetative state has been instituted, that is a fairly prolonged process. In addition to the judicial sanction, you also need to dehydrate and starve that patient to death. And that is a pretty excruciating business. But these decisions do have to be made. And when these decisions have to be made, this is called best interest decision making, where it doesn't take into account, it takes into account the whole ecosystem around the patient. And the best system for this is in the UK. This is called the Court of Protection. And if anybody is interested in listening to these stories and the way these decisions are made, I strongly recommend following the Kitzinger sisters on Twitter. So just to conclude, decision-making points in catastrophic brain injury can be initial, neurosurgical, early brain death determination, intermediate, tracheostomy versus palliative extubation, and late withdrawal of artificial nutrition and hydration. Remember that managing these patients, every patient family is unique, but you can do this well, ensure a good death. It's our responsibility to do right and to be seen to have done right. because if it does not done well, then it can leave the surviving family traumatized. Futile medical care that leaves a family with a dead body and financial debts is a huge cause of anti-doctor-centeredness. It requires a commitment to shared decision-making, to supporting the family and surrogates through the process, minimizing the sense of guilt, respecting the commitment, together with clarity about the ethical and legal framework. I'm going to stop at this point. My email ID and mobile number available in case anybody wishes to reach out to me for any advice in the future. I'm more than happy to help. Thank you.
Thank you, Roop sir. It's always a pleasure to listen to you, and we always learn new things when we listen to you. I now will request Professor Umesh Badani sir to introduce our next speaker, Dr. Abhijit Dam. The slides, please. Umesh sir, please introduce Dr. Abhijit.
Good morning, everybody. It is my privilege to introduce Dr. Abhijit Dam, who has done his MD from AIMS and done PDCC, NFM, MSc in palliative medicine. He is a specialist of now, he is basically an anesthesiologist, but doing palliative care in a very big way. He has done a lot of, he was the president of Association of Palliative Care and was a director of, medical director of Koshish, a hospice. He has done MSc in Cardiff, UK, fellowship in interventional pain management, fellowship in the aging from the Stanford University, and he has got lot of good work done in palliative care and in pain relieving medications and procedures. I welcome Dr. Abhijit Dam for his lecture, which is coming to this conference. Dr. Abhijit Dam, please.
Well, good afternoon, everybody. Today, I'll be speaking on ethics in palliative medicine with a special emphasis on neuropalliative care. In this 20 minutes which have been allocated to me, I really don't know how much justice I can do, but then definitely try I shall. Well, Eric J. Castle has said that the relief of suffering and the cure of disease must be seen as twin obligations of a medical profession that is truly dedicated to the care of the sick. Physicians' failure to understand the nature of suffering can result in medical intervention that, though technically adequate, not only fails to relieve suffering, but becomes a source of suffering by itself. And to give you a good example of this, here you see this lady. You can see that she just has one leg. She had one leg, to be precise. She had osteosarcoma, and one leg was amputated. And then there were metastases in the spine as well. And in this state, she was pregnant. And she was paraplegic when she was pregnant. But anyway, she underwent a cesarean section. And she delivered a little beautiful female child. Angered by that, her husband took her and the little child and dumped her back in her father's place. So the father had to now look after his paralyzed daughter, paralyzed from waist downwards, paraparesis. And then they consulted a neurosurgeon who said that the cervical spine was also unstable and that he would operate to stabilize the cervical spine. And it was a very expensive surgery, and titanium plates were put in the cervical spine to stabilize the spine. Although the osteosarcoma was already, widespread at that point of time. Post-operatively, this lady who was pre-operatively only paraplegic developed full-blown quadriplegia. And then she was in a state of total pain. So we need to now contemplate on the ethical considerations surrounding this particular case. I'll take you through other cases as well. Now, this was during my training in Poland, where this was a newborn child with multiple congenital anomalies. And the moment the child was born, the child couldn't breathe, and the doctors out there, they did a tracheostomy on the child. And then they found that the child couldn't swallow as well. So they did a feeding gastrostomy on the child. And you can see the saturation is just 85% on room air for the child. The quality of life of the child, you all can very well understand what the quality of life for this little child would be. But then the mother out there had decided that, no, I want that everything which can be done should be done for my little child. And I had the fortune to accompany the child back home for the first time from the hospital after the child was born. This is another child, again with a neurodegenerative disorder or probably a metabolic disorder. And since birth, the child has been on ventilator, on home ventilation, saturation around 94%. Here is another child, since birth, some complex metabolic disorders, and tracheostomized since birth, and on home oxygen therapy. And since birth, the child has been like this and is currently grown up to this state. So here again, it was the parents' preferences that we want everything that can be done for our child. So this is another example where certain ethical principles would definitely come into play. Now, when we apply ethics to clinical settings, we need to focus on different areas. The first is medical decision making. In all these examples which I've just shown you, medical decision making is very much important. Then comes the issues of futility, right? Then there are conflicts of value in terms of what, for the mother who decides that everything should be done for my child, the child is, for the mother, the child is very important. For the doctor, the child is just another patient. For the family, the child might perhaps mean expenses. So there could be conflicts of value between the patient, the family, the doctor, the mother. Then we need to focus on the best interest, the realistic goals of care. You need to focus on realism out here, because after all, it is the patient, after the surgery or after the intervention, whatever you do, you need to actually tell them the truth, what to expect and what not to expect, the level of suffering of the patient, the quality of life which is acceptable to the patient. Like in the first case where the lady with the osteosarcoma, where the neurosurgeon went ahead with stabilization of the cervical spine in spite of the fact that there were widespread metastasis, and after the surgery, the lady ended up in quadriplegia. She was earlier able to move her upper limbs at least, and after surgery, she ended up in quadriplegia with no benefit whatsoever and with a big financial drain. So what are the realistic goals of care? Now, the realistic goals of care would keep on changing as the disease progresses. So initially, we would be focusing on a cure of disease, then avoidance of premature death, and then as the disease further progresses, maintenance or improvement in function. At some point, you will be contemplating on prolonging of life, and then you will be thinking of relieving of suffering, good quality of life, and then you will be bargaining and saying, or at least let me have some control, staying in control. And then you, at some point of time when, this is called the melting ice situation, a good death, you would be thinking of a good death at least, And then after you die, what your family would need is good bereavement care. So the realistic goals of care keep changing as the disease progresses. And we need to keep on changing our plans accordingly. It is not that you just make a plan at a particular point of time and that is it. No, your goals of care need to keep on changing. And there should be a continuous discussion with the patient and the family members. So the goals of care keep changing. So review is very important. Change in priority of goals and review goals with change in the functional status of the patient, because this functional status is a very important determinant It's a very, very important determinant about how or what the patient what it means to the patient in terms of quality of life. Then you should also need to focus on setting of care. What is the setting of healthcare in which the patient would be nursed, and what are the treatment preferences as well. So the emerging ethical issues in modern times are inadequate or insufficient communication. We really don't have the time or the staff or the privacy to have a good conversation. You ask yourself, how much do you actually converse with your patient, right? And most of us are not even trained to communicate effectively. So, and also there would be issues with the patient, the family, language problems, the cultural and social factors, surrounding good communication practices. Then resource allocation, like staff allocation, who would actually do the communication, who would do it in a proper way and document it. Lack of bedside time. We hardly spend time by the bedside of the patient nowadays. And competences in palliative care, like good communication skills. Communication skills are, in essence, the backbone of good palliative care. And we need to have a holistic approach in what we do. So what are these ethical principles? These are basically guiding principles for the healthcare personnel in work and decision making. So there are basically 4 principles. The first is non-maleficence, that whatever you do, first of all, please don't do any harm, right? That is what non-maleficence means. And second comes beneficence, that is do good. But remember, before doing good, please do not do any harm. So non-maleficence, then comes beneficence. Third is autonomy. Autonomy means this is my body. At least let me decide what I want for myself, right? It is my life, it's my body, it's my suffering. So let me have the decision-making capacity. So that is autonomy. And justice, which means an equitable allocation of resources as per availability. If this doesn't happen, this is what would happen. You'd always end up in big fights, legal battles, and a lot of court cases coming up. So the 4 boxes which we classically say in terms of ethical practices, like first we have the medical indications and therapeutic interventions to evaluate and treat, which is basically beneficence and non-maleficence. That is, please don't do any harm and then do good. Then there are patient preferences. We have autonomy coming in there. Then the quality of life prior to and following treatment, where all the 4 principles, that is non-maleficence, beneficence, autonomy, and justice would come in as far as quality of life is concerned. And the 4th box is contextual features like familial factors, social factors, institutional factors, financial, which is very important in a country like ours, and certain legal factors, that are you going by the book or not in terms of the law. So this is what is justice. And if we don't do it, the patient sadly ends up in a state of total pain. And it is not only the patient who is suffering, the whole family suffers. So non-maleficence, as I said, first of all, please do not do any harm. Weigh benefit against adverse effects for every intervention. Beneficence is to produce benefit, to do good, to act in the best interest of the patient. But we need to distinguish beneficence from paternalism. Paternalism means often we have this attitude as doctors that no, don't eat this, don't eat that, don't be naughty, don't move, or go to sleep early. That is paternalism. So the patient is not a child after all, you see. Not all patients are children. So we need to distinguish beneficence from paternalism. You give your suggestions, but do not have this paternalistic approach, right? Like in this lady who had advanced cancer with multiple metastases, but she loved to smoke a hookah, and so we just let her do it. At this point of time, there's really no point in telling her not to smoke a hookah. And then autonomy. It acknowledges the patient's right to self-determination without prejudice. That is treatment only with informed consent, and it's the patient's right to decide what they want. And here, this was a patient of mine very early in my career, when I was just starting with palliative care. home visits and all those things. And this was an elderly person with oropharyngeal cancer. He couldn't swallow and he had this Ryle's tube within. And his son used to put his elderly father in a veranda, right? And this old man was in pain also, in a state of total pain. We sort of controlled that. And he would be getting feeds through the feeding tube, through the Ryle's tube. And one fine morning, his son rang me up and told me, Doctor Saab, jaldi aa jaiye. I said, what? He said, my father has just pulled out his feeding tube and he can't swallow anymore. So I rushed down to this gentleman's house, and then the first thing by reflex, what happened was I just took a tube of lignocaine jelly and, put it in his nose, and then took out a fresh feeding tube and tried to insert it in his nose. And then this old man, because of his throat cancer, he couldn't speak also, but he caught hold of my hand. And he gave me a look, and with his eyes, he made it very clear that he did not want the Ryle's tube to be put in, because that was his autonomy. And that I actually stopped in my tracks at that point of time. And at that point of time, I realized that his suffering was something beyond physical also. So he did not want to have the Ryle's tube in place. So that was his choice, that was his autonomy, and I did not put it in. And that was a decision which I have never regretted in my life. So autonomy is respecting the right to know the diagnosis, the right to know the various treatment options, the right to know the side effects of treatments, to know the benefits of treatment, to know the harm of not treating, and after knowing all this, the right to decide whether to treat or not to treat. So it is a patient's right, autonomy. But then while addressing autonomy, we should also be mindful of the decision-making capacity of the patient. That is the patient, competent enough to take a healthy decision. So we need to assess the patient's mental status. And in the UK, you have the Mental Act, where a psychiatrist would come in and assess the mental competence of a patient, whether the patient is competent enough to take decisions, right? And this is another case. This lady and her two beautiful daughters are sitting by her side, and she couldn't swallow, and I had advised her if she would like a feeding tube, and she had refused at first. And but then her daughter, who is a nurse, she intervened and she gently explained to her mother about the need of about the advantage of a feeding tube, and she actually helped in putting the feeding tube within, and her mother accepted it. So you see, there are so many ways around. You just need time, you just need explanations, you just need cooperation. Right? So there is no hard and fixed rule. You just need to know the basic principles, which are the guiding lines, which are the guiding signs, basically, and then you need to develop your own way through the maze. So here is another example. This child, this boy, he's mentally unsound, basically. His mental faculties are underdeveloped, and for him, his mother, who is sitting next to him, she is the decision maker. She is the surrogate decision maker for this mentally incompetent child. So here we have an example of a surrogate decision maker. And then there is something called presumed consent, which we take for life-saving treatments, where the whole idea is that of a beneficence, that is, we want to do good for the patient. The default is to provide life-saving treatment. So this is a presumed consent in only life-saving situations. This is totally different. And when the patient can't decide, for example, if the patient is unconscious or mentally incompetent, then a surrogate decision maker. You need to have a surrogate decision maker. So there is a hierarchy of surrogacy, where a judicially appointed guardian has the highest value, followed by the spouse, and then the adult children, parents, and so on and so forth. So where the patient can't take a decision or is incapable or incompetent of making a decision for addressing the question of autonomy, there you have a surrogate decision maker. Like in this elderly gentleman who had a stroke and had aphasia following the stroke, his daughter used to take decision making for him. So she was the surrogate decision maker. And then there are something called advance directives, which are legally binding documents that convey a patient's treatment preferences in certain circumstances. That is, today, if I want that, I can make a advance directive that tomorrow, if I have a stroke or if I fall down unconscious or if I am in a terminally ill state, then perhaps I don't want to go to ICU, or perhaps I do not want CPR if my heart stops beating, or maybe I don't want to be put on ventilatory support. So that I can jot it down right now, and that would act as my advance directive. Or I can also put down that tomorrow, if I'm unconscious and can't take decisions on my own, my wife or my son or my daughter will take decisions on my behalf, and that would be legally valid. That also I can put in. So these are advance directives. So these are also called the living wills. So in India, in March 2018, in a landmark decision, the Supreme Court in India approved passive euthanasia in the that Aruna Schonberg case, where passive euthanasia was defined as a condition where there is withdrawal of medical treatment with the deliberate intention to hasten the death of a terminally ill patient. A living will as a written document by way of which a patient can give his explicit instructions in advance about the medical treatment to be administered when he or she is terminally ill or no longer able to express informed consent. So we have the mechanisms in place, the legality in place for the living will to happen, but the legal process is still so cumbersome that it takes a lot of time to have it in place. You need a judicial magistrate of the first class to finally authenticate your living will. So what are the patient barriers to completion of advance directives? So why don't you, amongst all of you who are actually listening to this lecture, how many of you actually have advance directives in place? Have you actually ever even thought of it? Would you really like to die in some intensive care unit on a ventilator? Would you really like somebody, jumping on your chest and giving you cardiac compressions, which are so painful?
Not at all.
So what are the barriers? Why don't you even think of advance directives? Perhaps you don't even know them. We'll come to that. But what are the patient barriers to completion of advance directives? They believe that physicians would initiate the discussion, or procrastination, apathy, believe that the family should decide, believe that the family would be upset, fear of burdening family member, or discomfort with the topic. And what are the physician barriers to advance directives? Physicians believe that the patient should initiate discussion maybe, or discomfort with the topic, or time constraints, lack of knowledge of advance directives. This is very common. Or a negative attitude as such. And many a times in villages, in the areas where I practice, in rural communities, it's actually the panchayat and the big families which sit together and decide what is best for the patient, right? So our local social and cultural factors are very important. They itself decide and they would act as advance directives by themselves. But unfortunately, they don't have a legal stamp on them. But these systems are in place. And then the fourth principle is justice, which refers to equitable allocation of health resources according to need, irrespective of class, creed, race, or color. Like here, you can see here the dressing of the bed sore has been done with a banana leaf and some haldi, that is turmeric paste, has been applied. No, this I can't do in a town, in a city. like say Kolkata, people would be aghast. But then in resource poor settings where I practice, in remote villages where I have to walk maybe 10 to 12 kilometers to finally reach the village, where people hardly have anything to eat, and you can't prescribe, say you can't prescribe sucralfate ointment to them, you know, they just can't, it's out of question. They just can't get it. So for them, these things, daily changing of dressings, they can do, you know, very nicely with this. So for them, justice, this is justified in their settings. But in a city, in an urban setting, other things would be justified. So in clinical practice, in assessing which ethical principle is important, give priority to what is in the best interest of the individual patient. So treat every patient as an individual case, weigh the possible benefits against potential adverse events. And good communication, patients have a right to an honest and full explanation. Please communicate and document as well. Tell them about the prognosis of the disease, what to expect and what not to expect before even starting your chemotherapy or radiotherapy or whatever you want to put in a CVP line. You need to tell them everything about, including the adverse effects. We tell them only the good things so that, you know, they agree to whatever we are saying and then we are billed accordingly. But no, please don't do that. And giving information, telling the truth, how to tell the truth, how much to tell, right to know the diagnosis, right? So information should be given in small chunks rather than the full plate. Give it in small chunks and always check to understand whether the patient has actually understood what you're trying to tell them. And when not to communicate, where the patient is not competent or the patient refuses, or there could be other social, religious or cultural factors, you know. This was another patient of mine, very young guy who was studying in Bangalore, anal carcinoma. And then, but we gave him the autonomy, and then he actually would tell his choices, what he wanted and what he did not want. Withholding or withdrawing treatment, there is no ethic or in any culture or religion which says that a terminally ill patient must be kept alive by any means. No. Death is a natural end. So withdrawing a treatment is an act. Withholding treatment is an omission. So there is no moral distinction between withholding and withdrawing treatment. We need to understand that. Right? So ethically and legally, there is no difference between withholding and withdrawing treatment. The American Medical Association Code of Medical Ethics 2009 says very clearly that physicians are not ethically obligated to deliver care that in their best professional judgment will not have a reasonable chance of benefiting their patients. So futile therapy is out of questions. But why do doctors go for futile treatment? Because physicians are oriented to curative treatment only. They are not trained in palliative care. We have been taught that death is the enemy. We need to defeat death at any cost. But no, my dear friends, death is physiology. We need to understand that. Death is not a pathology. Death is physiology. Fear of being blamed for suboptimal treatment, absence of ethical and legal guidelines for end of life, self-determination of patients regarding end-of-life care issues are not well articulated in Indian Constitution, although things are coming up now. So there are certain legal provisions like IPC Section 88, not offering life-prolonging and life-sustaining measures like treatments considered futile, like CPR in a terminally ill patient, treatment whose burdens and risks greatly outweigh the benefits, like ventilating a patient with more, say, MND, treatments which are not considered to further the patient's medical good, like tracheostomy, gastrostomy in head and neck malignancies, and so on and so forth. So these are very controversial things, and then you need to just not focus on any one principle. You need to consider the patient as a whole. What are the resources available? What are the finances available? What are the patient's wishes, the autonomy, communication, disclosure, so many other things, right? And euthanasia definitely is out. It's not legalized in India. So we'll not go into that. But remember that withholding or withdrawing of futile therapy from the terminally ill is not euthanasia, as the intention is to assist natural death and not to deliberately terminate life. And then there is something called the double effect, where suppose you give a drug, medications given for relief of distressing symptoms may occasionally hasten the moment of death. Say you give high doses of sedatives, or say you give pregabalin for neuropathic pain, and or, the patient goes into deep sedation, or even as a drug interaction with other drugs, the patient has respiratory arrest and dies. But here, this is not euthanasia. This is what you call a double effect. So you were giving the treatment for relieving of a particular distressing symptom, but as a side effect, the patient died. So this is a negative, this is a double effect, and its legal provision is covered under IPC section 81. And then finally, justice. So we need to differentiate between need and want. Need is something without which one will come to be in a state which is contrary to one's most important interest, and want is those things one would simply like or desire. And then you need to also focus on what resources you have, resource allocation. And with that, I think I'll end my presentation. And this is our hospice at Koshish. This is in rural Jharkhand. And thank you. Thank you for listening.
Thank you very much, Dr. Abhijit. It was an excellent talk covering this tricky area of ethics in palliative care, or for that matter, medicine as a whole. We will take questions at the end. I'm sure there will be many. So I now request Dr. Sucharita Chakravarti to introduce our last speaker, Dr. Suparna Ganguly. He has told me that he will introduce himself in his talk. So Sucharita, could you just please take the responsibility of giving a short introduction?
Good afternoon, everybody. And I would like to invite Dr. Suparna Ganguly to give his talk on early neuro ICU rehabilitation, successes and challenges. He is the Director, Department of Neurorehabilitation, Institute of Neurosciences, Kolkata. Suparna, please.
Thank you, Dr. Sucharita, and thank you, Dr. Indrajit Ghosh, for inviting me for this talk. Now, dear seniors and colleagues, I have been asked to speak on a topic which is very close to my heart. I strongly believe that the functional outcome of any rehabilitation program depends on how early it begins. Now, before speaking on the topic, I would quickly like to introduce myself and our neurorehab department. So I completed my MD in Physical Medicine and Rehabilitation from the Institute of Postgraduate Medical Education and Research, Kolkata. Then I worked for a short stint at St. John's, Bangalore. Worked as an assistant professor at the Department of Physical Medicine and Rehabilitation, Christian Medical College and Hospital, Vellore. Then I went to Australia, gathered experience, came back to the city of joy, Kolkata, and started working at the Institute of Neurosciences, Kolkata since March 2015, under the able leadership of our beloved chairman, Professor Dr. R.P. Shengupta, OBE. So this is the place from where I started my journey at INK. Now, with the increasing number of patients, we had to shift our OPD services to INK Annex in 2019. A dedicated neurorehab ward was also inaugurated in the year 2018. With further increase in the patient population, we are on the verge of starting a 55-bedded state-of-the-art rehabilitation center at Behala, which is almost 45 minutes from INK. So our dream is basically to have an INK Neurorehabilitation Institute. Our present team strength is 70, and we are blessed to have 3 rehabilitation medicine consultants, and this is our healing team. So what is neurorehabilitation? The general awareness about rehabilitation is basically it's a tail malish or massage or physiotherapy or even sending the patient to a de-addiction center. But I guess rehab is much more than that. Neurorehabilitation is a patient-centered program carried out by a team of expert professionals led by a rehabilitation medicine consultant. At INK, we have a 24/7 rehab services. Now, what are the rehabilitation settings? Early rehabilitation. Here we start with our with my main topic of discussion. So early mobilization and discharge planning, as evidence shows, beginning the first day of intensive care unit hospitalization, and while the patient is still on ventilator, it actually shortens the length of stay and improves functional outcomes. So early rehabilitation paves the way for seamless transition to post-acute care. There's a good evidence showing benefit from early intensive physio as well as occupational therapy in the hospital for stroke patients, traumatic brain injury patients, and for patients with orthopedic complications. Definitely, early rehabilitation significantly reduces the length of stay and improves physical functioning in patients. Now, early rehabilitation, post-acute, all these in terms facilitates early discharge and outpatient-based rehabilitation. We also have launched our outreach services, which is the reaching out at home, continuing rehabilitation services at home after discharge. Thanks to COVID-19, we have been able to launch our long-cherished tele-rehab services. This allows patients to avail rehabilitation services from home itself. So what is early rehabilitation? It begins in the emergency within 40 to 72 hours of inpatient admission, or as soon as the patient is hemodynamically stable. So what are the components? Optimization of medical management, care of all the tubes, proper positioning, chest physiotherapy, mobilization, early orthosis to maintain muscle length. This is a very important aspect of rehabilitation. Early detection of complications like neglect and apraxias, speech and swallowing pathologist evaluation, assessment and cognitive rehabilitation by a rehabilitation psychologist. So these are very important points on which the whole rehabilitation program depends and its outcome. So what are the advantages of early rehabilitation? It decreases mechanical ventilation and intensive therapy unit stay, decreased hospital length of stay, and hence increased patient turnover, decreases complications, increases functional independence at discharge, and decreases wastage of resources and cost to patient. There was this study in the late 1980s where David Off looked at the appropriateness of elective referrals to physiatry and physiotherapy from different acute clinical services over a 1 year period. Interestingly, they found that 47% of patients referred for physiotherapy alone actually needed a physiatric consultation, because the role of a physiatrist or a rehab medicine consultant is just not formulating a plan, but neuropharmacological management, liaising with the acute care colleagues, planning a proper rehabilitation program, executing ideas, and timely discharge and follow-up. I strongly believe rehabilitation is the portal of exit. I have seen in my own experience that problems which tend to be missed out can actually be picked up by the rehabilitation team and addressed appropriately and early. So, there are a lot of myths and facts. Few of them I'm just stating here. Early rehabilitation is too early. There is no life after stroke. Spinal cord injury means you will never be able to move and work again. But I will be running you through a few patients of ours to establish the importance of early rehabilitation. So, sorry, SM, 18-year-old boy diagnosed as Guillain-Barré syndrome with all the signs and symptoms which were possible. He was progressively quadriplegic, dyspneic, dysarthric, dysphagic, and in extreme pain while he was admitted under a neurologist. When he was transferred under our care, we had lots of challenges. The first challenge was, of course, the challenge of prolonged ventilation. How could we decannulate him? What we do for other patients, we did the same for him. A well-coordinated, physiatrist-supported ITU rehab program was started. We have an excellent nursing team at INK. They took care of the skin, and our rehab team took care of the chest, the limbs, the muscles. Orthosis were also prescribed, and the care of the tubes like the endotracheal catheter and the nasogastric tube were also taken care of appropriately. The next challenge was, because he was on nasogastric tube for a prolonged period of time, we were really concerned about his adequate nutrition. So here comes the role of the speech, language, and the swallowing pathologists. They examine him as early as possible. We also refer the patients, if needed, for flexible endoscopy, whether the patient is still safe to be continued on a NG tube, or we should be inserting a PEG tube. This is probably one of the biggest challenges that we face initially in the rehabilitation process. So, dysphagia management, and a very important tool in rehabilitation program. Swallowing should ideally be screened at least within 24 hours of admission. Dysphagia screening protocol includes water intake tests of 10 teaspoons through oral and lingual motor test. Patients failing this test should be referred for fees as early as possible. All these paves the way for a proper post-acute care, physiotherapy, occupational therapy. Being with us for so long, he needed spiritual support as well as leisure activities. After 9 months, SM was discharged and he could fulfill his dream of beating the drums during the Durga Puja, which is the biggest religious festival in this part of the country. Our next patient, PK, a 24-year-old gentleman, had suffered a head injury with a right frontoparietal subdural hemorrhage, polytrauma, and an incomplete spinal cord injury. On transfer to neurorehabilitation, his GCS was E1-VT-M3. He had multiple skin abrasions and an exposed tendon of left foot, which was missed out initially, which was picked up only once he was transferred under our care. So the highlights of successful rehabilitation. We have to understand, crux is to take a risk in spite of negative prognostic factors. We have to prioritize the line of action in a polytrauma patient, manage his pain. A decision of early plastic surgery was taken in his case, and a K wiring of the left foot with skin grafting is done. PK is just on the left of our screen. He is now absolutely fine. Mr. AS, a 52-year-old gentleman, assault, polytrauma, a right frontotemporal hemorrhage, subdural, and a subarachnoid hemorrhage. His highlights of early rehabilitation. The most important points were early nutritional management with PEG tube insertion, coma arousal program, and management of visuospatial perception deficit, like neglect. We need to insert a PEG tube if there is no improvement in swallowing, even after 2 to 3 weeks, just to prevent the risk of aspiration-related complications. PEG tube insertion is a safe and a common way to ensure proper nutritional intake for patients whose needs are not met otherwise. We started with the coma arousal program. There are a number of processes to help patients to improve, to come out of coma, out of which sensory stimulation, which is done by our expert professionals in our team, pharmacological management, music therapy, right median nerve stimulation. These are things which we do at our institute. Hyperbaric oxygen therapy, dorsal stimulation, repetitive transmagnetic stimulation. I have idea about it, but I do not have any first-hand experience on these. So what is coma stimulation? The main goals are to promote arousal and appropriate patterns of movement and interaction with the environment. Contraindication we have to keep in mind: absolute contraindication, elevated ICP or any seizure episodes. Relative contraindication with tracheostomy. The patient reaction must be very carefully monitored. So what are the stimuli that the professionals give to arouse the patient? They are the auditory stimuli, the olfactory stimuli, visual, tactile, gustatory, kinesthetic. It has to be very carefully patient tailored. It has to be individualized, and frequency usually between 3 to 4 times a day. Visual spatial dysfunction like neglect has to be picked up as early as possible, because it resolves to some degree over time. It severely interferes with rehabilitation, predicts a poor outcome if no recovery after 6 months. Treatment involves educating the patient and the relatives. Using neglect classes, the patient on our screen has one, and RTMS. So early recognition of visuospatial inattention may be targeted rehabilitating interventions to improve the long-term functional outcomes. So here is our AS, who has been promoted to the position of ACP in the last few months. Here is our next patient, Mrs. BB, a 45-year-old female, who had a ACOM aneurysm which bled, had a subarachnoid hemorrhage, coiled and clipped, had a VP shunt. On transfer to rehab, she was E1 VT M3. These are the CT scans of the patient. So it's in Bengali, probably people might not understand, but what it says is after 4 months in comatose state, BB wakes up through music therapy. So she had all the conventional processes involved with her coma stimulation along with music therapy. As we all know, musical parameters, example tempo, rhythm, are manipulated accordingly, and it changes in patient's attention or arousal. Music stimulation activates the superior temporal gyri in healthy adults, which we have probably extrapolated to our patients. It helps in improvement in arousal and cognition. This slide is very interesting because what we are using now as music therapy for our patients was actually being used in Charaka Samhita in ancient times. So everything is early, even the music therapy. This helps, probably supplements to the other programs that we use for coma arousal. Our next patient, AC, a 39-year-old gentleman, was airlifted from Germany on tracheostomy tube in the ITU, diagnosed as C2 Asia C tetraplegia with a C1 C2 fracture. He had a 400 kilo object which hit his neck. When on admission, his muscle strength was 0/5. AC is now almost back to his near normal state. Our next patient, AS, diagnosed with a left basal ganglia bleed. Through early rehabilitation, he is now independent and back to his IT job. So, the stories of all these patients definitely confirms that there is a shift in paradigm. As there is increased life expectancy over the years, there's a change in people's attitude and improved awareness about quality of life. Patients and relatives seek expert rehabilitation, advice, and care. So now rehab is not luxury. It has actually become a necessity. Don't we have challenges? Yes, we do. For a proper neurorehabilitation program, we need a fully equipped rehab setup. We need an expert multidisciplinary team. We need proper resources, financial as well as in terms of personnel. Before concluding my talk, I would like to just touch upon the recent advances which further emphasizes the importance of early rehabilitation. Hyperbaric oxygen therapy. Does it really improve the survival of and quality of life in patients with traumatic brain injury? Cochrane says it may reduce the risk of death and improve the final DCS, but there is no evidence that survivors have a good outcome. Virtual reality may be beneficial in improving upper limb function only when used as an adjunct to usual care. Despite evidence from a small number of individuals, EMG biofeedback plus standard therapy is the gold standard of treatment in motor power and recovering functional and function and gait. Cochrane's evidence says that. Robotics, electromechanical and robot assistant arm training improves activities of daily living, arm function and arm muscle strength. It might improve these functions, which again is an Cochrane-based evidence. So What are the take-home messages from my short speech? It's early, preferably from day one. Rehabilitation is the key word to successful outcome. No rehabilitation potential. This has been said by a lot of physicians, but it is actually a myth. Every patient deserves a chance, and every patient will benefit from rehabilitation. That is the fact. Still, conventional therapy is the cornerstone of rehabilitation. However, combination of skill and technology gives a better outcome. At INK, we are actually blessed to have an expert team to provide holistic neurorehabilitation services. We are also in the process of developing indigenous VR system and robotic technology with the collaboration with IITs to further augment the process of early neurorehabilitation. At the end, a family reuniting after early holistic rehabilitation. That is what we as a physician and the family wants absolutely. So, past can't be changed. Let us change our life today with early rehabilitation. Thank you.
Thank you, Dr. Ganguly, for an excellent talk and hammering the fact again that rehab is not just tail malish. It is something more important and very, very vital to the ultimate outcome of the patient. Now, also thank you for finishing absolutely on time. I think we can take a few questions. There are some questions on the chat box, so I'll just read them. The first question is from Professor Ramesh from Hans. He asks, is advanced directives legal in India? Maybe Dr. Roop sir can answer this.
Yes, so they are legal in India. There is, that has been very clearly put out by the 2018 Common Cause judgment. The only thing is that the process as of now to have them make them enforceable requires it to be countersigned by a judicial magistrate first class. So if anybody is interested, I recommend that you either look at the IAPC website, Indian Association of Palliative Care website, or Pallium India website, download the form, the Advanced Medical Directive that we have drafted and which is available for free download. Fill it up. You may need, well, depending on, obviously doctors should not, but you can then go on to ask a lawyer to help you to get a judicial magistrate first class to have it signed out. We are trying to get this broad-based in the sense we will try to get at least one High Court bench to give directions to all the JMFCs in Maharashtra to pass this order. But then it will become necessary for everybody to do this individually. So as of now, when somebody goes to a magistrate with this, they're very likely to tell you that we have no knowledge of this. But it is being done. And it's important for us to make it a movement so that more people do it.
Right. Thank you, sir, for the answer. There's another question from Dr. Sri Ganesh from Nimhans. He asks how to balance ethical and legal aspects during communication with patient and or family. For example, ventilating a patient for life versus making a ventilator bed available for a salvageable patient. So, Dr. Abhijit, sir, can you take this question?
Yeah, see, there can be no fixed pathway in this. As I said, that it becomes a conglomeration of various factors involved out here. Various principles would come into play. And one thing we should keep in mind that withholding of therapy is much easier than withdrawing of a therapy which is once instituted. So we need to keep in factors the local settings, the expectations, the finances,
and it has to be a holistic thing. So this question just can't be answered in one way. It has to be situation based. It has to be logistic based. So many other, and definitely there can be bureaucratic and administrative issues which can also have a influence on your decision making. What is important is to document everything, preferably also have a video documentation of all these things. So that way, I think a larger amount of clarity can be maintained. Thank you.
Thank you, sir, for pointing out the fact that there is no alternative to a good communication and as well as documentation of that good communication. The other question is from Arvind sir from All India Institute. He wants to know how median nerve stimulation works. So I think Dr. Suparno can take this question. Dr. Ganguly, you have to unmute yourself.
Sorry. So actually, a very few studies have been done on this, and in India there are very few centers which actually does this median nerve stimulation. We have just started both treatment as well as research on this right median nerve stimulation. So actually, median nerve is a portal to interact with the injured comatose brain. Peripheral nerve electrical stimulation has a central nervous system effect. Now it has been shown 2 to 8 weeks or 2 to 4 weeks to be precise of right median nerve stimulation. It hastens the awakening from deep coma by increasing the dopamine levels. Now, these have been done actually on the rats. A few studies have been done in India, and one of them definitely have been done in CMC Vellore. One of our registers did it, and so their results are like, I won't say it is very heartening, but they're definitely, the outcome is not bad as we would have expected. So I think we are doing a study on this right now, and probably in the next few months we should be able to come up with a robust data, because our number of patients at this institute is quite a large number. So we have just started it. The basic idea is to increase the dopamine levels in the patient with a comatose brain.
Thank you, Dr. Ganguly. There are no such, not any questions anymore in the chat box. So I shall ask the chairpersons if you have any questions. Otherwise, we'll close the session.
I just want a small question.
Please carry on.
I just wanted to ask, sometimes when we go and see, though the patient's cognitive ability, everything is okay, but they say that, don't tell the patient that, oh, you are undergoing surgery, but I feel strongly that patient had to be informed, and so that, the cooperation is better. Sometimes in that situation, how do you react? Do you tell them that you are undergoing a surgery and you will post-operatively, you will go through that? And though he's able to understand, but the relatives will say that, no, you don't do it.
Yeah, I think Rama madam, you're asking something in the lines of what is known as collusion. So I'll ask Roop to take this question, maybe. How to prevent collusion?
Yeah, so you actually begin a discussion. Of course, Abhijit is the expert on that. Palliative care physicians are perpetually dealing with collusion with families. In fact, the biggest issue in neurology, of course, you still have the excuse that sometimes patients may not have a full cognitive understanding. But when you have to deal with families wanting patients not to be told about their cancer, and especially when you have to carry out a long spell of treatment, you need to ask them, find out why they want not to tell the patient. Do they understand the consequences of the patient not being aware? In patients, in my field, especially when the patient has cognitive ability at the time that we are communicating and is likely to lose it, I try to explain to them what the consequences of that will be, that the patient will not be able to communicate any further decisions whatsoever. And it takes a certain amount of effort on our part. I think the bigger issue typically is that because we as doctors are not used to communicating in difficult situations, we are more than happy to go along with this collusion and to drop the ball there. And I think that is wrong. We have to take this effort. Dr. Dam?
Yes, Dr. Abhijit, could you please throw some more light on this issue, on the issue of collusion?
I completely agree with Dr. Goshami, and this is basically an issue of collusion which is coming up, and this definitely, as Dr. Goshami has elaborately explained, that is the way to go about it. And here again, there can be no hard and fast gateway. It's just a matter of negotiation and going the way forward. Thank you.
Thank you, sir. So I think because there is no end to discussing this particular specialty of neuropalliative care and neuro rehab, and we can go on. And with the permission of the chairpersons, may I just close the session?
Thank you. Thank you.
Yeah. I thank all the chairpersons and delegates who and we'll close for the day. Thank you.
Thank you so much. Thank you.
Bye.
Hello, ma'am.
Hello, can you hear me?
Yes, ma'am.
Yes, I shall be moderating the session.
Yes, ma'am.
Am I audible?
Yes, ma'am, you're audible.
Okay, thank you.
We'll start at 2.
Okay, fine. Hello, am I audible to everybody?
Yes. Good afternoon.
Good afternoon. Very good afternoon, everybody. Now we are going to begin the first post-on session of day 2 of our conference. Some very interesting topics will be discussed here in this session. To chair the session, I would like to welcome Dr. Himangi Karnik ma'am, Dr. Anil Parekh sir, and Dr. Devendra Gupta sir on the dais. A few words on the members of the chair. Dr. Himangi Karnik ma'am, she is a professor at LTM Medical College in Mumbai. Her areas of interest are neuroanesthesia, neurocritical care, trauma anesthesia, and monitoring. She was a visiting professor at Stanford University Hospital in USA in 2000. She is the editor of the Practical Approach to Anesthesia for Emergency Surgery. She has over 40 publications and about 9 chapters in various books to her name, and she is in the editorial committee of the Journal of Neuroanesthesia and Critical Care. She is a recipient of the Har Gobind Foundation Medical Fellowship Award in 2000. Welcome, ma'am. We have Dr. Anil Parekh sir with us today. He's a consultant neuroanesthesiologist and head of the Department of Anesthesiology at Global Hospital, Mumbai. He was a past president of ISNACC and the founder secretary of the Association of Neuroanesthesiology and Critical Care, Mumbai. He is a recipient of the Literary Excellence Award 2017 for his contribution in the field of medicine by Bharat Nirman Foundation and has featured 4 times in the list of top doctors of Mumbai, a survey conducted by India Today and Outlook magazine. A very warm welcome, sir. Dr. Devendra Gupta, sir. He is a professor in the Department of Anesthesiology, SGPGI Lucknow. His area of interest being neuroanesthesiology. He has over 70 international publications and 8 chapters in various works to his name. He also has 2 patents to his name. A very warm welcome to all our chairpersons. And now I shall request Dr. Hemangi Karnik ma'am to introduce our first speaker for the session, Dr. Massimo Lampati, sir. Over to you, ma'am.
Good afternoon, all. First of all, I congratulate organizers of the ISNACC 2022 for this wonderful conference. I'm honored to introduce Dr. Massimo Lampati. He is a clinical professor and chair of anesthesiology at Institute of Cleveland Clinic, Abu Dhabi. Before that, he was working at National Neurological Institute, Vesta, Milan, Italy. His main fields of research are point-of-care ultrasound, depth of anesthesia, and procedural sedation. He has contributed as reviewer for many international journals and is associate editor of prestigious British Journal of Anesthesia and Journal of Vascular Access. Today, he will be talking about a very important topic of PEEG in critically ill patients. Welcome, sir.
Good morning. My name is Massimo Lamperti. I'm the chair of the Anesthesiology Institute in Cleveland Clinic, Abu Dhabi, and professor of anesthesiology at the Cleveland Clinic Lerner College of Medicine. Today, it's a pleasure to be invited to the ISNACC conference and to present you some evidence on the use of processed EEG in the monitoring of critically ill patients. I have some conflict of interest because I am one of the co-authors of the international consensus on the use of PEEG monitoring in ICU patients that is going to be published soon in a peer-reviewed journal. And I thank this ISNACC for the invitation. First of all, we will talk today about the different kind of EEGs that we can use in critically ill patients, how they work, how the sedation is affecting the EEG, especially when we are involved in critically ill patients in ICU, and how to use EEG in critically ill patients admitted to ICU. Finally, we will mention something regarding the education on the use of the EEG for non-neurologists. So there are some definitions first regarding the terminology regarding processed EEG, quantitative EEG, and continuous EEG. The processed EEG is the result of the mathematical and the statistical modeling that is applied to the raw EEG and is usually used during anesthesia in order to understand what is the level of the depth of anesthesia, or in other areas like in critical care when we are sedating a patient under mechanical ventilation. The processed EEG is involving EEG features and is extracting this data in order to give a final index that usually dimensionless and that is correlated with a range of different sedation and consciousness level. Otherwise, the PEEG is using different algorithms according to the time domain and the frequency domain analysis in order to transform the EEG raw data in a signal and in a number that usually is considered for deep, moderate, or light sedation in both anesthetized and sedated patients. There are different kinds of processed EEG monitors that came out in the different tiers, and this is an example of those monitors who are providing many indexes that have been usually validated according to different kinds of sedative agents performed and used during the analysis of the data. While the quantitative EEG is more a mathematical processing of a digitally recorded EEG that is providing and transforming the EEG in a quantitative measure, like, for example, the power analysis of the different EEG rows, Or, for example, the spectral edge, that is the percentage of EEG waves that are under a certain range, a certain percentage in the EEG recording. Another kind of commonly used EEG is the continuous EEG. This involves the monitoring of a standard 21 electrode or even a simplified one using 8 to 10 electrodes in the montage of multiple channels. And this technique is allowing a continuous assessment of the cerebral cortical activity with good spatial and excellent temporal resolution. With the quantitative EEG, we can even have continuous EEG, and so in this way we can analyze the spectrum of the EEG waves that are continuously monitored in the critical ill patients. This is the typical example of the classic cup electrodes that are mounted on over the head of the patient. How the EEG works? So we are to rely on the traditional 10-20 system where the nasion and the inion are considered the reference, and the left and the right of the scalp are considered with different numbers and labels and are providing a reference standard. Say that there are different patterns of the EEG according to the level of sedation till when the patient is going to an unconscious level. And after the patient has lost the level of consciousness, we can go even to deep level of sedation up to a level of burst of passion or even isoelectric activity. See that different levels of EEG waves are corresponding to different level of sedation. And according to the different frequency bands in the spectrum, we can have slow delta, theta alpha, beta gamma waves, according to the frequency range of each of these waves in per second. And so the visualization and the analysis of this unprocessed EEG is a form of time domain analysis. So reading the frequencies and the amplitude from the unprocessed EEG is not easily and is really representing the most challenging part of analyzing an EEG raw during the continuous EEG monitoring. For this reason, the technology has provided a way to divide the unprocessed EEG waveform in the different components and with the different EEG waves. And according to the different components, we are able to create a spectrum of EEG recordings in a time domain, and then create not only a compressed spectral array, but a spectrogram, so a density spectral array that is showing us during the time what is the density of each spectrum and of each wave of the electroencephalogram. For this reason, we can have different waves that are corresponding to a spectral edge frequency that usually is the range of waves that are under, of which 50% are under this spectrum, and a median frequency that is representing the median frequency of the EEG waves in that time. What is the correlation between sedative drugs and EEG? All the sedative drugs are mainly interfering with the EEG waves. The first example was created in 1937, where there was the first study by injecting pentobarbital sodium in a patient, and we could see that there was a slowing in terms of frequency and amplitude of the EEG waves, going from a fast and with a very small amplitude EEG to a slow amplitude and slow frequency EEG waves. And you can see that not only during the injection of pentobarbital, so a drug, but in another example, when there was an alcoholic intoxication, the patient was initially unresponsive, and as soon as there was the recovery of the consciousness after 11 hours, the patient was recovering EEG waves and becoming more frequent with an amplitude that was less than when the patient was unresponsive and drunk. Going from drug intoxication to drug pharmacology and interaction with EEG, we can see that different drugs, sedative drugs, or inhaled agents used for anesthesia have different interactions with the spectrum of the EEG. Not only different drugs, but even different ages have a different spectrum. In a paper from Purdon and colleagues in 2015, Purdon discovered that there was a reduction of the alpha waves according to the age of the patient. Why this? Because there is a reduction in the brain volume when the patient is aging. There is a cortical thinning and a decrease in the, not only in the neuron numbers, but even in the interaction between the white matters and the rest of the brain. So in this case, we have a reduction in the neurotransmission that is happening with the age. And knowing that, we can see that different ages have different patterns, different spectrum, delivering the same amount of drug. And even between the same patient with the same age, we can have different patterns according to the different interaction that this patient has. Not only, but lowering the power of the alpha waves with the age can even be related to an increased risk of post-operative or even ICU risk of delirium and cognitive disease. Say that there are some issues when we are creating a reduction in the cortical activity in the so-called burst suppression. The burst suppression is mainly, or suppression burst, is a pattern of discontinuous EEG. What happens is that we have period of marked suppression or even isoelectric activity, like a cardiac arrest, that are alternating with bursts of normal activity with or even without embedded epileptiform features. Unluckily, this burst suppression activity is very common when we have a patient after cardiac arrest or when you have even a patient hypoxic or ischemic. And these are sometimes transition periods that are later developing to alpha or theta coma, and then in the worst scenario to electrical silence or electrocerebral inactivity or death. So this is an example of burst suppression where we have periods of silence, alternating period of a small activity, very, very slow in terms of amplitude and frequency. And unluckily, these are very common in our ICU patients. One need to monitor the EEG in the ICU is that there are many studies showing, for example, that after cardiac arrest, we have very high correlation with burst suppression. And in a study that has been done in 2015 by Sivarayu, 100% with burst suppression had a bad outcome after the occurrence of burst suppression and cardiac arrest. There was only one case reported that reported a better outcome, but in that case reported there was an effect of an induced sedation with propofol and phenobarbital that was confounding the factor. So again, this is an example of vasopression in a very young patient following cardiac arrest, where the bursts are separated by interburst periods of suppression. And in this case, the patient had a negative outcome. So an example of interaction between EEG and patients admitted in ICU is the fact that many encephalopathies are creating a cerebral dysfunction. And this includes hepatic and renal failure, sepsis, intoxication from toxins, TBI, and hypoxic encephalopathies, for example, strokes. While the EEG is not giving us the specific etiology, but is very sensitive to let us know if the patient brain is suffering. And in this case, we can even create a possible treatment in order to avoid that this patient will continue having a cerebral dysfunction. For example, in this case, this a continuous EEG recording of a stimulus-induced periodic ictal discharges. And we can see that after an anoxic injury in this patient who is deeply comatose, we still have discharges. And in this case, we can see that there is a sufferance that is increasing the epileptic form activity of the patient and is inducing a stress in patient's brain. Further support on the use of continuous EEG has been recommended by the American Society of Clinical Neurophysiological Monitoring and the European Society of Intensive Care. Those guidelines were supporting the use of continuous EEG. Despite that, the use of continuous EEG is very resource intense and is requiring real-time expert interpretation, not only a real-time neurophysiological presence, and which can sometimes not always be present. For this reason, there is in the recent past a consistent use of process EEG monitors that were used to improve and understand what was the level of sedation, and even there was the presence of reduced electrical activity in the brain of our critically ill patient. One example of use of process EEG as a predictor of post-coma delirium in mechanically ventilated patients was done by Watson in 2014. The study was measuring with process EEG the presence of burst suppression that was induced by sedation, mainly with propofol, in patients ventilated for different reasons. And they measured the prevalence of burst suppression in terms of time resolution. And they found that the presence of burst suppression was highly related with the incidence not only of post-coma delirium, but of deep sedation delirium, because the higher was the level of sedation, the higher was the incidence of post-sedation delirium. This suggested the authors to reduce the level of sedation when the patient were mechanically ventilated, or to use other agents, not propofol, that could avoid the incidence of burst suppression in mechanically ventilated patients. One further example of burst suppression is related to the late stages of sepsis, where in patients with sepsis we can have a metabolic and even hypoxic encephalopathy that is highly related with a poor prognosis. For this reason, it's quite important to understand if apart the different organ dysfunction. We still have even a cerebral dysfunction that can be related to a negative outcome or even a poor neurological outcome when the patient is withdrawn from mechanical ventilation or from vasopressors. This is an example, for example, of anoxic encephalopathy in a patient with burst suppression with severe sepsis, and we can see that is representing again the usual pattern of the burst suppression. But most recently, focusing on the link between sedation and post-operative mortality, and so the presence of burst suppression, a study that was done on patients undergoing mechanical ventilation in ICU. The study was done on adult patients, and they were trying to understand the connection between the iatrogenic use of propofol, and so the induction of burst suppression, and the mortality as the primary outcome. So in this case, the connection between burst suppression, propofol, and mortality was not found. And the authors found that burst suppression is the factor that is contributing to mortality, but not the combination between the overdose of propofol, the burst suppression, and mortality. So in this case, the first time that burst suppression per se is demonstrated as a factor that is impacting the mortality of the ICU patients. And for this reason is a factor that we need to understand in the future, because we need to understand if deep sedation can be considered a positive or negative factor impacting the outcome of the patient. Lastly, so we have to talk about education. So because we have different tools that are from intermittent EEG that usually performed by neurologists to continuous EEG that is commonly used in the ICU patients, and or even process EEG that are commonly used monitored in anesthesia, but not so commonly used in the ICU patients. There are two studies showing what was the impact of the education EEG in non-neurologists. The first one is a meta-analysis that was done with 29 studies. 15 of them were focusing on the use of process EEG, and in 24 of these, the education was shorter than 1 day of duration, with the didactic material that were mainly focused to improve the acknowledge of the participants that were not only physicians, but even critical care nurses, in order to let them understand what was the presence of other pattern of raw EEG. And in this case, this meta-analysis found that there was an agreement that was moderate with the presence of seizures when the EEG was compared with an opinion by an expert. So in this case, this is the first demonstration that even with the shorter education period of training, we can still have a good result in having non-neurologists recognizing pathophysiological patterns of the EEG rules, both when a continuous EEG or a process EEG is used. The second study that I want to show you is a study that is a sub-analysis of the ENGAGE study that was performed 3 years ago, in which the sub-study was testing the hypothesis that the EEG-guided anesthesia could prevent post-operative delirium. But mainly the focus was to have a 35-minute training session that was summarizing typical EEG changes when volatile-based anesthesia was used. And the participants were performing a pre- and post-educational test in order to understand their proficiency recognizing 2 deep level of anesthesia. there were 71 participants. Some of them, a minimal part, had previous anesthetic EG interpretation training. And after the training, the other 58 participants without prior training had an improved outcome in identifying EEG waveforms corresponding to the different depth of anesthesia. And the study showed that they were able to recognize when the anesthetic depth was too deep, and even when there was a discordancy between the index that was provided and the EEG rules. And in this case is again one demonstration that even a very short training period can allow non-neurologists and to understand what is the level of sedation just provided by the interpretation of the raw EEG that is in the monitor. So the EEG monitoring is allowing us many things. First, to titrate sedation, and this is quite commonly used in the OR, but can even be useful in the critically ill patients, mainly to avoid burst suppression. And this is one of the main features that we are having now with both continuous G and processed G. And with the detection of that, we can even understand what are or if we have neurological impairments in critically ill patients. And as I showed just now, with even minimal training, we can achieve good results and avoid patients to be in burst suppression or to receive oversedation. There are still some points, and this is the research agenda that we have to do. We still have to understand if the burst suppression is a problem or is a problem only in severely ill patients, and for how long we should tolerate burst suppression. If we can tolerate a burst suppression higher than 0 for a short period of time, or we have to intervene to avoid that the burst suppression will happen. And we need even to understand if the processed EEG that is now very commonly used in some areas like in the operating room can be considered useful as the continuous EEG that is more complex even to mount on the patient. And finally, we need to understand which kind of training we have to use, if we need a supervised training by a neurologist or should be considered expert neurointensivists just as trainers for this kind of monitoring. So these are the open questions, and I hope it will be food for thoughts for you in the near future. So thank you very much, and these are my contacts, and I hope you will have a very nice conference. Thank you very much.
Thank you, sir. Thank you so much for your talk on processed EEG. Now I would like to request Dr. Anil Parikh, sir, to introduce our second speaker for the session, Dr. Indranil Chakraborty, sir. Over to you, Parikh, sir.
Good afternoon, everyone, and good afternoon, my chair colleagues, Dr. Hemangi and Dr. Devendra. I'm happy to introduce Dr. Indranil Chakraborty, who is a professor in anesthesiology and tenured clinical educator. He's a director of Division of Neuroanesthesiology and Department of Anesthesiology, College of Medicine, and University of Arkansas of Medical Sciences, Arkansas. And he's in the Society of Neuroanesthesia and Critical Care, SNACC. He's a member of the Clinical Affairs Committee. He's a member in the Training and Engagement Committee, and he's also the member of Diversity and Inclusion Committee. So I present to you all Dr. Indranil Chakraborty, who is really speaking on my favorite topic, that is awake craniotomy, challenges and the solution. Dr. Indranil, please.
My name is Indranil Chakraborty. I'm professor of anesthesiology at University of Arkansas for Medical Sciences, and I direct the Neuroanesthesia division in my university. I want to thank Dr. Indranil Ghosh and other leadership members and all members of ISNACC 2022 for giving me this wonderful opportunity to talk to you. And my topic today is awake craniotomy, challenges and solutions. I do not have any disclosures or disclaimers at this point. And the objectives of today's talk and outline are very simple. I will talk about the history, the basic principles, and the technique of awake craniotomy. Then I will go over briefly some of the literature that is currently available to support the technique, and also talk about some of the current challenges and potential solutions. From the very beginning, awake craniotomy actually came into existence for taking care of epilepsy patients and occasionally patients with severe psychiatric conditions such as schizophrenia. Historically, the patients were treated for seizures by trepanation of the skull, and the first documented awake craniotomy in modern times was in the 17th century, again to treat epilepsy. I sincerely apologize for the poor quality of this painting, but this actually depicts the process of trepanation or awake craniotomy in a patient with what they used to be called stone of madness, or what was possibly a seizure disorder. And this is from the 14th and 15th century. Another painting which depicts a similar process from the 16th century, again, a possible awake craniotomy early on. A third diagram or a third painting or a sketch depicting similar process in the 16th century. It was in 1874 that Bartholo published a report wherein he used a defect in the skull of a patient and used that to place electrodes and stimulate for brain mapping in human beings. And in 1920s, Wilder Penfield was the pioneer who worked extensively on awake craniotomy, and this was to map cortical epileptic focus and surgically excise them. He also had some tumor work using awake craniotomy as well. So it was in the 1920s that the modern awake craniotomy came into practice. And we have come a long way, ladies and gentlemen. This is 2018, where a famous jazz guitarist, Musa Manzini, is undergoing awake craniotomy while playing his guitar. So we have indeed come a long way. This is our small claim to fame in our anesthesia program, and our division offers the patients an option of video chatting with their family during the case. So this was one of our patients who is chatting with his family. So we have indeed come a very long way from the early days. What is the main purpose? The main purpose of keeping somebody awake during brain surgery is to avoid collateral damage to the eloquent areas of the brain. So lesions and tumors and other lesions which are possible, which can cause possible damage to the eloquent cortical tissues can undergo awake craniotomy. Some of the major indications are biopsy of tumors as well as their excision. We can also use it for epilepsy focus resection. And in the last few years, there are reports and more studies coming up showing aneurysm clipping as a potential option. Some of the contraindications we thought were very, very difficult in the early days for those of you who do awake craniotomies have actually become relative now. Possibly the only absolute contraindication these days is patient refusal. Anything else is probably a relative contraindication, such as young age of a patient, mental impairment and poor understanding of the process, personality disorders like anxiety and depression, agitation, behavior problems, difficult airway, alcohol, drug abuse. All these have moved from possible absolute to possible relative categories now. What are the advantages? We all know that. It's potentially fewer complications, very high patient acceptance rate. Many studies quote as high as 30% or even higher patient satisfaction and acceptance. Some of the problems, common problem we face is pain, and this is usually from either the head holder, inadequate local anesthetic, or position in the OR for long periods of time. Overall, there are four major types of anesthetics that we can use for awake craniotomy. Of these four, the first one, which is general with variable depth in periods of wakefulness, is not as popular anymore. What are really popular are three, which is sleep, awake, asleep, MAC with scalp block and some IV sedation, or awake, awake, awake craniotomy with scalp block but no sedation. So the latter three are the commonly practiced awake craniotomy anesthetic techniques. Some of the basic factors for success are patient selection. We all know that the surgery team, the anesthesia, and other people work in close coordination to select the right patient. And that is absolutely critical for the success of these procedures. Patient's perioperative or preoperative psychological preparation is very important. Rapport between the patient, surgeon, and anesthesiologist is critical. The trust that you build with your patient is very, very important to help you in successfully creating these healthy patient conditions. Comfortable positioning is important. Patient is awake and in an awkward position for long periods of time. So you should be very diligent in positioning these patients. And of course, without saying, we know that scalp block is absolutely probably the most important step you will do all day in these cases. Sedation selection and airway management is important. As I said, difficult airway can be a problem, and you have to anticipate and plan for it. Teamwork and communication obviously is critical, and patient factors like motivation, mental immaturity, understanding, alcohol and drug and other substance abuse are also important factors. This is our protocol at UAMS, University of Arkansas. I will not go into a lot of details, but if you have any questions later on, I will be more than happy to answer. Important highlights of our program is we use MAC with sedation and of course scalp block. With IV sedation, we use dexmedetomidine as our main agent and then propofol as a supplement. Arterial line is placed in every patient. We have a urinary catheter in every case. And scalp block we do with bupivacaine 0.5% with epinephrine 1 in 200,000. Rest of the process is pretty standard, and I'll be happy to answer questions. Patient selection obviously is critical. The surgeon, the team communication, planning, and preoperative patient interview and evaluation are important steps of patient selection. For scalp block, the most common and very popular local anesthetic is bupivacaine. We most commonly use 0.5% with epinephrine, but of course you are free to use any local anesthetic you think will work. Usually 1 to 3 or 2 to 3 mils per site. And advantage of bupivacaine with epi is it's very long acting. So it would last way into your post-op period. Technique, not going into too much detail, we know that there are 14 nerves, 7 on each side of the scalp. And there are some of these nerves have accompanying major arteries very close to them. So you should be careful, which are supraorbital, auriculotemporal, and greater occipital nerves. This is a diagram showing the 7 nerves. It's a sketch, but it lists all the 7 nerves on each side of the head. IV sedation, most commonly people use dexmedetomidine, which is the primary agent. It has several advantages, and that's the reason I use it a lot. It's a good sedative. It maintains excellent airway reflexes. It causes minimal respiratory depression in mild to moderate doses. Analgesic and anxiolytic action is very, very unique and important, and is reasonably easy to titrate. What we do in our institution and what is a popular concept is we do not give a loading dose of Presidex because we think it can cause sedation. It can also cause prolonged wake up during the mapping phase. So we avoid loading dose. Infusion is on a standard dose of 0.3 to 0.7 micrograms per kg per hour. Remifentanil is an alternative, very popular among many of the anesthesiologists. The main disadvantage is it can cause a respiratory depression, but advantage is very easy to titrate. It's very responsive. So it is popular. Most places would supplement sedation with propofol, not a very high dose, but low dose of 25 max to 50 micrograms per kg per minute, but it's a useful supplementation, especially with Precedex. Adverse events, common thing that could happen is seizures. Cold saline is usually the treatment. The surgeon instills cold saline on the brain. Benzodiazepines can work, low dose midazolam if the saline instillation does not work, or you could use low doses of propofol bolus IV. Brain swelling is a problem, can be treated with mannitol or head positioning. Airway obstruction, respiratory depression, hypoxemia, hypercarbia can happen. Nausea, vomiting has an incidence of about 4%. Agitation, panic attack in the middle of the process, middle of surgery and anesthetic can happen. And conversion to general anesthesia usually has an incidence of around 2%. So it can happen. Here is some of the literature that I think are important. Going back all the way to 2007, Gupta et al., they published a paper, which was a prospective randomized trial, which was an awake craniotomy versus general anesthesia craniotomy. The results were very interesting and very positive. They found decreased neurological deficits, decreased operating time, decreased blood loss, and decreased hospital stay. So all positive news. And they did a 3-month follow-up. In 2011, Sacco et al. Published a paper where they compared awake craniotomy with general for eloquent tumors. It was again a prospective randomized trial with a larger number of patients now, about 214 versus 361. And the results were very similar and promising. They found a better neurological outcome, and resection quality was good. Hospital stay was short. It was safe and allowed resection and lower deficits, less complications, and quick discharge. So all positive results on this study. In 2013, Brown and his group did a review of literature for a long period between 1970 and 2012, 8 studies and 951 patients. Again, they compared awake versus general anesthesia for brain tumors. Conclusion was similar. They found hospital stay was shorter. They did find that the resection quality was not as good as they thought. Post-operative deficits and surgery time were much less. 2016, again, a huge meta-analysis by Stevanovic and team, 47 studies, and they compared all types of awake craniotomy techniques, and they found failure rate of 2%, a seizure rate of around 8%, dysfunction about 17%. They also concluded similarly that the awake craniotomy techniques were feasible and safe. And they did comment that the awake at that point in time did not have enough data to make any definitive conclusion, but it did show promise. 2019, a big review article by Swell and his team found that awake craniotomy was, they even stated it as a gold standard for gliomas, especially eloquent tissue areas or close by. And they said prognosis depended on overall free survival, seizure control, and morbidity was important. They also found very high level of patient satisfaction, which is a great advantage of this process. And they also found that it avoided general anesthesia, reduced hospital stay, and reduced hospital cost. They further said that the failure rate was around 2%, which we know from other studies as well. Seizures were a problem, incidence of around 3 to 30%, which is a wide range. But they commented that preoperative anti-seizure medications do not decrease incidence. They actually said dual anti-seizure treatment in the OR may decrease incidence. none of the anesthetic techniques for awake craniotomy was found superior to the other. So they are all comparable. So what are some of the current challenges and concepts that have come up in the last few years? One big question we always ask is, what is the perioperative surgical outcome after an awake craniotomy? Now, to answer this, SNO did a big study in 2017. They compared awake craniotomy versus general anesthesia for eloquent glioma. It was a retrospective study, but on the same surgeon. So they had some amount of comparability. They found that in awake craniotomy group, they had better total resection success, better post-operative Kranofsky performance score, shorter hospitalization, and similar perioperative complications. So very positive results when you compare perioperative surgical outcome when you compare awake versus general. Now, Gerritsen in 2019 again compared awake craniotomy with general for gliomas. This was a meta-analysis, 53 studies, and more than 9,000 patients. They looked at complication rate, survival, gross total resection success, extent of resection, and eloquent areas amount being involved. Again, awake craniotomy group had excellent results. They found better surgical outcome, better longer post-operative survival, lower post-operative complication, and higher percentage of tumor resection success. The other new interesting concept that has come up in the last few years is what we call a same-day discharge after craniotomy. Goldmacher and his team, led by one of our speakers in this conference, Dr. Lakshmi Venkatraghavan, have done extensive study on this particular interesting technique. And thank you, Lakshmi, for tremendous leadership and foresight in propagating and studying this very interesting concept of same-day discharge after craniotomy. Mind you, this involves craniotomy under general as well as awake. So it is not just awake, but it can also involve general anesthesia. In 2021, Lakshmi and his group, led by, first authored by Goldmacher, published this review. And they said that it was first time attempted in 1996. And the advantage of this system is obvious. It reduces hospital cost. And they have predicted that the hospital cost saving is actually up to 50%. This reduces nosocomial complications, case cancellation, and increases patient satisfaction. What are some of the barriers of discharging the patient on the same day after craniotomy? The barriers are obvious. Surgeons who are not used to sending their patients out the same day and may have genuine concerns. The anesthesiologists who may not be comfortable doing it. The patients who may not be ready to go home and take the responsibility. Obviously, there is a resistance to change. No system wants to change easily. There is always an inertia. That is a problem. Medico-legal concerns are genuine and legitimate for obvious reasons. And of course, many centers, many countries may not have the infrastructure and the communication and the follow-up setup in place to closely follow these patients. So these are some of the barriers that the authors have mentioned. They further go on to say that a same-day care pathway and multidisciplinary approach and forming a strict protocol is the solution for these problems. As is obvious, patient selection and education is critical to successfully implement the programs. Use short-acting drugs. They also recommended avoiding invasive monitoring such as an arterial line, drains, and hyperosmolar therapies if possible. In their protocol in Canada, they have a 6-hour post-operative surveillance where all the patients who undergo craniotomy, either general or under awake craniotomy, and are scheduled to go home or go get discharged, are monitored for minimum of 6 hours. They always get a CT scan before they go. Is usually around 4 hours to 6 hours after surgery is finished. And there is a strict discharge and follow-up protocol in place where the patient is contacted frequently by the patient care team, and it is ensured that the patient has access to emergency medical care if they need once they're discharged. So as you can see, an extensive, strict protocol has to be followed to successfully and safely implement these programs. Some predictors of success, which Dr. Goldmacher, Lashmi, and their team proposed, was that they said that it's more successful if the patient is undergoing awake craniotomy, if the patient is a male, low modified Rankin scale score, low modified frailty index scores, small right-sided supratentorial tumors, so not the dominant side, and a small size and supratentorial, and if they preferably have no surgical drains. So these are some of the points which improve the success of this particular technique. The last mention I will talk about is about awake technique, where the patient undergoes only scalp block but no IV sedation. This was published in 2013 for the first time by Hansen and his team. What they recommended was avoid sedatives, use strong perioperative rapport between the patient and the anesthesia team so that the patient has complete trust in what you suggest, what you recommend, and what you do. They also said that there has to be a permanent presence of a contact person very next to the patient, who is in verbal communication and physical communication with the patient at all times. They also recommended therapeutic communication rather than sedatives, and that included hypnotic suggestions, reframing thoughts, and dissociation into safe spaces. Some of the psychological and behavioral techniques that can be used to calm a patient down and instill more confidence in you. So to summarize, awake craniotomy has massively increased in popularity to the point that for certain tumors, they are considered the gold standard. They provide more accurate brain mapping during tumor resection and excision of any epilepsy focus. So they provide a direct access to the patient's brain while the patient is awake. They have proven to have fewer complications compared to general anesthesia. Of course, to successfully implement these programs, you have to have a stringent patient selection and exclusion criteria. Pre-op psychological assessment and counseling is absolutely important. Close communication and teamwork between all the players involved, the pre-operative people, the surgery team, the anesthesia, the circulators, the nursing services, the hospital infrastructure, follow-up process, everything has to have very close communication. Some of the complications that can happen, obviously, are respiratory depression, airway obstruction, nausea, vomiting, seizures, and discomfort. This is my family. These are the people who make things possible and let me do what I do. So thank you, everybody. Do you have any questions? Please feel free to ask through the appropriate methods.
Thank you, sir.
Thank you.
Thank you so much for your wonderful presentation. Hello, am I audible?
Yeah. Yes.
Yeah. Thank you, sir, so much. Thank you so much for your wonderful presentation, sir. Now, we would like to request Dr. Devendra Gupta, sir, to introduce our next speaker, Dr. Rajesh Srinivasa, sir. Over to you, Devendra, sir.
Good afternoon. At outset, I am thankful to organizer of ISNACC 2022 for giving me this opportunity to attend and participate in this conference. It is my honor and privilege to introduce Dr. Rajesha Srinivasa. He is a consultant anesthetist at Neuroanesthesia and Perioperative Medicine Division at Walton Center NHS Foundation Trust, Liverpool, UK. His area of interest is functional neurosurgery and the clinical outcome in the elderly and quality improvement. He has a two research project in which he is a principal investigator. One is a famous Arctic 1 study, and second is a SNAP 3 study. Over to Dr. Rajesha.
Today, I'm going to talk about challenges of managing functional pain surgery patients. I would like to thank organizers for giving me an opportunity to speak in this meeting. The Walton Center is one of the few UK centers which offers neurosurgical interventions for chronic pain. My talk is based on the experience of managing these patients who come for this pain surgery. In today's talk, I will be going through the following topics. Chronic pain is one of the most disabling and expensive health conditions across the globe. Patients present for neurosurgical treatment for pain as a last resort when they have exhausted all other options. Pain surgery is an important but often less fancied neurosurgical subspecialty. Not all neurosurgical centers have pain surgery done. Advances in technology and a better understanding of pain has led to sophisticated surgical interventions for pain with improved outcomes and less side effects. These are the neurosurgical interventions available for chronic pain. They're broadly divided into treatment of cause, neuromodulation, which can be pharmacological neuromodulation or electrical neuromodulation. And then we have ablative techniques along the pain pathway, right from the peripheral nerve to the brain centers. Anesthetic consideration for pain surgery. There are several types of procedures at various target sites. These patients have complex pain problems and are usually on maximal dose of multiple analgesics. They also have associated mental health issues. And pain is often associated with negative thinking. And of course, like all other patients, these people also have medical comorbidities. What are the challenges for us? As there are so many techniques, we need to be proficient in understanding the surgical requirement and the various positions that these surgical technique requires. Most of the ablative techniques, we use intraoperative neuromonitoring. So as a result, we have to use the total intravenous anesthesia to enable this neuromonitoring. And each surgery has got its own individualized anesthetic requirements. We need to be versatile in our anesthetic techniques. Can be from monitored anesthesia care to total intravenous anesthesia or deep sedation or conscious sedation. Managing acute post-surgical pain in a chronic pain patient can be a challenge for any anesthetist. And meeting expectations of these patients is a tough ask. Preoperative considerations. Comprehensive preoperative assessment is essential in understanding these patients. The number of patients taking opioids on a long-term basis has grown rapidly over the last couple of decades. So we need to rationalize the use of opioids in the preoperative period. In our setup, the pain physicians does it for us. We need to look for the side effects as well. We have to explain the whole procedure from the anesthetic perspective. And we need to agree a post-operative analgesic strategy with the patient by patient education and by empowering them to take that decision. And also we need to develop a rapport with the patient. We all know about the short-term side effects of the opioids. However, we don't give the same importance to the long-term effect of opioids. The CNS side effects are neurotoxicity, dizziness, sedation, depression, and hyperalgesia. The last one is very important for the patients who come for chronic pain surgery. It can also cause increased risk of fractures, especially in elderly patients, by dizziness and sedation. And they can also have an effect on endocrine system, and they suppress hypothalamo-pituitary axis and causes hypogonadism in men and osteoporosis in women. They also have intrinsic immunosuppressant activity by suppressing the HPA axis. We know, though, there is a worldwide opioid crisis in different parts of the world. Because of the long-term use can lead to addiction and misuse. So these are some of the pain procedures that we performed at Walton Center in 2019. As you can see, we've done few neuromodulatory techniques, and we have done some ablative techniques, and we also done the treatment of the cause for trigeminal neuralgia, microvascular decompression, and the percutaneous balloon compression. We have a multidisciplinary approach. Most of our patients are referred to either a pain physician or neurosurgeon. They, in turn, will refer to the physiotherapist, psychologist, and specialist pain or neuromodulation nurse. They will go through the pain questionnaires, and they will do psychological assessment. And then once they are ready, we will get involved in the perioperative period. For trigeminal neuralgia, we are offering microvascular decompression, percutaneous balloon compression, peripheral neurostimulation in the patients with the complex facial pain. And for some of the patients, we have done sphenopalatine ganglion stimulator insertion. We all know about microvascular decompression. It's done under general anesthesia with the TIVA because of the brainstem auditive potential monitoring. Post-operative nausea and vomiting is common in these patients. The balloon compression has got a 90% success rate. It's done in an X-ray suite and a general anesthetic, and it's done as a day case. These are the neurostimulation techniques that's available for chronic pain. We have deep brain stimulation, spinal cord stimulation, motor cortex stimulation, direct cortical stimulation, transcranial magnetic stimulation, and focused ultrasound. Norman Shealy and his colleagues performed the first SCS implant in 1967. And nowadays, about 14,000 spinal cord stimulator implants are done every year. Since 2015, high-frequency spinal cord stimulator is becoming popular. The indications for this is failed back surgery syndrome, neuropathic pain in limbs, chronic regional pain syndrome, and chronic back pain. The spinal cord stimulator can be percutaneous, or it can be open with the paddle electrodes. Percutaneous technique is a minimally invasive, can be done under sedation and local anesthetic in prone position. And patient selection is important because they are in the prone position with a deep sedation. And we used propofol and dexmedetomidine infusion for this. For open spinal cord stimulator, paddle electrodes are used. It requires laminectomy at the level of insertion. It's more painful. We do it under GA and use multimodal analgesia and plus or minus PCA for these patients. So we performed about 60 spinal cord stimulator insertion in 2019, and this is our results. As you can see on the right-hand side, there's an improvement from the pain scoring prior to trial and the post-trial and at 1 year follow-up. In patients who don't get benefit from spinal cord stimulator, we also offer dorsal root ganglion stimulators. And it's used when SCS stimulation is not adequate. It can be used for post-surgical pains like herniorrhaphy, mastectomy, thoracotomy, etc. It's done in an X-ray suite under sedation in prone position, and it gives a good pain relief. The other neurostimulation technique that we offer is a deep brain stimulator. So currently it's indicated for post-stroke pain like thalamic pain syndrome, deafferentation pain, and failed back surgery syndrome. However, it's no longer indicated nowadays, and trigeminal neuralgia. The various targets for DBS insertion are thalamic nuclei, periventricular gray, and periaqueductal gray, and cingulum. The anesthetic considerations for patients coming for DBS, persuading patients to be awake can be challenging. They'll be on multiple analgesics, and in selected patients, you can perform it under sedation and scalp block. Otherwise, we are going to do it under general anesthesia with TEVA. And post-operative pain management can be tricky in these patients. As you know, DBS involves inserting an electrode and connected to a battery through a connector. So in the last 10 years, we've done total 16 DBS for pain indication. And we have achieved about 60% pain control with minimal morbidity. However, getting a nice approval for this surgery is difficult nowadays. Peripheral nerve stimulation. The most common one that we are using is occipital nerve stimulator and trigeminal ganglion nerve stimulator. Occipital nerve stimulator is performed under GA in lateral position so that we can do both electrode insertion and the battery connection in the same position so that we don't have to change. Post-operative pain is very common, and IV lignocaine and oral ketamine is often helpful in these patients. Trigeminal peripheral nerve stimulation, we're doing it in the last 2 years. We use ultrasound for the electrode placement, and it needs deeper plane of sedation for electrode insertion and an awake patient to confirm the electrode placement to elicit the paresthesia. So for that reason, we use dexmedetomidine and propofol sedation. The pharmacological neuromodulation can be achieved by intrathecal drug delivery systems. Now it's no longer indicated for functional failed back surgery syndrome. We're only using it for cancer pain patients with more than 6 months life expectancy, usually done under general anesthetic. Coming to ablative procedures, they are selectively destructive. We have to use intraoperative neuromonitoring, and there are different targets. The targets can be anywhere from the peripheral nerve to the various brain centers. Myelotomy is actually used for intractable visceral pain, and we don't do many of these procedures nowadays. It's done under general anesthetic, and post-operative pain management can be difficult in these patients till the effect of myelotomy comes into effect. Dress lesioning. We are doing it for brachial plexus avulsion injuries, and thermal lesions target the nociceptive fibers of the lateral part of the dorsal rootlets and medial aspect of the Lesseur's tract. It gives 80% pain relief, and we usually do it under TEVA. Selective dorsal rhizotomy for spasticity-related pain, and chordotomy for cancer pain. It can be done either percutaneous technique or open technique. Nowadays, percutaneous technique is the preferred one. For all these three procedures, we can use the same anesthesia. And it's usually lasts, it's a long procedure, 6 to 8 hours in prone position, intraoperative neuromonitoring. Patients are often on multiple analgesics and depression is quite common. We use opioid-free TIVA for these patients, which reduces post-operative opioid requirement. And for post-operative analgesia, we give oxycodone PCA and oral ketamine and IV paracetamol and their regular analgesics. So I mentioned about opioid-free TIVA. So this reduces the opioid side effects, which is opioid-induced hyperalgesia and tolerance. It reduces post-operative opioid requirement, and it's commonly used in a bariatric surgery. So our regimen is we start with the dexmedetomidine 1 microgram per kilogram bolus over 10 minutes. And then once the bolus is gone, then we will use propofol TCI with the Snyder model and atracurium 0.5 milligram per kilogram. And then we also give ketamine 0.25 milligram per kilogram bolus, followed by the infusion. And wherever possible, we use local anesthetic infiltration to the wound, or scalp block, or ESP block. Nowadays, we have liposomal bupivacaine available, which can offer pain relief for up to 96 hours. We've also talked about multimodal analgesia earlier. So what does it mean? The drugs with the differing mechanism of action targets pain pathways, resulting in additive and or synergistic effects. The aim of the multimodal analgesia is to improve pain relief while reducing opioid requirements. The analgesic modalities currently available for postoperative pain include the opioids, regional anesthetic techniques, paracetamol, NSAID, and COX-2 inhibitors, and adjuncts like steroids, ketamine, alpha-2 agonists, magnesium, and anticonvulsants. And nowadays, cannabinoids are being increasingly used for treatment of the postoperative pain. So this is a graph showing the timing and dosing of multimodal analgesia, at what time that we can use which drug. So in the pre-medication section, we cannot give gabapentinoids, and followed by dexmedetomidine infusion before induction with the propofol and rocuronium or atracurium. And then we can use ketamine, magnesium, and lignocaine intraoperatively. And then we can use bupivacaine towards the end. So I would like to share my experience of one of the patients' interesting cases. So this is a 33-year-old lady who had a thalamic tumor. She underwent craniotomy for that. However, she left with a persistent post-craniotomy pain, which was affecting her quality of life. She had multiple pain interventions in different neurosurgical centers. However, she was left with a constant debilitating pain. So she came to our neurosurgeon. As you know, pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. So we looked at her, and she already had so much interventions done at the sensory part. So our neurosurgeon decided to treat the emotional aspect of the pain. So he actually performed DBS targeting the anterior cingulate gyrus. And this lady had a very good pain relief post-op. Many of the pain procedures are done under sedation. It's very important to use the capnography for these patients, and it's a must. It helps us in early detection of respiratory depression and airway obstruction, and it prevents further complications. So what are the future interventions in the chronic pain? The technology will play an important role in the future of pain surgery. Genomics and gene therapy has already been used in the treatment of trigeminal neuralgia. And there are newer targets of our DBS has been considered, like cingulate gyrus and insula. There is a new focused ultrasound technology being used for thalamotomy, which is a incision-less ablative technique. And there is a neurorestoration of dorsal root ganglions in the animal studies, which is encouraging, and it can soon be used for the human beings. To conclude, pain surgery is an important part of multidisciplinary pain treatment. Patient involvement in decision-making, individualized analgesic strategies, and the setting of realistic expectations plays an important role in the successful management of pain surgery patients. Adapting the anesthetic technique to newer treatment modalities is essential for good outcome. Thank you for your kind attention. I would like to thank my colleagues, Mr. Farah, Dr. Bamber, and Dr. Mahalingam. Good day.
Thank you, sir. Thank you so much for this wonderful presentation. Due to lack of time, we can only take up 1 or 2 questions. I shall request the chairpersons to open the session for questions. Over to you, chairperson.
Thank you, all the speakers, for giving an excellent talks. There is a question from to Dr. Massimo about, I think he's there or not, I don't know whether he's there. This was regard, I think, yeah, he's there. So how much percentage of asymmetry between right and the left is considered as abnormal when we use third-line sedation monitor?
So in general, so more than 10% discrepancy between the two sides is considered abnormal. So it's very common, for example, if you have a patient with a stroke and you perform, for example, the compressed craniotomy, and then you have to replace the scalp, you will see this difference after the stroke. So mainly considering the baseline of this post-stroke patient at 10% is considered normal. But if you have a patient with this abnormality during the surgery, you have to inform your surgeon that there is something happening, and you have to restore the circulation and the cerebral perfusion.
Thank you. So, Dr. Massimo, one question is how much a role the AI, that is artificial intelligence, is going to play for the future of EEG and interpretation for a layman?
So, very interesting question. And I unlikely don't have the answer. So the problem of artificial intelligence is mainly to have a good input in the information. So far, it's still not able to interpret some data. So especially because there are a lot of artifacts when we do surgery, and there is not a connection caused by, for example, interference caused by movement of the patients or artifacts by electrocautery that can allow artificial intelligence to have this data and to have the noise of this data eliminated. So it's still far from being a reality, especially when we have to understand, as I mentioned in my lecture, if we have a patient with vasopression that can be caused by oversedation, or per se is the patient under vasopression. In this case, we have to change something else and not only the sedation.
Thank you. Dr. Hemangi, any question?
There is another question. I think Dr. Rajesh, what is the role of SPJ block for chronic pain following craniotomy?
Well, actually, so we used a series of spinopalatine ganglion stimulator, insertion for the chronic facial pain. However, its efficacy was not great. So as a result, our NICE has now suggested that it should no longer be used. So it only gives partial relief. So yes.
Thank you, sir.
Yeah, there is a question to the Dr. Indranil. Do you use closed loop TIVA technique, and what is your experience?
Can you hear me?
Yeah.
Yeah, in our institution, we do not use it. I do not have personal experience with it. Others may opine, and I know of discussion with my other colleagues in the similar interest group that people have started to research that and started to use it, but I do not, unfortunately.
Thank you.
Thank you, sir.
Sir, I think there is no other question. So with the permission of the chair, should we consider the session to be closed, sir?
Yeah. Thank you very much to all the speakers, Dr. Indranil, Dr. Rajesh, Dr. Massimo, and my co-chair, Dr. Devendra, and Dr. Imani. Thank you very much.
Thank you so much.
Thank you.
Thank you so much, Chairperson. Thank you so much, speakers, for this wonderful session. Okay. Now we head to our next session, which is the session 12. And to chair this session, I would like to request Dr. Sharburi Shoika ma'am, Dr. Debashish Saha sir, and Dr. Prashanna Bidkar sir to please join us on the dais. Unfortunately for us, due to some family issues, Dr. Debashish Saha sir will not be able to join us, so we shall have two chairpersons in this session today. Now a few words about the members of the chair. Dr. Sharburi Shoika ma'am, she has done her DA, MD, and fellow in medical education. She is a professor in anesthesiology and head of the Department of Emergency Medicine and in charge of Trauma Care Center, IPJMER, Kolkata. She has been the past president of ISA West Bengal, past vice president of RASCP National, and past president of WBSSP. She is an instructor of calls, BCLS, CCLS, and transplant coordinator. She has some 31 publications in various national and international journals. Her areas of interest being difficult airway management, laparoscopic anesthesia, pediatric anesthesia and trauma and critical care, and disease donation program, to name a few. She's also the treasurer of this present 23rd annual conference. A very welcome, ma'am. Okay, now we will go to our next chairperson, Dr. Prashanna Bidkar, sir. Sir is a professor and head of the Division of Neuroanesthesiology at JIPMER. He is an ISNACC treasurer and NCSI treasurer at present. He has some 52 publications and has written as many as 25 chapters in various books. His areas of interest is very different. As he says, it's anything other than anesthesia, maybe badminton. A very warm welcome, sir, to this conference. Now I would like to request Sharburi Shoika ma'am to introduce our first speaker, Dr. Patrick Hasse. Over to you, ma'am.
Thank you, Dr. Navanita, for good words. Very good afternoon to all. At the outset, I convey my sincere gratitude to the organizing committee of ISNACC 2022 for giving me this opportunity. Now I take the privilege to introduce Dr. Patrick Hasse. He has done his MB, BCH, BAO, AFRCSI, and FCARCSI, and MD. He is affiliated to Cork University Hospital, Ireland, as a consultant anesthetist and intensivist. He has done MD in acute lung injury and gene therapy in acute lung injury. So he will be delivering lecture on prognostication in neurological catastrophe. Over to Dr. Patrick Hasse.
And today I'm going to be speaking to you about neuroprognostication. I work in this hospital, in Cork University Hospital in the south of Ireland. It's a tertiary referral centre for approximately 1.5 million people. We have 40 subspecialties under one group, including, of course, neurology and neurosurgery. I don't have any particular commercial interest to disclose. I suppose the only disclosure I would make is that recently I had the unfortunate role of being a family representative in discussions around neuroprognostication of my cousin who had sustained a out-of-hospital cardiac arrest. And it's largely this which prompted me actually to give this presentation. The scope of the presentation will be on the why, the who, the how, the science of neuroprognostication. That's the most main part of this presentation. The latter end of my presentation will be just briefly on why I think maybe neuroprognostication is increasingly pointless in many settings in neurointensive care, and the reality that we and as clinicians and as family members face. So why do we neuroprognosticate? Well, of course, we neuroprognosticate to inform families around their loved ones' likelihood of survival and outcome, and also to inform decisions on ceding of care or withdrawal of care. We also neuroprognosticate, I would hope, to inform service planning around the downstream effects of those decisions. Who do we neuroprognosticate on? Well, we do so in a wide variety of patients, in fact. We neuroprognosticate on traumatic brain injury patients, subarachnoid hemorrhage patients, stroke patients, and in particular hypoxic brain injury patients. Now, the large part of the data I present to you next is specifically looking at patients with hypoxic brain injury, and it comes from this particular review of the topic. This was published in Intensive Care Medicine in 2020. It's a follow-up to the same review that was published last in 2013. There are some minor changes to it, which I will mention, particularly around the topic of somatosensory evoked potentials. But if you have an interest in this or want to further look up data around this particular topic, then I would suggest to you that this particular paper is a must-read. Now, when I ever ask a medical student to talk to me a little bit around the concept of how to assess a patient for anything, I like to see a structured answer come. And that structure should be based on the history of the patient, the examination of the patient, and then the appropriate investigations from those last 2 points. And that's how I'm going to actually approach this particular topic largely. When you look at the history of a patient, we of course are interested in certain elements of the history of a patient who's been brain injured. We like, for instance, to look at the type of cardiac arrest, because we know that out-of-hospital cardiac arrest with ventricular arrhythmias tends to carry a better prognosis. We also like, for instance, to look at pre-hospital care of these patients. What was the return of spontaneous circulation, or what was the downtime? Was there bystander CPR, and what was the quality of that CPR? We, of course, also like to look at premorbid conditions, such as a cardiac history or a significant previous neurological history. There are some scoring systems, of course, that are of interest. Historically, the Glasgow Coma Scale was, in fact, a prognostic tool. And indeed, there are other more advanced scales now, like the World Federation Neurology scores and the Fisher-Gray scores around subarachnoid hemorrhage. I think when you talk about history in the setting of neuroprognostication, you have to acknowledge its weaknesses as well as its strengths. I think it can be often difficult to unpick inaccuracies around, for instance, the length of time a patient was down in terms of CPR. But at the same time, I think where its usefulness in terms of history comes in is where it helps to paint an overall picture when you're discussing neuroprognostication with families. So what about examination then? I think, first of all, it's important to talk a little bit about the timing of the examination in these patients. Generally speaking, some features are prognostic early on, earlier than 72 hours, but at the cost of higher false positive rates. What's more important, perhaps, in looking at the trajectory of a patient is to look at the persistent or lack of change or progression of certain features on examination as time progresses beyond 24 hours to 72 hours to 96 hours. The other point I would make at this particular juncture is that it's important to understand what the concept of false positive rates mean in usefulness for predicting a poor outcome. If a patient's feature on examination or investigation has a false positive rate, it means that there's a potential for you to incorrectly assign a poor neurological outcome to that patient when in fact the patient will have a good neurological outcome. And so we always strive, of course, then in any feature to have a zero false positive rate. And it's also important, I suppose, as well, to look at the confidence intervals for a poor outcome. So let's move on to examination of pupillary reactions and unreactive pupils. If you look at these studies, it's important to note that the feature of unreactive pupils at 24 hours is often, in fact, carries with it a high false positive rate. But if that feature persists into the 48 to 72 hour period, that feature carries with it a far lower false positive rate, reassuringly. When you look at motor score, as defined as a motor score less than 2, that is to say extensive response or no motor response on examination, again you'll see that their pattern develops whereby the feature carries with it a relatively high false positive rate at 24 hours, which subsequently decreases on further examination at later time periods to lower false positive rates. But compared to, say, for instance, fixed pupils, it still has a significant false positive rate. And that is also reflected in the confidence intervals associated with such false positive rates. What about absent gag and cough reflexes? Again, the same pattern emerging. Early on, an absent gag or cough reflex carries with it a very high false positive rate. But as time progresses and the feature persists in examination, the false positive rate drops dramatically, as do the confidence intervals. Myoclonus is a little bit more complicated. The problem in the literature with myoclonus is that there isn't really an agreed definition of what defines myoclonus. So it can mean in the literature, for instance, isolated limb jerking movements or generalized jerking movements that persist. Generally speaking, we do know that the presence of myoclonus does carry with it a poor neurological outcome, but there are unfortunately many case reports as well that suggest that it isn't always the case that the presence of myoclonus carries with it a uniformly poor outcome. In particular, that myoclonus, which is noted to be isolated limb jerking in nature. What about investigations? Well, I think we briefly need to talk about the EEG, imaging, SSEPs, and biomarkers. Now, for the purposes of time, I have to concentrate on a few features of these investigations, so obviously this isn't a complete overall picture I'm giving you here. When you look at the EEG, there are a number of criteria used in the literature. The general theme is low false positive rates for poor outcomes, but it comes at a lower sensitivity. That is to say that the feature of an abnormal EEG isn't always present on those patients who do ultimately have a poor neurological outcome. Broadly speaking, the EEG changes can be described as either background activity or suppression, seizures or abnormal discharges, and then finally superimposed seizures on abnormal background activity. The next few slides will concentrate on numbers 1 and 3 for the purposes of time. When you look at background suppressed activity, as defined as an EEG amplitude of less than 10 microvolts, you'll notice that, for instance, the false positive ratios at 24 hours, even early on, are quite low. And similarly speaking, the confidence intervals of such ratios the confidence intervals of such false positive rates are quite low as well. When you look at background suppressed with burst activity, you get an even more uniform picture again of very low false positive rates or absent false positive rates and correspondingly narrow confidence intervals. However, if you do look at the other highlighted column here, the sensitivity of this is quite low, relatively speaking. That is to say that many patients will not have these features on EEG and will also then still have a poor neurological outcome. So in general then, I think it's important to focus on the third group of those changes, which is superimposed epileptiform activity on abnormal background, and to say that if those patients have an abnormal EEG in the first 24 hours, which may subsequently improve, but often they may have a completely normal EEG and still carry a poor and still suffer from a poor neurological outcome. The presence of number 3, the third group, after 24 hours carries probably the worst prognosis of all the EEG changes. But as I said already repeatedly, sensitivity of EEG does drop off as time passes on. The EEG, I think it's important to note, is also subject to inter-observer error. The other malignant patterns in particular, such as status epilepticus, burst suppression, unreactive EEGs, etc., they all suffer from a lack of agreed definitions in the literature, and so therefore the data on them is not reliable. And the final thing I'd say about EEG is that BIS currently has no recommended role at present in this particular review that I'm quoting. There are very few studies, they are of poor quality and really not to be recommended as useful at all in this setting. I'm going to move on quickly now to CT. CT as an imaging modality, I'm going to concentrate only on, for the purposes of time. Generally speaking, CT is described in terms of cytotoxic edema versus vasogenic edema, with cytotoxic edema being the actual metric that's used in radiological studies. Cytotoxic edema is that type of edema that is responsible for the reduction in grey white matter differentiation. When you look at the literature, in fact, studies measuring grey matter densities versus white matter densities describe a ratio known as GWR in regions of interest. Low GWR accurately predicts poor outcome with low false positive results. The problem, however, is that there's a lack of consensus as to what constitutes a normal GWR ratio. And again, generally speaking, the sensitivity largely but not uniformly improves around these studies after 72 hours. Now, this is a very busy slide. The only thing I really want to point out from this slide is that it just demonstrates the heterogeneity of the studies involved around imaging. There are a number of different areas of interest that are proposed as being of interest when looking at GWR, and if you look at the data, really, it is quite heterogeneous. The false positive ratios are, relatively speaking, quite low, and it still means that despite the heterogeneity of the data, that the utility of CT as a prognostic indicator is still recommended. When you look at somatosensory evoked potentials, or SSEPs, I think there are a couple of points to make, really. The first is that they're not widely available. The second is that they are, generally speaking, a response to a standardized median nerve stimulus. The third is that, generally speaking, they have a high sensitivity and low false positive rates. And we'll discuss that in a minute. And also that previously they suffered from what was known as a self-fulfilling prophecy bias. And I'm going to discuss that now in the next slide. When you look at SSEPs, when combined with a feature on examination of unreactive pupils in the past in the literature, you get a very robust combination for prediction of poor outcome in a comatose patient. So absent bilateral N20 waves combined with unreactive pupils, generally speaking, in the previous literature published, has shown to be one of the most robust in terms of poor prognosis. And there have been, of course, some other poor quality studies with high false positive rates. But the studies I referred to that were published in the last review in 2013 all suffered from a self-fulfilling prophecy fallacy argument. And that was that they all came from institutions where the presence of unreactive pupils with absent bilateral N20 waves resulted in a withdrawal of life-sustaining treatment. Now, what's new in this particular review is that the authors have included 5 new studies since 2013 that have been completed on this particular topic. And what's interesting around that is that those 5 new studies were completed in jurisdictions where withdrawal of life-sustaining treatment was not culturally acceptable. And even using then the combination of unreactive pupils and absent bilateral N20 waves on SSEPs, those studies showed that uniformly patients had a poor neurological outcome. So I think we can largely put to rest, to a degree, the self-fulfilling prophecy fallacy arguments around the previous studies on this topic. This is the data on this particular topic, and I think it's quite obvious to see that early on even, the false positive ratio is very low for most of these studies. And again, the false positive ratio percentage or confidence interval is quite narrow, again, associated with these studies. I'm going to talk very briefly about biomarkers finally around this particular topic. The advantages of the biomarkers, I suppose, are that they're not affected by sedation or paralysis. They are quantitative. However, I'll just mention briefly that that is a double-edged sword in a minute. And of course, they can be evaluated blindly in the laboratory by somebody who has no idea what's going on with the patient. And so there isn't really an argument for a self-fulfilling prophecy there. The disadvantages of biomarkers are that they're not widely available. Whilst they may be quantitative, giving a range, making agreed false positive thresholds is difficult. There are extracerebral sources, and there is a variation in the conduct of assays between different labs. So when you put all of this together then, it's important to probably point out at this stage that there are, of course, pitfalls around the science, as is evident in the published literature. One of the points that is often made when discussing the literature around this is that counting death or withdrawal of life-sustaining therapy is not really ideal in terms of poor outcome metrics, because you can't really, with finality, know what a neurological outcome is if you withdraw life-sustaining therapy. The second point is that setting arbitrary time limits like 1 month on when neurological recovery is finished is not really a fair thing to do a lot of the time as well. There are many times when patients whom we think the neurological recovery is front-loaded, in fact, go on to, with proper therapy, such as occupational therapy and physiotherapy, make more of a recovery. So arbitrary time limits are problematic in this setting. Another point, which is not really possible to get over, is that you will never really remove publication bias or selection bias in large reviews of the nature of the data I've presented, since they're retrospective studies and no registration is required for such studies. And finally, the other major problem we have in this topic is that we can never achieve 100% certainty. We can only approach it. And this brings me on to the next section of my talk. I think as intensive care physicians, we've all been faced with a family discussion and the question asked by a family, are you 100% certain, doctor, that my loved one will not make a good neurological recovery? And that question really is not possible to answer. And the reasons are obvious. This is just a short graph looking at the complex nature of brain injury, both in terms of injury and recovery. And it reflects really why we can never be 100% certain. Things like necrosis, axonal injury, glial injury, apoptosis and demyelination, microgliosis and neuroinflammation. All then, on the flip side of that coin, things like chronic neurodegeneration and systemic responses, all add to uncertainty. And not only that, we haven't even really looked at what available services that there are for patients in terms of occupational therapy and physical therapy that would promote a good recovery. If you look at it in terms of particular examples, take the case of a 70-year-old woman with a history of hypertension presenting with a GCS of 4 and no motor response. In other words, a World Federation of Neurology score of 5. And on a Fisher grade 4 score on subarachnoid hemorrhage on her CT. Now we know from looking at the data that there's a 10% survival rate for these patients. And this is despite optimal surgical and critical care management, early neurocoiling or securing of the aneurysm, and optimal neurointensive care management with things like triple H therapy and so forth. We don't really have an accurate way of predicting yet who is in that 10%. We don't really yet have an accurate way of predicting who might even be in the 1% of those patients who actually do well. And so therefore we are faced with no choice but to proceed with the high-end interventions that we do so often. What about traumatic brain injury? Deckard trial showed that really reduction in intracranial pressure doesn't always lead to better outcomes in patients. We know as well that decompressive craniectomy, therefore, is not a panacea. And in fact, I think it's fair to say that decompressive craniectomy is often used beyond the guidelines of published evidence to save a patient's life. We fall into the trap of we've started, so we might as well finish logic. In fact, when you look at the data around traumatic brain injury, age is the second best metric used for prognostication, but even that is inconsistent. What is the best metric for traumatic brain injury for neuroprognostication? It appears that time is in fact the best metric for neuroprognostication. And time is often what we give these patients. Everybody likes the high-tech task-oriented interventions in medicine. We like to coil aneurysms. We like to bring them to theatre. We like to manage them intensely in the neurointensive care. The question, though, is whether we like to do the other interventions. When you look at, in fact, the neurointerventional devices market, that interest in doing the high-tech stuff is reflected in the global net worth of it, at 2.5 billion forecast for 2019 and rapidly rising. It brought me to think, well, what is the interest in neurorehabilitation for these patients? A quick Google search brought me to this site, which verified that, in fact, the neurorehabilitation devices market was worth 5 billion. And I was quite reassured by this. However, when I actually drilled down into this figure of 5 billion, it turns out that this is not money that's been spent on occupational therapy, on physiotherapy, on rehabilitation hospitals, and so forth. This is money that's been spent on high-end interventions in things like Parkinson's disease, such as deep brain stimulation therapy, and so forth. It then really begs the question, does everybody want to do the other interventions? When we talk about neuroprognostication, does everybody want to, in fact, bring their family member home who requires 24/7 nursing care? Does, in fact, everyone want to go through the gamut of prolonged occupational physiotherapy with a degree of uncertainty as to what the eventual outcome is? And those questions are not really easily answered, but they are questions we must always ask. So in summary, I'll say that we live and die with degrees of uncertainty. And when you speak to families, you have to acknowledge this point. The other point I would say is that you must convince yourself first and your colleagues in the allied health professions what the right thing to do is for patients. And most importantly, when you talk to families and neuroprognosticate, you must never talk in terms of survival only. Thank you.
Thank you, sir. Thank you so much for your talk. In absence of Dr. Debashish Shah, sir, I would like to request Dr. Shaurvari Shaika ma'am again to introduce our next speaker, Dr. Lakshmi Venkat, sir. Over to you, ma'am.
Thank you, Dr. Navanita. I'd like to take the opportunity to introduce Dr. Lakshmi Kumar Venkataraghavan, who will be speaking on innovative neuro-interventional procedures, its anesthesia consideration. He is the Associate Professor, University of Toronto. He is the Director of Neuroanesthesia Fellowship Program, Toronto Western Hospital. And he is the Director of Neuroanesthesia Fellowships Program in India and UK also. His area of research of interest is in anesthesia for functional neurosurgery, functional neuroimaging, and improving patient outcome after neurological and spine surgeries, including daycare surgery. He has more than 120 peer-reviewed publications. So over to Dr. Lakshmi Kumar Venkataraghavan. Sir, please.
wonderful introduction and my sincere thank you for inviting me for this conference and giving me opportunity to present in this meeting. So my topic today is the innovative neurointerventional procedures and anesthesia considerations. I do receive royalty for my up-to-date book chapters. Apart from that, I don't have any disclosures. As we all know, traditionally, the neurointerventional procedures are focused on the treatment of intracranial aneurysms, arteriovenous malformations, carotid stenting, and more recently, the endovascular treatment of a stroke. In addition, we may be involved in the gamma knife treatment for brain lesions, and more so in a pediatric population than the adults. And however, in the recent years, there has been a significant advancement in the neurointerventional technique, focusing on the some of the newer neurological conditions. So, for example, middle meningeal artery embolization for chronic subdural hematoma, venous sinus stenting for idiopathic intracranial hypertension, and MR-guided focused ultrasound ablation for essential tremors, and the MR-guided laser interstitial thermal therapy for deep-seated brain tumors and as well as for epilepsy. So with this background, the learning objectives of today's presentation are to review the new neurointerventional procedures and to describe the neurointerventional treatment for chronic subdural hematoma, idiopathic intracranial hypertension, and essential tremors, and to discuss the anesthetic considerations and the perioperative anesthesia of care for patients undergoing these procedures. Due to lack of time, so I'll be focusing only on 3 of these new neurointerventional procedures. And I would not be talking about the MR-guided laser interstitial thermal therapy. So my first one is the middle meningeal artery embolization for chronic subdural hematoma. As we all know, the pathophysiology of subdural hematoma is that there's initiating event is a venous bleeding into the 2 layers of subdural space. And the bleeding can lead to inflammatory reaction, leading to thickening of the inner dural membrane. And as a process of healing, the fragile capillaries form within the inner dural membrane, which may further causes bleeding. And then there's more inflammation, more angiogenesis, and the bleeding, and this cycle repeats every 2-3 weeks. So hence the recurrent bleeding usually outpaces at the rate at which the blood products are reabsorbed, so leading to chronic, often sometimes recurrent subdural hematoma. And we all familiar, so depending upon the clinical presentation, the size of the hematoma, either they undergo observation or medical treatment, or they undergo surgery, and surgery is either a burr hole or mini craniotomy or a larger craniotomy, depending upon the size of the subdural hematoma. The problem with the surgical treatment is that the recurrent rate can be quite high. Up to 30% of them there is a recurrence. And these patients are usually elderly with the multiple comorbid conditions. They also have additional anesthesia risk, and they're more susceptible to post-operative infections, and the patients are usually on antiplatelets or anticoagulation medication, so it becomes very tricky when to stop it, when to restart the antiplatelet and anticoagulant medications. So one of the newer treatment is the middle meningeal artery embolization. And we all know familiar with the anatomy of the middle meningeal artery. So this is one of the branch of the external carotid artery, and which passes through the foramen spinosum, and it has got supply as anterior and the posterior branch of middle meningeal artery. So middle meningeal artery embolization is becoming a popular alternative strategy to surgery for the treatment of chronic subdural hematoma. And chronic subdural hematoma is prevalent in aging population, projected to double from 10 to 18 over 100,000 over the next decade, making it likely the most commonly treated cranial neurosurgical condition in adults in 8 to 9 years from now. And earlier studies have demonstrated the favorable outcome with the middle meningeal artery embolization when compared to conventional surgical evacuation. And middle meningeal artery embolization has stabilized or improved in 91 and 98% of elderly and advanced elderly groups, respectively. These are the two papers which came out a couple of years ago, the single center experience and as well as the multi-center experience, looking at the very, very favorable outcome with the middle meningeal artery embolization compared to surgery. This is one of the patients. The first one is presented with the subdural hematoma, and the second image in the middle image is the after 2 weeks, and the last image is the 4 weeks after the middle meningeal artery embolization. See, the major complications are very rare, but some patients may develop cranial nerve 7 or a facial nerve palsy. And there are also, we need to watch for ophthalmic collaterals, which may be involved accidentally with the embolization part. And they may have a delayed infarction and delayed seizure, and some people may have an intermittent aphasia. These are the side effects, but they are extremely rare. From the anesthesia aspect of it, and if the patient is cooperative with a good GCS, this can be done with the light to moderate sedation. And if the patient is not that cooperative and if you worry about the patient movements, then they may need a general anesthesia. For example, for a unilateral procedure, usually takes around an hour. And for sometimes the bilateral procedures can be up to 3 hours or so. So they probably need a general anesthesia. And in our center, we moved on to a transradial approach and compared to the transfemoral approach. And then we found that the transradial approach is much superior, and they don't need to lie flat for 4 hours as a result of a transfemoral approach. So they can able to sit up and they can resume their activity straight away. So the second neurointerventional procedure I'm going to talk about is the venous sinus stenting for idiopathic intracranial hypertension. And idiopathic intracranial hypertension, as we all know, it's also called as the benign intracranial hypertension or a pseudotumor cerebri. This is the clinical syndrome for raised ICP in the absence of space-occupying lesions or vascular lesions without enlargement of the cerebral ventricle, for which no causative factor can be identified. And it is 15 to 100 per 100,000 people as per the statistics from US. And it's most common in women, 4 to 15%, 15 times compared to men. And the majority of the patients are obese. And it often happens in a younger age group between 28 to 35 years. And it is quite a debilitating condition because of the clinical presentation. They have a significant disabling headache with the nausea and vomiting. Some people may have such a high intracranial pressure leading into papilledema. And other presentation is the pulsatile tinnitus and vertigo. Interestingly, we've seen quite a few patients post-COVID also presenting with pulsatile tinnitus as well. The pathophysiology is not very clear. There has always been a debate between whether it is to do with the CSF production or the CSF drainage. And recently it has been found out that there is an extrinsic as well as the intrinsic compression or stenosis of the venous sinuses, especially at the transverse and sigmoid sinus section of it. So that is why the treatment of venous stenting came into the play here. And so the traditional treatment is the acetazolamide or symptomatic treatment for a headache and repeated LP to drop the pressures. And in extreme cases, in a patient with severe papilledema, they may do optic sheath fenestrations. And in rare cases, if they're still quite symptomatic, they may offer shunting, like a CSF shunting pathway. So the venous stenting is one of the newer treatment for idiopathic intracranial hypertension, especially when they have demonstrate that there is stenosis or intrinsic or extrinsic narrowing at the transverse or sigmoid sinus junction. As you can see in this diagram, the usual location is between transverse sinus and sigmoid sinus junction, and the placement of a stent. That's what the treatment for idiopathic intracranial hypertension. And usual venous axis, transfemoral venous axis, and the microcatheter. And then the key part of the procedure is that they need to measure the pressure differences across the stenosis. So usually they measure the pressure at the longitudinal superior sinus and the sigmoid sinus, and then you should have a gradient of at least 4 millimeters of mercury. And most of the time they don't need a balloon angioplasty, they just need to deploy the stent, and then they repeat the pressure measurement, and the final gradient should be 0 or negligible gradient. And they also should not have any residual stenosis. And the stenting outcomes, this is our data from our, this is a study done by one of the neurointerventionalists, and has shown that the improvement or resolution of papilledema is 93%, and the pulsatile tinnitus is around 90%, the recurrence rate is less than 10%, and the major complications are quite rare. From the anesthesia aspect of it, they're quite challenging patients. They have a high BMI. They have a quite significant symptoms, quite depressed. They have a polypharmacy, a lot of opioids and non-narcotic analgesia. And they need to be on dual antiplatelet therapy before the stenting and continue, followed by aspirin alone for 9 months. And we usually do a general anesthesia with or without arterial line, depending upon the comorbidities. And the key consideration is the intraoperative pressure measurement. I'll be talking about it in a second. And no major postoperative issues. And the usual complications are because of the groin puncture related. Some people may have a subdural hematoma because of sudden drop in intracranial pressure, or is related to a guide wire puncture. And some people may have quite a persistent headache for some time that is secondary to a meningeal irritation. And these people usually respond well with the steroids. So as I mentioned, that important consideration for anesthesiologists is that if this patient need a general anesthesia, increase in intrathoracic pressure usually increases the pressure in the sagittal sigmoid sinus. So the gradient between the transverse sinus and the sigmoid sinuses can become quite narrow. So one need to keep the intrathoracic pressure, airway pressure constant throughout the procedure. This is one of the study from Lenk et al., which showed that when you're doing a conscious sedation, the pressure difference or gradient is quite high, and general anesthesia pressure gradient is pretty low. So even a few millimeter changes in the intrathoracic pressure may change the gradient. So we need to make sure that the gradient is, the intrathoracic pressure is kept as minimum as possible. And the last part of my talk will be focusing on the MR-guided focused ultrasound treatment for essential tremors. And focused ultrasound is a high-intensity ultrasound waves were focused to converge in a precise target in the body. And the energy is absorbed by the tissues, which is converted into heat, and heating causes a tissue ablation. And it is confined to the target, sparing the neighbor tissue. So that's why it's called as a very focused. And it is not a new technique. They've been using for a treatment for fibroids and other intra-abdominal and thoracic pathology for a long period of time. And the newer application is for a neurosurgery. And the essential tremor causing a thalamotomy was the FDA-approved treatment of indication for a focused ultrasound. Parkinson's disease, and especially in a selected patients, pallidotomy is also being considered. And also focused ultrasound causing the blood-brain barrier disruption and the delivery of chemotherapy is another newer indication which is being explored now. Essential tremors, as you know, it's one of the most common movement disorders affecting around 10 million people in the US, and quite debilitating conditions. It is quite sad that these people cannot even perform a simple day-to-day activity like eating, drinking, writing. And it's a completely different spectrum, age spectrum to a Parkinson's disease. And then there are significant differences between the Parkinson's disease and essential tremors. And pretty much the treatment is that is either observation and medical treatment with the beta blockers, benzodiazepines, gabapentin, or botulinum toxin. So these all these agents which have been tried, or the surgery. Surgery is basically either thalamotomy, which used to be the standard surgery for essential tremors. Then with the development of DBS, deep brain stimulation has become one of the treatment for an essential tremors. So all these procedures does have invasiveness and the complications. So in compared to that is the MR guided focused ultrasound is a non-invasive or minimally invasive, usually unilateral procedures, and the high intensity ultrasound was targeted using a real-time MRI guidance, intact skull, no incision, real-time monitoring to optimize and personalize the treatment. As the tremor improves, then they can plan it when to stop the procedure. And most of the patient can be ready to go home same day. And one of the very interesting point is that they come into the MR suite where they can't even button the shirt. And then at the end of the procedure, they can able to drink and button the shirt in. So it is very satisfying to see the response at the end of the procedure. And inclusion is essential tremor refractory to treatment. And apart from the usual contraindication for MRI and the bleeding risk, one of the major contraindication is the thick skull, because if the skull density is high, then the ultrasound waves cannot pass through it, so the treatment may not be very effective. So basically, the procedure is done in MRI, and the identification of target or the identification of the thalamus, the ventral intermediate nucleus of thalamus, which is very similar to DBS procedures. So they do need to have a leg cell frame, they need to have a 3T MRI. The focused ultrasound equipment consists of a couple of things. One is that the outside, it's like a helmet kind of thing where we have an outside transducer array, and then inner cold water is being circulated so that you can dissipate the heat from the ultrasound. And then there is a water resistant rubber diaphragm which is placed on top of the head. Okay, and the process of heating up the tissue is called a sonification, and then MR thermometry measures the real-time temperature measurement. So nucleus ventralis intermedius, or ventral intermediate nucleus of thalamus, that's usually the target. And once they identify the target, they will start the heating process or sonification. And the initial stages, they want to make sure that the location is correct, and to see some benefit, and as well as there is no side effects with the sonification. And then they go into the ablative stage. They go up the temperature up to 55 to 57 degrees Celsius for a few seconds. And you may need like a 10 to 15 treatments at least till the symptom improvement. Some people may improve with 5 or 10 sonification. Some people may need like a 15-20 sonification. Each one lasts for very few seconds. So as you can see, the temperature measurement when they're measuring it, and the red indicates the temperature around 55 degrees, and the surrounding areas are between 45 to 50. So you can have a real-time assessment of temperature in the brain. And so they do intermediate testing every episode of sonification. So we go in and test the patient, ask them to draw a spiral, and you can see that this patient's pre-treatment spiral drawing versus the post-treatment spiral drawing, and you can see a clinical improvement in tremors as well. From the anesthesia-wise, the key to success is the precise localization of the target, and as the lesion is irreversible, and optimizing the treatment, the symptom control with no adverse effects. So you need to have an awake patient. So the role of anesthesia is to provide an adequate comfort, monitoring, and the diagnose and treat the complications. So apart from the usual challenges from remote locations and MRI precautions, patient needs to be quite awake, because the treatment depends upon the patient's response to treatment. So we have a no or minimal sedation, and the head fixed to the frame, so it causes the pain, restricted access to the airway, and the risk of aspiration. And the frame attached to the focused ultrasound equipment, pressure from a silicone membrane can be quite uncomfortable, and the patient may be lying flat for 4 to 5 hours. And sonification can cause a quite significant headache and nausea, vomiting because of the irritation of the dura. And so the blood pressure control is also important so that we don't have an intracerebral hemorrhage. So we usually give a prophylactic antiemetics, either with the ondansetron or granisetron with the dexamethasone. So you also keep other agents as a backup. And a second dose of ondansetron during sonification, because that's the time they're more likely to get nausea and vomiting from dural irritation. Some fentanyl for the frame placement and as well as the headache associated with sonification. And between sonification, you give a reassurance to the patient. Once they start seeing the improvement in the tremor, patients becomes quite motivated and they will be very happy. And post-procedure, so they always have some pain after the removal of the frame and analgesia as needed as well. And this is data from one of the hospital in Toronto called Sunnybrook Hospital. And these team are the first one who started doing the MR-guided focused ultrasound. And they presented 82 patients data as a case series published in 2 years ago. And they showed that only 1/3 of patients needed sedation or analgesia, and headache and transient paresthesia are the most common side effects. But usually prognosis is very good with this treatment. So the summary, with the technological advancement, more minimally invasive treatments are continuing to develop. So anesthesiologists need to understand the challenges and adapt and modify the practice. Thank you very much for listening. And this is the aerial view of Toronto in early winter. And it usually gets worse as the winter progresses. And this is my email and my Twitter. And if you have any questions, please feel to contact me. Thank you.
Thank you so much, sir. Now I shall request Dr. Prasanna Vidkar, sir, to introduce our next speaker, Dr. Francisco Lobo. Over to you, Prasanna, sir.
Thank you and good afternoon to all. Thank you, Dr. Lakshmi, for that excellent lecture on the newer innovative neurointerventional procedures. Move on to the last topic of this session. It is my pleasure to invite Dr. Francisco Lobo, who is presently the consultant in anesthesiology and director of research at Cleveland Clinic, Abu Dhabi, UAE. He has done his residency in anesthesiology from Portugal. He has worked as a consultant there in Portugal. He has worked in several parts of the world, including the USA. He has been the visiting professor to the Washington University of School. And he is in the board of directors for European Society of Intravenous Anesthesia and Euroneuro. He is now holding the steering committee of ISTAP, that is International Consortium for EEG Training of Anesthesia Practitioners. He has been the former member of European Society of Anesthesia and Intensive Care and former member of SNACC Scientific Committee. He is the authority in the field of intravenous anesthesia. So I welcome Dr. Lobo to present his lecture on total intravenous anesthesia in neurosurgery. Over to you, sir.
Hi, how are you? Thank you for your attendance for my second lecture in this ISNACC meeting. It's time to talk about intravenous anesthesia for neurosurgery and why and how to do it. So I'll try to review with you the general benefits of TIVA and why to prefer TIVA for neurosurgical patients, and in the end, some tips and tricks and some examples of how to optimize the practice of TIVA with target control infusion in neurosurgical patients. Everything very squeezed in 20 minutes. Well, Mike Irvin and the other authors, they wrote this great review article 2 years ago, published in the Anesthesia journal. It's a great review addressing all the benefits of TIVA compared with inhalational anesthesia technique. when we talk about TIVA today, I think that we should agree that we are talking about target control infusion of propofol, remifentanil, eventually dexmedetomidine, and some other drugs that I'm going to mention after, titrated or guided by brain function monitors, electroencephalogram, and hopefully also some monitors of the nociception and T-nociception balance. And this idea of different drugs as different components of the total intravenous anesthesia approach is based on this very new concept of multimodal general anesthesia described and developed by Emery Brown and Maruza Naranjo. And the idea is that we should use different drugs acting by different mechanisms in different networks in the brain to achieve the main goals of the general anesthetic states. I mean, unconsciousness, anti-nociception, and immobility and absence of reflexes. And ideally, these different drugs should be administered with target control infusion if a pharmacokinetic pharmacodynamic model is available and in one TCI pump. TCI is mandatory nowadays as when we talk about TIVA. Why? Because if we compare a manual infusion based on populational average weight derived dosing schemes, well, TCI achieves a stable drug effect with a proportional titration, is faster to adapt the concentration, minimizes side effects, and so in the end, we are going to spare a lot of drugs with obvious economical consequences. In the particular case of neurosurgical patients, why to use TIVA? Is there any special reason to use it? Well, the first one, I would say that is to fight boredom. All of us involved in neuroanesthesia in India, in Portugal, in UAE, in US, we are used to this. So the neurosurgeon keeps saying, it's almost done, it's almost done, and 3-4 hours after is saying, it's almost done. So if we have these many pumps and many monitors, we'll try to, we'll avoid situations, shameful situations like this one. So that's advantage to have all these monitors and pumps. Well, actually, what do we want when we talk about anesthesia for brain and spine surgery? Many of these issues are common to every patient, right? So a smooth induction, airway stability, a stable and smooth maintenance without or a minimal interference with CNS physiology, especially when you use intraoperative neuromonitoring with evoked potentials, for example, allowing this adequate neuromonitoring, providing a good operative field and a relaxed, cool neurosurgeon, and then in the end, a fast and smooth awakening with a fully recovery for a prompt neurological evaluations. It's classical. Anyway, after decades of research, I think that we still did not agree about TIVA or inhalation. Or do we? I think we have strong evidence today that tell us that we should use TIVA. Well, the basic is the physiology and the pharmacology. All of us know that inhalational, they have effects in the cerebral blood flow and in the cerebral metabolic rates, right? So, and while the intravenous anesthetic drugs like propofol, dexmedetomidine, well, we know this since the first year of our residency, right? So decreasing cerebral blood flow, decrease proportional, decrease in cerebral metabolic rates, and a decrease in the intracranial pressure. So if we have, for example, a patient with a brain tumor, we don't know in which point of the pressure volume curve the patient is. So imagine that the patient is somewhere between point B and point C, and you use, for example, sevoflurane, right? Sevoflurane, well, can increase the cerebral blood flow, and this increase in the cerebral blood volume can be enough to bring the patient from point C to somewhere between C and D. So, and a disaster, right? So, and we know this, we don't know how much anesthetic drug concentration the patients will require to be with an adequate level of anesthesia. Sometimes we listen, some colleagues say, well, I start with inhalational anesthesia, and then if the brain starts to be tense, well, I change to propofol-based anesthesia. Well, why not to start from the beginning with Tiva, correct? So what do we have published comparing Tiva with inhalational anesthesia, for example, for brain tumor surgery? I have to say that Tiva versus the clinical studies addressing these comparisons are like something like comparing oranges with apples. We cannot compare that. Different methodologies, much more strict when the authors use Tiva, for example, the last trial, a big trial, neuromorphil trial, still using the old Bristol formula of Price Roberts of propofol from the 80s. So what do we have to follow? I think that it's a meta-analysis published in 2014 that is very clear. ICP values were lower and CPP values higher with propofol maintained anesthesia. And it's clear like this, physiology and pharmacology are there. And spine surgery, any difference? Well, we have to think about spinal cord physiology. It's very similar with the brain physiology. I love this title, is the core, the microcosm of the brain. I think that we agree that yes, right? So, but there are some different issues. For example, the needs, that also applies to the brain surgery. In brain surgery, we also use evoked potential monitoring. So it's the same. It's more common for spine surgery, but we know that intravenous anesthesia is safer to keep reliable the evoked potentials monitoring, right? So, there are some very interesting small studies, but showing on a very good methodology some advantages. For example, this study published some years ago by Polans and Vincent Bonhomme in Belgium showed that patients having smoking habits, so they had less cough during and after extubation, after C-spine surgery, when Tiva was used. Quite important, right? So, and the same, not for cervical, but for lumbar disc surgery, the same, the frequency of coughing during emergence, much lower with Tiva than with inhalation. I think that I would like just to have some minutes discussing these new three musketeers of the multimodal general anesthesia applied to neurosurgery: ketamine, dexmedetomidine, and esmolol. And I think that we should start to think that in reality, we should include these drugs in our daily practice. Esmolol has important effects in the hemodynamic control, for example, during emergence, but it's not only this. So eventually, has some protective effects during ischemia in spinal cord and the brain, but I think that mainly for spine surgery, esmolol, a very low dose of esmolol has a strong effect in antinociception, an effect not connected with a beta-adrenergic effect or antagonist beta-adrenergic effect, and it's independent with a local effect in the spinal cord modulation of the nociceptive impulse going to the brain. And it's really important. Ketamine, the low dose of ketamine as a known role as antinociceptive and anti-inflammatory drug also. And dexmedetomidine, I think that should be mandatory today to use dexmedetomidine. Its role in neurosurgical patients is very important, very well described during brain and spine surgery. It's essential, for example, in deep brain stimulation. I'll show you that after, without interference in the neurophysiological recordings during the location and the placement of the sensors. And very interesting, this study shows that patients having acute thrombectomy during acute stroke, those patients who had dexmedetomidine during anesthesia, they had a better recovery and a faster recovery of the motor and cognitive performance after thrombectomy. And the antinociceptive effect of dexmedetomidine, the mechanisms of antinociceptive effects of DEX are very well described, and I think that we should clearly use it during brain and spine surgery. So something that hardly we can get with inhalational anesthesia is the post-operative time for analgesia. So, for example, in this study that we published many years ago, so we show that keeping remifentanil during emergence, during extubation, and slowly decreasing the remifentanil in the PACU, it's an excellent strategy to optimize the post-operative pain management. But it's very important, as one study by Johan Redar from Oslo University show, it's a way to decrease the complications of hypersensibility to hyperalgesia, of remifentanil. And even we can have TCI of patient-controlled analgesia of remifentanil. So what I think it's important is to measure also the effects of the drugs. And so for that, I think that we should focus on the brain. And this applies to the neurosurgical patient, but also the non-neurosurgical patients. And it's our task as brain guys, as Dr. Brains, to teach our colleagues that we should use brain monitoring during anesthesia, namely the EEG, the spectral analysis of the EEG, the cerebral oximetry, and also some way of monitor the nociception and antinociception balance. My experience is clear, either with heart rate variability derived monitors like the ANI. And so the last part of my talk, I would like to share with you some tips and tricks that we are used to discuss in our teaching sessions here in Eurosiva, and some examples of neurosurgical patients. So this is a paper that we published some years ago. I think it's free in the web. So we give a lot of tips and tricks how to safely use TIVA and TCI. So a very common question is about model, PK/PD models. My model is better than your model. So Marsh, Schneider, and Elveld now. So we have so many models. And for example, we discuss a lot that Schneider model has very poor rationale. For example, the fixed central compartment V1 that is equal for a big guy or a small guy is nonsense, for example. And we cannot use the Schneider model, for example, for obese patients, we have this cutoff of lean body mass that they use. So if we have a very short guy and with weight achieving a maximum lean body mass, then the lean body mass by the James equation goes to 0. So why to use this model if we have another options like the Marsh model or now the Elveld model, which is based on allometric size scaling. So I can share if you want, just email me. I can share you the summary. This is a cool slide for a screenshot. It's a summary of the different models of propofol, dexmedetomidine, and ketamine, for example. And just to finish, I'm running out of the time. So some examples of how we can use TIVA-TCI in some special interventions, neurosurgical interventions. Awake neurosurgery is very, very common. So my approach that we suggest in this editorial is to have a awake asleep technique with an intraoperative awakening and performing the craniotomy with a patient under GA and a supraglottic device like a third generation of laryngeal mask. For example, this patient, we published this study using simulations. We had not the TCI when we did some of these patients while working in US. As you know, US, we don't have TCI there. So we identify the ideal concentrations of propofol and remifentanil guided by BIS. So and allowing an intraoperative awakening of 3 minutes. With the time we split from the BIS guided anesthesia for a pure EEG and spectral and spectrogram guided anesthesia, and now we have intraoperative awakening.
No filme? Pronto.
Very smooth.
Bom dia.
Awakening.
Viva o Benfica.
Yeah. This is important for deep brain stimulation and functional anesthesia. So there's a patient with a very difficult dystonia. Classically, it's done with general anesthesia because it's difficult to control the dystonic movement. So we did a different approach here. And you see the movements of the patients, of the limbs, of the heads, quite more marked than the Parkinson disease. And so what we did in this first case, and then we replied to many others, was to perform the initial part with going to the imaging suite with intubation with propofol, remi, and dexmedetomidine, and placement of the frame. And then the patient awake with a tube, just in case, and guided by see the patient awake here. And so with the control movements and reliable recordings, according to neurophysiologists. And what we were doing was and that's how we do it, is to have a fixed TCI dexmedetomidine infusion, and then we change the concentrations of propofol depending of the need of the patient is more or less awake. And you see here the transitions of sleep, awake, awake, asleep again, guided by the EEG. Minimally invasive brain surgery like stereotactic biopsies, awake with a scalp block and remifentanil, for example, and transitions in the different moments of the surgery, or for deeper lesions like this one, we may use, for example, scalp block and dexmedetomidine. This was an example of a very sick patient for evacuation of this large subdural hematoma, and plasma control of dex, and propofol with scalp block, very low dose of dex, and remifentanil and propofol, guided by the EEG and also the cerebral oximetry. You can even see here where we were performing the
Seu Marcos, como é que o senhor se sente?
fully awake after the surgery. And just to finish, just small tips about spine surgery, a very a big AVM between C4 and D5, propofol, remifentanil, ketamine, esmolol, dex, and 16 hours of anesthesia. And the patient, between the patient was supine to extubation, just 45 seconds. And the extubation of this patient was, well, it was the patient being
Ao texto que tens na boca. Abres a boca.
E agora puxa.
Tens que abrir a boca.
Keeping some low dose of remifentanil, as I said before. So very stable, the hemodynamic of these, the concentrations, very low concentrations of remi, of propofol, and very stable the hemodynamic. Lumbar spine, here, propofol, remi, guided by EG and ANI, a very low dose of dex, remi, and propofol again. So I think that we may use these examples to show you how use the multimodal general anesthesia approach and guided by EG and the nociception and tenoception balance. We optimize the outcome. So thank you very much for your attention, and I'll be free to share the lecture and some doubts after that. Thank you very much.
Thank you so much, sir. So we are running really short of time. I would like to request our chairpersons to open the session for question answers. Most of them have been answered in the chat box. Over to you, chairpersons.
Yes, Dr. Lobo, there is a question in the chat box. What additional advantage does dexmedetomidine offer over remifentanil or fentanyl?
I think that we shouldn't see dexmedetomidine replacing remifentanil or fentanyl. Well, the idea of this multimodal general anesthesia is to include dexmedetomidine with propofol and remifentanil, and because dex with a different mechanism of action, acting on a different neural circuits, contribute to complement the effects of drugs like remifentanil. So using these different drugs, what we do is to using these different drugs, we may decrease the dose of each of them. So we decrease the chance to have side effects, delayed emergence. So using dexmedetomidine as a component of a general anesthesia, we have a very reliable way to provide anti-nociception along with a low dose of remifentanil also.
Yeah, thank you. But what will happen to the processed EEG monitoring when we use multiple combination of drugs, particularly, for example, dexmedetomidine or ketamine, and we are monitoring a processed EEG, and how are we going to rely on that monitor?
Yeah, that's a great question, and to reply to your question is justify to use raw EEG and the spectral analysis for every patient. And look this example. For example, a patient having a complex spine surgery. So we start with a propofol infusion. So we expect to have mainly delta and alpha waves in the EEG, okay? So then we want to start a low dose of ketamine. So what's a low dose of ketamine? It's a dose that provides anti-nociception without hypnotic, let's say, effects. In other words, it's a dose not inducing changes in the EEG. So if you imagine how propofol and ketamine works in the brain, so they compete for the same interneurons between the cortex and the thalamus. So if you have a stable initial infusion of propofol, alpha and delta activity in the EEG, if you add ketamine, and if you see decrease in the power of alpha waves or the appearance of fast activity in the EEG, so you say, this is not a low dose of ketamine, this is high dose of ketamine for this patient. So you should decrease that dose of ketamine. Dexmedetomidine, for example, also induce alpha oscillations. However, the shape of the spindles induced by dexmedetomidine is different than the shape of the spindles induced by propofol. And so if you can imagine the spectrogram of propofol anesthesia, so it's a continuous red line on the band around 10 Hertz. So if you start dexmedetomidine infusion after, and if the dose of the dexmedetomidine is going to be too high, you can see a different pattern of alpha spindles, or you can see some more discontinuity in the bands of around the 10, with an increase to 12, 14 Hertz of frequency. So yes, so we should monitoring the EEG, the raw EEG, and the spectrogram allow us to make the difference of what is the major contribution of these different drugs, propofol, dexmedetomidine, or eventually ketamine. If you look only to the number, you can do it. So that's one advantage, as I was discussing also, I think yesterday, to use to move on from the single number, dimensionless number of this anesthesia depth scales to raw EEG and spectral analysis.
Yes. We have two questions for Dr. Venkataraghavan. In which group of SDH cohort you will recommend MMA embolization? This is number one. And number two is, have you considering using sedation for the venous sinus stenting?
Thank you for the great questions. So currently we are in the phase of doing both craniotomy as well as the embolization. So we are trying to do more patients toward MMA embolization for a chronic subdural. So now anybody with a good GCS, so we tend to do the embolization first, as well as the patients who have a recurrent hemorrhage after the burr hole. So now we're trying to do the embolization. The plan is to move most of these procedures to MMA embolization. So we're in the process. Regarding the venous stenting, yes, venous stenting can be done under sedation. Unfortunately, we tried, we do some patient under sedation, but these patients, as I mentioned, they have a high BMI, they have a multiple opioid analgesia. They're not a great patients. So we do them under general anesthesia, but sedation is a good choice if the patient is cooperative.
And if it is sorry, what about the patient presents with the midline shift with an SDH? Do you still recommend?
No, if it is, that's what I said. If the patient is have a good neurological to baseline, so we try to do an MMA embolization. If they need an urgent neurosurgical intervention, obviously they need a decompression.
Thank you, sir. So we are running short of time. Sir, any further questions? I think we don't have any questions here. So with the permission of the chairpersons, should we consider this session to be closed?
Yes.
Anand, sir?
Yes, thank you.
Yes, thank you, Dr. Thank you all the speakers.
Thank you very much for inviting.
Thank you, Dr. Venkat.
Thank you, chairpersons. Thank you, speakers, for this wonderful session. Now we move on to our next session, which is a debate on ICP versus CCP targeted management in neurocritical care patients. To chair this session, I would like to request Dr. Dilip Kulkarni sir and Dr. Monica Tandon ma'am to join us on the dais. A very warm welcome to ma'am and sir. A few words on the chairpersons. Dr. Dilip Kulkarni sir.
Yeah, I'm audible? Okay.
Yes, sir.
Okay.
Sir has done his MD in anesthesiology from PGI Chandigarh. He is currently attached to the Department of Anesthesia, ESIC Medical College and Hospital, and was previously retired as a senior professor, Department of Anesthesiology and Intensive Care, as an associate dean and executive registrar from Nizam's Institute of Medical Sciences. He was a former president of ISNACC and the recipient of the Vaidishri Award in 2010. He has presented 70 papers in different forums and has 68 publications and 3 chapters in various books, and has been the section editor for original articles in the Journal of Neuroanesthesia and Critical Care. A very warm welcome, sir.
Thank you. Thank you for the introduction.
Monica Tandon, ma'am. Ma'am, she's a director professor of GB Pant Institute of Postgraduate Medical Education and Research, New Delhi. She's a section editor of SNACC and has 62 publications in national and international journals. She has 12 chapters in books on neuroanesthesiology and critical care. She's a co-editor of the Transfusion Practice in Clinical Neurosciences. She's also the examiner and thesis evaluator of various neuroanesthesiology exams like DM and PDCC. A very warm welcome to ma'am. Now I would like to request Dr. Dilip Kulkarni sir to introduce our first speaker for this session, Dr. Ashutosh Kaushal. Over to you, sir.
Thank you. At the outset, I will congratulate for the very good SNACC conference and also giving me opportunity to chair this session. And belated New Year for all my senior and colleagues of SNACC Society and the delegates. And now I'm going to introduce Dr. Ashutosh Kaushal. He is Associate Professor in Anesthesia Critical Care, AIMS, Bhopal, and he qualified with MD, DNB, PDCC, and DM Neuro Anesthesia Critical Care from AIMS, New Delhi. And he published more than 50 research papers in various index journals, wrote multiple book chapters, reviewed for 7 index journals, many papers presented in national and international conferences, and international travel grant award also awarded from South Korea. And his area of interest is minimally invasive neuroanesthesiology, neurocritical care, head and neck pain management. And now I request Dr. Ashutosh Kaushal to talk on ICP target management in neurocritical care patients.
Very good evening, everyone. I am very thankful to organizing committee for providing me opportunity to talk in this conference. 2 different main concepts for the treatment of neurocritical care patients have been tried during the last 25 years. Namely, the more conventional concept in the form of the ICP targeted therapy on the one hand and the CPP targeted therapy on the another. Till date, still there is controversy regarding superiority among these 2 modalities. So in this talk, I will discuss regarding pro part of the ICP targeted therapy in neurocritical care patients. I have no financial disclosure or conflict of interest to declare in relation to this presentation. Severe intracranial hypertension leads to brain herniation syndrome, cerebral hypoperfusion, cerebral ischemia, secondary brain injury, and ultimately fatal outcome. So mainstay of the care of the patients with the most severe brain injury has been the monitoring of and the treatment of intracranial patients. ICP is a valuable indicator of injury severity after severe traumatic brain injury, and there is a well described relationship between intracranial hypertension and mortality after the severe traumatic brain injury. So this relationship becomes proportionally greater as the value of ICP increases with a six-fold increased risk of death when ICP is greater than 40 mm of Hg. Over the years, the definition of what ICP threshold dichotomizes acceptable and dangerous ICP elevation has been extensively debated, and the value of ICP monitoring has also been questioned. However, the current Brain Trauma Foundation guideline recommend ICP monitoring as level 1 and 2A recommendation that there is insufficient evidence to support this topic, whereas level 2B recommendation suggests that management of severe traumatic brain injury patients using information from ICP monitoring is recommended to reduce in-hospital and 2-week post-injury mortality. Whereas the previous Brain Trauma Foundation editions, which is not supported by evidence meeting current standards, describes that ICP monitoring can be done in salvageable severe traumatic brain injury patients with the abnormal CT scan or severe traumatic brain injury patients with a normal CT scan with 2 or more than 2 criteria at the patient admission, that is age more than 40 years, unilateral or bilateral motor posturing, or systolic blood pressure less than 90 mm of Hg. Coming to the ICP threshold, the Brain Trauma Foundation 4th edition suggests that level 1 and 2A evidence says that there is insufficient evidence to support a level 1 or 2 recommendation, whereas level 2B says that treating ICP above 22 mm Hg is recommended because values above this level are associated with increased mortality, whereas level 3 says that a combination of ICP values and clinical and brain CT findings may be used to make management decisions. So there are many studies which are in favor of ICP targeted therapy, and on another hand, many studies which are in favor of cerebral perfusion, pressure targeted therapy. Here I am included few studies which are in favor of ICP targeted therapy. So in this study, the authors aimed as to compare the effectiveness of the ICP targeted therapy versus the CPP targeted therapy in secondary brain injury patients after aneurysmal subarachnoid hemorrhage and the traumatic brain injury. Whereas in this study, the ICP targeted therapy was achieved with using modified Lund consent. So this was a prospective randomized control study in which 60 comatose operated patients with the secondary brain injury were randomized. In ICP targeted therapy, CPP of 60 mm Hg was achieved, ICP less than 50 mm Hg, and the systolic blood pressure of 100 to 120 mm Hg was achieved, whereas in CPP targeted therapy, CPP more than 70 to 80 mm of Hg along with ICP monitoring was achieved, and they analyzed the mortality rate and the tissue biochemical signs of the cerebral ischemia on the basis of cerebral microdialysis, and outcome was achieved using Glasgow outcome score. So they found that the mortality rate was 20% in ICP targeted therapy groups, whereas it was 43.3% in CPP targeted therapy groups. they concluded that ICP-targeted therapy based on modified Lund concept provides a superior alternative to the CPP-targeted therapy in the treatment of comatose operated patients sustaining secondary brain injury as a result of aneurysmal subarachnoid hemorrhage and severe traumatic brain injury patients. In another study, the aim was to compare the effects of two different protocols, that is reducing intracranial pressure and maintaining cerebral perfusion pressure, on physiological characteristics and outcome in patients with brain trauma. A series of 67 patients in Uppsala were treated according to a protocol aimed at keeping ICP less than 20 mmHg and a secondary target cerebral perfusion pressure at 60 mm of the Hg. In another series of 64 patients in Edinburgh were treated according to a protocol aimed primarily at maintaining CPP more than 70 mm of Hg and secondarily ICP less than 25 mm of Hg for the first 24 hours and 30 mm Hg subsequently. The ICP and CPP insults were assessed as the percentage of monitoring time that ICP more than or equal to 20 mm Hg and CPP less than 60 mm Hg respectively. And the outcome was analyzed at 6 months according to Glasgow Outcome Score. So, an important component of cerebral pressure autoregulation is the ability to maintain a stable ICP for a wide range of mean arterial blood pressure levels. Patients are described as the pressure passive if ICP varies together with mean arterial blood pressure, and the pressure active if ICP varies inversely with mean arterial blood pressure. But if ICP was stable over a wide range of mean arterial blood pressure level, then patient was described as pressure stable. Pressure reactivity in each patient was assessed based on the slope of regression line relating mean arterial blood pressure to ICP. The x-axis of the graph represents increasing values of the variable, whereas the y-axis the probability of a certain outcome, for example, death or good outcome. So this was derived with the help of Bayesian neural network model to predict the likelihood of good or bad clinical outcome using a pressure reactivity index among severe traumatic brain injury patients managed using either ICP or CPP based treatment strategy. So according to this data, the optimal point at which to switch from one management strategy to another is when the mean arterial blood pressure by ICP slope is 0.13. The CPP, in the CPP oriented protocol, even short duration of CPP insults was strongly predictor of the death. The pressure active, that is the slope less than 0.13, patients had a better outcome, whereas in ICP oriented protocol, even long duration of CPP insult was significant predictor of favorable outcome. The pressure passive patients, that is the slope more than equal to 0.13, had a better outcome in ICP oriented protocol. So they concluded that relatively low CPP in the range of 50 to 60 mmHg is not harmful in many cases and in fact is associated with a favorable outcome. Whereas in ICP oriented therapy should be used in patients whose slope of regression line is at least 0.13, and if the slope is less than 0.13, then hypertensive CPP therapy is likely to produce a better outcome. So the combined approach should be used to achieve better overall patient outcome than either protocol separately. This is another study in which authors aim to know the relationship and relative importance of ICP and CPP in severely head-injured patients by examining the higher risk groups who manifest neurological deterioration following initial resuscitation after admission to the hospital. They hypothesized that CPP is more important in influencing outcome, so they investigate the same in their study. They examined the relative contribution of ICP and CPP parameters to outcome in a series of 427 patients prospectively studied in an international multi-center randomized double-blind trial of N-methyl D-aspartate antagonist, self-etal, conducted by Morris G.F. et al. In previous studies. So adherence to the American Association of Neurological Surgeons guideline was maintained in more than 90% of the patient population, and patients in each of the study centers were treated using a defined protocol for head injury management with emphasis on prevention of secondary brain injury, including criteria for initiation of treatment for elevated ICP and for maintenance of CPP at level higher than 60 mmHg when possible. The most powerful predictor of neurological worsening was the presence of intracranial hypertension, ICP more than equal to 20 mmHg, either initially or during neurological deterioration. And there was no correlation with the CPP as long as CPP was greater than 60 mmHg. In the presence of intracranial hypertension, the mortality rate was 93 as opposed to 46% in patients without ICP elevation regardless of their CPP. The favorable outcome was seen in 7% of the patients with the ICP elevation and in 32% of the patients in this subgroup who did not have intracranial hypertension. So they finally conclude that treatment protocol for the management of severe head injury should emphasize the immediate reduction of raised ICP to less than 20 mmHg if possible, and a CPP greater than 60 mmHg appears to have little influence on the outcome of patients with severe head injury. This is a study done by Robertson et al. In 1999, and the purpose of this study was to compare the effect of two acute care management studies on the frequency of jugular venous desaturation and the refractory intracranial hypertension and on long-term neurological outcome in patients with severe head injury. This was a randomized control trial in which 189 adults admitted in coma because of severe head injury were recruited, and patients were divided into two protocols, CBF targeted protocol in which CPP more than 70 mmHg and PSO2 of 35 mmHg was maintained, whereas in ICP targeted protocol, ICP less than 20 mmHg and CPP more than 50 mmHg with the PSO2 in a range of 25 to 30 torr was used to treat intracranial hypertension. The CBF targeted protocol reduces the frequency of jugular desaturation from 50% to 30%, and the risk of cerebral ischemia was 2.4-fold greater with the ICP targeted therapy, but there was 5-fold increase in frequency of ARDS in CBF group. So they concluded that although the secondary ischemic insult was lesser in CBF targeted therapy, but the beneficial effect of CBF targeted protocol may have been offset by development of the ARDS. This is a pilot trial which compares cerebral perfusion pressure with the intracranial pressure targeted therapy in children with the severe traumatic brain injury. This was a randomized control trial to assess cerebral perfusion pressure and the intracranial pressure therapies in 17 children. In ICP group, ICP less than 20 mmHg and CPP more than 50 mmHg were achieved, whereas in CPP group, CPP more than 70 mmHg for more than equal to 2-year-old patients and more than 60 mmHg of CPP was mentioned for patients lesser than 2 years of age. The outcome was analyzed as death or functional outcome at 1 year post-injury. The median GCS in the CPP group and the ICP group was 6 and 7. In CPP group, 2 patients died. 1 was lost to follow-up and 4 were unimpaired and 5 had mild impaired. Whereas in ICP group, all patients survived. 1 was lost to follow-up, 2 had mild impairment, and the 2 had hemiparesis and the moderate impairment. And there were 4 unimpaired survivors in the CPP arm compared with none in the ICP arm. So they concluded that the CPP method appears to be safe, although this feasibility study does not stabilize that CPP therapy is superior to ICP therapy. So, owing to the lack of well-controlled randomized outcome studies comparing ICP versus CPP targeted therapy approaches, we cannot conclude that one is better than other. Neurocritical care patients, including TBI victims, are not a homogeneous group, and more studies are needed to give evidence-based individualized care in order to further improve the outcome for these patients. Obviously, adequate perfusion of the brain is essential and should not be overlooked. However, treatment of CPP without therapy aimed at decreasing intracranial hypertension appears to be inappropriate. Thus, it appears safe to conclude that when efforts to keep the CPP in higher range of successful intracranial hypertension remains a major predictor of neurological deterioration and ultimately of outcome. Even though no level 1 evidence to support the use of a generic ICP threshold, it is clear that ICP remains important to and the foundation of severe traumatic brain injury neurocritical care patients. Thank you very much.
Thank you, sir. Thank you so much. Now I would like to request our next chairperson, Dr. Monica Tandon, ma'am, to introduce our next speaker, Dr. Zulfikar Ali. Over to you, ma'am.
Yeah, thank you, Navanita. It's my pleasure to introduce a very distinguished colleague, Dr. Zulfikar Ali. Hello, am I audible?
Yes, ma'am, you're audible.
Yeah, I'm audible, yeah. Dr. Zulfikar is an additional professor in neuroanesthesia at the Sher-e-Kashmir Institute of Medical Sciences at Srinagar. He heads the neurosciences ICU and is also the course director for the DRNB Neuroanesthesia Neurocritical Care Program. Dr. Zulfikar has won many laurels. He's a recipient of the ISA President's Appreciation Award in 2015, the ISA Proficiency Award in 2021. He's also the section editor for the Indian Journal of Anesthesia and an executive member of the All India Difficult Airway Association. In the past, he has been an executive member of the ISNACC, and he has made a lot of active contributions to the formulation of several guidelines and practice statements, especially for ISNACC and for the Indian Society of Anesthesiology. Last year, there was a consensus statement regarding monitoring in neuroanesthesia, and I think there was another one on fasting guidelines that was published by the Indian Society of Anesthesiologists, and Dr. Zulfikar had a very, very active role in that. Over the next 15 minutes, Dr. Zulfikar is going to try and convince us that cerebral perfusion pressure targeted therapy is the treatment of choice for neurocritical care patients. Over to you, Dr. Zulfikar.
Thank you, Dr. Monica. Am I audible?
Yes, you are.
Are my slides visible?
Yes, they are, Dr. Zulfikar.
Yeah, thank you. Thank you, everybody. I would like to, before starting, I would like to thank the organizers for giving me a chance to be a part of this academic event. I'll be briefly putting my waves forward. That cerebral perfusion pressure targeted therapy, it's helpful in the treatment of patients while they are being managed in a neurointensive care unit. As all of us know that once we manage patients in neurointensive care unit, the basis that we need to keep in mind is that we have to try to minimize their intracranial hypertension and to prevent the secondary brain injury. And once we concentrate on secondary brain injury, the cerebral perfusion pressure, its management, it becomes vital because it's this cerebral perfusion pressure that determines the driving force of the cerebral blood flow in the brain, and it determines the oxygen supply and the metabolite delivery to the brain once a patient is being treated. Unfortunately, we do not have a clear-cut understanding of the factors that determine the cerebral blood flow. What we currently presume is that a complex set of factors in the form of myogenic, metabolic, and neurogenic factors, they regulate and they somehow intricately manage the balance as how much blood should the brain receive at a particular point of time. As Dr. Ashutosh nicely pointed out, that once we manage these patients in neurocritical care unit, ICP monitoring has a very important role. Nobody can deny that. And there have been a lot of studies that have shown that ICP monitoring, they improve the outcome in a neurocritical care unit. But if we see most of the studies that have tried to address this issue, most of them are large observational studies, and many of them are retrospective analysis. We do not have many studies. We have very few randomized control trials that have tried to show the benefit of ICP monitoring guided techniques once we compare it to the cerebral perfusion pressure monitoring techniques. It was way back in 1977, once this issue was first addressed by the Miller in 1977. And what the authors at that point of time found that ICP is in fact a very powerful predictor in determining the outcome of a patient in a neurocritical care unit. But as of now, we do not have any study that has shown that ICP is an independent predictor of mortality in a neurocritical care unit. As Dr. Ashutosh showed these studies, we have many studies that have shown that as the values of ICP increases, the mortality increases. So if we have an ICP of around 40 millimeters of mercury, the mortality in a neuro-intensive care unit, it may be as high as 80%. With a progressive increase in the ICP values, there is a progressive increase in the mortality. But unfortunately, if we only try to decrease the ICP values, we are not going to change the mortality. So once we have to improve the outcome, we have to keep two things in mind. At the same time, once we decrease the intracranial pressure, at the same time, we have to improve the cerebral perfusion pressure. Once we do both these hands side by side, we do both these maneuvers side by side, they are definitely going to improve the outcome. Again, this is one of the studies that was published in 1992, and this study was one of the first studies that tried to use transcranial Doppler in head injury patients. And from this study, what we see is the cerebral blood flow. It's least on the first day of head injury, and again, it's very less. It's less on 3 to 4 days after the head injury. So during these two stages, that's the phase 1 and phase 3, the authors observed that the middle cerebral artery velocities, they are the maximum. So probably this decreased blood flow is one of the features that may contribute to the mortality of patients once we are having patients with severe head injury. Any maneuver that would physiologically increase the blood pressure, whether it's by the use of inotropes or hypervolemia, if it's really effective, it could lead to a change in the outcome. It could improve the outcome in the long term once our patients. Based on these things, we have over a period of time developed two types of approach. We have the ICP targeted approach and we have the CPP targeted approach. If we see the ICP targeted approach, we conventionally have been following it before the CPP targeted approach came into existence. And the main aim of ICP targeted approach has been to keep the cerebral intracranial pressure less than 22 millimeters of mercury, coupled with sedation, paralysis, CSF drainage, and osmotherapy. While as in CPP targeted approach, we have tried to maintain an optimal cerebral perfusion pressure. Unfortunately, we have not been able to derive a value of an optimal cerebral perfusion pressure till date. That's an area where an ongoing research is going on. But we have seen from the post-mortem studies that if we lose any patient in the neurocritical care unit, particularly patients with traumatic brain injury, and if we subject them to autopsy, as many as 90% of the patients, they do have cerebral ischemia. So the physiological basis of the cerebral perfusion pressure management strategy, it tries to ameliorate, it tries to break the vasodilatory cascade. At any point of time, if there is a decrease in the cerebral perfusion pressure, there is vasodilation, and so we have increased cerebral blood flow and a vasodilatory cascade results, which causes an increased intracranial pressure. So if we use any maneuver that increases the blood pressure, this could inhibit the vasodilatory cascade and set off a chain of events which could help in improving the outcome of a patient while he is being managed in the intensive care. So historically, it started with the Rosner's concept, where we were taught that the cerebral perfusion pressure has to be managed greater than 70 millimeters of mercury with the use of fluids and vasopressors. And at the same time, another group of authors came with the Lund concept, where we were taught that the cerebral perfusion pressure, it has to be managed greater than 50 millimeters of mercury with the use of albumin and erythrocytes, which could help maintain a normal colloid osmotic pressure. Or again, we could use various agents as metoprolol to reduce the capillary hydrostatic pressure. And also we could use ergotamine to reduce the cerebral blood flow volume. So once this thinking was coming into vogue, in 2000, there was an article published in Anesthesiology by Claudia Robertson, and they summarized the traditional practice that was in vogue at that time, that ICP has to be kept less than 20 millimeters of mercury. And at that time, the new concept was coming, that's Rosner's concept, let us keep the cerebral perfusion pressure greater than 70. And at the same time, another group of authors was coming with the opinion that based on the Lund concept, that let's keep the cerebral perfusion pressure greater than 50 millimeters of mercury. But at the same time, even in 2001, there was a group of authors who came with the concept of individualized therapy that may hold true, as we'll see in the subsequent slides. So once the Rosner's concept came, it was seen that the mortality, once this concept was practiced, it was reduced to 29%, once it was compared to the historical controls of 60%. And again, from the Lund concept, it was seen that the 5-year non-randomized study in which Lund and his co-authors, they studied around 53 patients. They found that the mortality was around 8%. And this mortality was very less than 47% of the historical controls. But so far, we don't have a randomized trial whether Lund is better or the Rosner's is better. We do not have, as of now, a randomized controlled trial that has tried to address this issue. Sorry. So in 2000, for the first time, Brain Trauma Foundation guidelines, once they were published, they favored the Rosner's concept, and what was advocated that the cerebral perfusion pressure has to be kept greater than 70 millimeters of mercury. But at the same time, there were two studies that were published. One of the study was published in Critical Care Medicine, And it was seen in this study that once the cerebral perfusion pressure was maintained greater than 70 millimeters of mercury, and it was compared to the ICP targeted group. Unfortunately, the patients in this group, they had a higher incidence of ARDS. And at the same time, a post hoc analysis from a patient which tried to see the efficacy of sulfotil in patients, it was seen that if these patients, they had a cerebral perfusion pressure greater than 60 millimeters of mercury, the patients did not have an optimal, the patients, if the cerebral perfusion pressure, it was less than 60 millimeters of mercury, the patients did not have an optimal outcome. But if it was greater than 60 millimeters of mercury, the patients had a better outcome. So following these two studies, the Brain Trauma Foundation guidelines changed, and they recommended that cerebral perfusion pressure, it should be maintained above 60 millimeters of mercury. Later on, as transcranial Doppler became more frequently used in various intensive care units globally, and it was noticed that these unitary values of cerebral perfusion pressure of 70, 60, 65, they may not hold true. There may be different values for different patients, and there may be different values for a same patient at different points of time. So a concept of individualized cerebral perfusion pressure was suggested. And this was one of the study that was published in 2005, where the authors, they identified two types of patients. They found we can have pressure active patients who have an intact cerebral autoregulation. And this is the group of patients which respond better to hypertensive cerebral perfusion pressure therapy. And we can have a pressure passive patients, which have a non-intact cerebral autoregulation. And this group of patients, they could respond better to the hypotensive intracranial pressure oriented therapy. Recently, over last 4 to 5 years, now a lot of research is going on as to what are the targets of the optimal cerebral perfusion pressure. So what has been done in this area, a lot of research has been done, and various authors, they have tried to study the data that has been obtained from the waveforms that have been studied during the slow waves of the intracranial pressure waveform, and at the same time, the slow waves of the arterial blood pressure. And a log analysis of these waveforms has been done. And based on this, the authors, they have tried to develop various indices. And based on these indices, they have tried to calculate the optimal cerebral perfusion pressures. If the authors have seen from various studies that if the optimal cerebral perfusion pressure, it's in the range of 60 to 80 millimeters of mercury, it's better to keep the cerebral perfusion pressure 10 millimeters of mercury higher than that. And if we have already the optimal cerebral perfusion pressure above 80 millimeters of mercury, it's better to keep the cerebral perfusion pressure 5 millimeters mercury above or less than. A Cochrane analysis, a systematic review was again done, which was published recently in 2017-2018 by Edward Needham. And what the authors did, they took the data from around 8 studies, and 6 distinct data sets they were analyzed. And based on this, the authors found that if we follow this approach of targeting the optimal cerebral perfusion pressure study, it might represent a technique where we could have an improved outcomes following traumatic brain injury. But once they analyzed their evidence on the grade criteria, unfortunately, the quality of evidence, the quality of the evidence from the studies they have taken, they were not of a very high grade criteria. So the quality of evidence, though it's very low, at present, but it could be an area of research in the future, and in future probably this optimal cerebral perfusion pressures, once we derive these values, they could form the targets of determining the blood pressure targets that we have to manage in a neurocritical care unit setting. Thank you.
Dr. Ashutosh, since you were the first speaker, would you like to make any comments? You have a right to rebuttal if you wish to.
Good evening, ma'am, and thank you very much for your comments, ma'am. Actually, no, ma'am. Actually, in my vision, ICP and CPP are not two different entities. Practically, we can't target any one therapy without another one. So, in practically, we have to target the optimal CPP, and it ultimately causes decrease in the ICP. So, have to target it both side by side, actually, to improve the outcome of the patients.
Yes, I hope Dr. Kulkarni would also agree with this. I think we are both interrelated, and I think we need to look at a more individualized approach. And I think we also need to look beyond ICP and CPP. If you're looking at a holistic approach, we also need to look at measures of cerebral oxygenation. Of course, that was not a part of the discussion or the debate, but both of you were kind of on the same page. What is your opinion, Dr. Kulkarni?
What I feel is in the ICU, I think I'm audible. ICU, as you said, not only CPP and ICP, mean artery pressure is very important because TBI patient, traumatic brain injury, usually associated with polytrauma, one thing. And secondly, these two factors, both ICP and CP, are dependent on mean artery pressure. So in ICU, we have to manage continuous monitoring of artery pressure. That's a basic important. Mean artery pressure we have to monitor. Then comes the CPP and ICP. So that's confined to only brain part of it. But we have to look, as you said, holistic approach. That means we have to see the systolic or mean artery pressure, on which these two factors are involved. And of course, oxygen saturation. That's a multimodal monitoring what is required. In fact, in neuro intensive care, to have a better outcome from the patient point of view. That's what I feel. And I don't know any further clarification.
Also the airway pressure, but airway pressure also equally important.
Yes, obviously. Holistic approach, that's what is important. So many factors are important. Airway pressure again depends upon if it is high, then CVP will change and all these factors. So targeting only these two is not going to help. We have to be seeing all the monitoring and holistic approach and multimodal monitoring. That's what is important. A better outcome in case of TBI. Anything?
Monica, since so far as TBI is concerned, traumatic brain injury, in spite of all the extensive work that has been done so far as the ICP is concerned, the consensus of opinion is that it is not a very valid predictor of the outcome or the state of the patient. So from whatever we have gathered, and we have done, initially we did a lot of this Codman's ICP monitoring, and we also didn't find a lot of correlation between the clinical state of the patient and the state of the ICP readings. So I don't know what the general opinion is. Maybe I'm a little outdated. Is there any specific indicators for ICP monitoring in traumatic brain injury now?
Would you like to answer, Zulfi or Ashutosh? Ashutosh, would you like to answer?
The recent Brain Trauma Foundation's 4th edition, it says that level 1 and 2 recommendation, it is insufficient evidence. Whereas 3rd is saying that ICP should be monitored to improve the outcome of the patient. And the threshold is 22 mmHg. So it is till now, it is the best and high evidence-based what we have.
for ICP monitoring as well as for threshold.
I don't think you can isolate either ICP or CPP. They are all interrelated. You can't isolate them. You have to take a lot of factors in consideration to be looking at an optimal management. And if you look at a simplistic, very, very simplistic CPP equation, ICP is inherently included in that. So plus I think the focus now is on, the cerebrovascular reactivity and finding this thing. There were some very beautiful slides by Zulfikar about the latest research.
Does it boil down to the brain plasticity?
Hello?
Yes, also depends on the plasticity of the brain. It might differ from individual patients. That is the problem. It cannot be same to all the patients. So the outcome and may depend on that also. Because even CBP, as Zulfikar was telling, monitoring CPP and ICP has to be individualized. It's not that every patient will have the same target and same thing. That is also very important in management.
Yes, very much, sir. Sir, we are running short of time and I don't think there are any more questions. So with your permission, ma'am and sir, can we consider this session to be closed?
One second. I just want to thank Amna madam, Vibu Kallani madam, and all my senior colleagues like Chaudhary sir, Dash, and Uma Meshwara. Nice meeting all the people online after a long time. Thank you.
Actually, we are dying to have a physical conference. Now it's time we have a physical conference.
Maybe in Hyderabad next time.
Maybe next time, right.
Thank you so much for giving me an opportunity. And you have both the presentations were very good. The quality of slides were very nice. And you have a special congratulatory note from Professor Kj Chaudhary. And he writes that everything was very well explained. So compliments to the both of you. Thank you so much, ma'am.
Thank you so very much, ma'am. Thank you very much, sir. Thank you.
Thank you so much, ma'am. Thank you so much, sir. Thank you, the speakers and the
for the
chairperson.
wonderful presentation. Thank you.
Thank you, Amna ma'am. Now we move on to our next session, which has a mixed bag of topics. And in this session, to chair this, I would like to welcome Professor Bibu Kalyani Das ma'am, Professor R.S. Chauhan sir, and Professor V.J. Ramesh sir to join us in the dais. A few words about the chairperson. Bibu ma'am does not require any introduction, but a few words that I would like to say. Ma'am is the Director of Academics, Head of the Department of Anesthesia and Critical Care and Pain Clinic at Institute of Neurosciences, Kolkata. She was a former Head of the Department of Anesthesia, Neuro ICU and Pain Clinic at Bangalore Institute of Neurosciences, Kolkata. She has held various prestigious positions in the past, like the President of ISNACC, ANI, ISSP, and she's the present Dean of India Academy of Pain Medicine. She's a member of the editorial board of IJA, Neurology India, JNAC, and many other journals. She has delivered many orations in various conferences, like Professor Gode oration and Professor Harvar Singh oration in ISNACC, and Professor R.N. Chatterjee oration in Anicon in 2018, to name a few. She has received various awards in her lifetime, like the Distinguished Teacher Award by ISNACC in 2018, Lifetime Achievement Award for ISSP 2014, Bharatiya Chikitsak Ratan Award 2016, Vishishta Chikitsak Award 2019 by Government of West Bengal, Distinguished Senior Anesthetist Award, Eastern Zone, ISA 2019. She has over 92 publications in various national and international journals, various chapters in various yearbooks and various update books of pain, neurology, neurocritical care, and anesthesia. She has edited A Practice of Anesthesia and Resuscitation, 2nd edition. She's also the organizing chairperson of this 23rd ISNACC conference. A very warm welcome, ma'am.
Thank you, Navanita, for those kind words.
Professor R.S. Chauhan, sir. Sir is a distinguished professor in neuroanesthesiology and critical care at AIIMS, New Delhi. He has done his MBBS in 1991 and MD Anesthesiology in 1994 from MGM Medical College, Indore. He has over 25 years of experience in neuroanesthesiology and critical care. He has started neuroanesthesia services at Sultan Qaboos University Hospital, Muscat, and worked as a consultant at Sultanate of Oman from 2009 to 2011. He has over 70 publications to his name and has been instrumental in organizing various conferences and delivered several lectures and been the panelist in various forums and presented as much as 41 papers as author and co-authors at various conferences. A very warm welcome, sir.
Thank you very much.
Dr. Kj Ramesh, sir. He's an esteemed professor in the Department of Neuroanesthesia and Critical Care at NIHAMS, Bangalore. He has over 25 years of experience in neuroanesthesia. His area of interest include neuromonitoring, head injury, and subarachnoid hemorrhage. He has published more than 50 articles, mostly in international journals. He was a former secretary of ISNACC and the former scientific committee chairperson of ISNACC in 2016 conference, and the editorial board member of the Journal of Neuroanesthesia and Critical Care, and he has reviewed many journals in the past. A very warm welcome to all the chairpersons.
Thank you. Thank you.
And now I'd like to request Professor Bibhu Kalyani Das ma'am to introduce our first speaker, Dr. Bhumi Thakur. Over to Bibhu ma'am.
Thank you, Navanita, once again. And it is my pleasure to introduce Dr. Bhumika Thakure. She is a consultant anesthesiologist, PD Hinduja Hospital, MRC, Mumbai, accredited PG teacher for Dr. NB, Neuroanesthesiology, accredited AHA, BLS, and ACLS instructor. She authored chapters for anesthesia and neuroanesthesia books, authored review articles, authored research publications, and presented several posters, papers at national conferences. She is a speaker at the national and the state level of conferences. So I'm very happy to invite Bhumika for the first speaker of this session.
Kind words, ma'am. Good evening, everybody. At the outset, I would like to thank the organizers for giving me this opportunity to talk in front of such an esteemed audience and eminent faculty. My topic for the day is management of seizures during awakening after craniotomy. I'll be discussing the same with respect to its incidence, in which group of patients it's most likely to occur, the causes and pathogenesis, the types of seizures seen intraoperatively, the scenarios which mimic seizures, how to prevent the episode, treatment and recommendations from literature, and complications associated with the event. Now, seizures after intracranial surgery, unlike the post-traumatic seizures, are less reviewed in literature because of their complex background pathology and other confounding factors like extent of surgical insult, the skills of the surgeon, history of preoperative seizures. All this leads to a lack of guidelines for the management and treatment of the same. They are mainly divided into three categories depending on the timing following craniotomy, namely immediate, occurring within 24 hours after craniotomy, early, within a week, and late, occurring beyond 1 week after craniotomy. In true sense, the late seizures are described as true seizures and require long-term therapy. Overall incidence of immediate seizures is 3% and early seizures is 17 to 22%. Of these, 41% progress to late seizures requiring long-term therapy. Again, a definite incidence cannot be granted because of the multiplicity of pathologies, variety of operative procedures, the size and site of tumor differentiation, and a variety of age of patients undergoing these procedures. Manka et al. Studied 278 patients from 41 neurological institutes across Japan and found that the incidence of seizures in the post-operative period was highest in infective pathology, namely abscesses of the intracranial cavity, followed by tumors, namely meningioma and glioma. The latter also showed increased incidence of preoperative seizures in these patients. Apart from the pathology, other factors which increased the seizure incidence was position of the patient, more so seen in sitting position because of the incidence of venous air embolism and pneumoencephalus. Patients with history of preoperative seizures had higher incidence in 55% compared to 25% with no history of seizures. Infection of the ventricular shunt system increased the incidence from 20% to 47%. Aneurysm per se are not epileptogenic, but because they are ruptured and they cause intracerebral hematoma and associated complications, the incidence again of seizures increases from 3% to 48% in them. Hassan M. Aldarzi also reviewed patients coming for surgery and had an incidence of seizures after craniotomy for primary brain tumor resection. They also had similar findings, and they also postulated that tumors which affect the temporal, parietal, and frontal lobes had higher incidence of seizures, namely 33% compared to 24%. Of these, if they were smaller in size and of low grade, they had further increased incidence risk, namely 92% compared to 78%. The reason being that smaller and slow-growing tumors have a more time period to cause local tissue injury, leading to epileptogenesis. A surprising find was obese patients had higher incidence of seizures, 20% compared to 0.5%. This leads to formation of a high-risk group, and if any of this patient is on your table, you need to be vigilant in the post-op arousal phase, namely when the tumors are meningiomas, the gliomas, and are smaller and lower grade. If the surgeon has done a subtotal resection of tumors, leaving a foci for the seizures. If you have done an intraoperative cortical stimulation during the procedure. Of course, location of the tumors being temporal frontal, or a history of preoperative seizures, extremes of age and obese patients, and infection and sepsis are also red flags. Now, what are the causes? The most common cause is non-compliance of taking the anti-epileptic medication. It could be patient-related who forgot to take it, or the nurse who, because of nil-by-mouth orders, have forgotten to give him the normal dosage of the drug. Surgical causes are hemorrhage, acute tissue damage leading to tissue hypoxemia and edema. Metabolic and electrolyte abnormalities like hyponatremia, hypocalcemia, hypoglycemia can lead to seizures. Last but not the least, local anesthesia toxicity needs to be kept in mind. So pathogenesis, two mechanisms are proposed: free radical generation and disturbance of the ion balance across the cell membrane. Now, whenever there is a surgery, there is extravasation of blood, and hemolysis and breakdown products cause the iron to bind with hydrogen peroxide present in the tissue, leading to formation of the free radicals, which cause increase in the excitatory neuronal activity in the thalamocortical tract. Again, handling causes local cellular ischemia and hypoxemia and reduces the ATP stores, which causes a disturbance in the ionic balance across the membranes, which reduces the ratio of intracellular to extracellular potassium and sodium ions and causes decrease in the hyperpolarization of membranes, resulting in early seizures. This also leads to calcium efflux and increase in production of glutamate and decrease in transport of glutamate, leading to, again, excitatory pathway. This is the common phenomena seen in glioma patients especially. Now, what are the types of seizure presentation in these patients? The patients which have a history of preoperative seizures have similar seizure profile in post-operatively also. It is very rare to have a different seizure profile suddenly seen. In those with de novo seizures, that is, they never had seizure in their life, 81 to 85% are just focal seizures. 15 to 19% can show generalized tonic-clonic conversions. These are mainly sometimes just an extension of the focal seizures which have been missed and convert to tonic-clonic conversions. An entity which always needs to be kept in the back of the mind is non-convulsive status epilepticus, which is a persistent, more than 30-minute change in behavior and or a mental process from the baseline, and is associated with continuous epileptiform EEG, but has no major motor signs. The incidence is very rare, 0.5 to 1%, which accounts to 25% of all status epilepticus. So whenever you have a patient who has had a supratentorial surgery and has an altered level of consciousness, or if you have a fluctuating or unexplained alteration in the behavior or mental status of a patient, always keep this in mind that it could be non-convulsive status epilepticus and do an EEG to confirm the diagnosis. So they can present even after a single episode of seizure, and they can take form of prolonged confusional state, and sometimes it is mimicked and mistakenly thought that it is just post-ictal phase. The patients could be typically drowsy, but can present even with agitation, violent behavior. There can be mild, subtle blinking or jerks of the face, which can be missed by the observer. Amnesia, aphasia, their behavior, and hemiparesis can also be seen at times. The other differentials or scenarios which can mimic seizures are syncope, the most common. It could be triggered because of a vasovagal attack or a cardiac arrhythmia. It could be psychological, mainly psychogenic non-epileptic seizures or pseudo-seizures, panic attacks, or hyperventilation. Metabolic causes like hypoglycemic syncope, alcoholic withdrawal. Now, alcoholic withdrawal seizures are typically seen in chronic alcoholic patients, and they occur after 48 hours or within 48 hours after the abstinence from the last drink. Transient ischemic attack and breath hold. How does one differentiate? Now, psychogenic non-epileptic seizures are generally seen in young women, and it is of a slow duration from minutes to hours. They generally tend to forcibly close their eyes, do pelvic thrusting or vague, bizarre flinging of limbs. The movements are always not stereotypical, and there are infrequent bites or trauma to the patient. Post-ictal confusion is not present, and EEG is normal in these patients. Syncope 2 is less abrupt in its onset and doesn't have any association with incontinence or jerking of limbs. The post-ictal recovery is usually rapid with no post-ictal confusion, and EEG is also usually normal. So now that we know differentials, how do we prevent the occurrence? Now, Adam Nissan studied 641 patients who always had a history of seizures, and they came for any procedure and anesthesia in a period of 5 years. They concluded that patients with frequent seizures at baseline and with recent seizures before surgical admission are always at risk of perioperative seizure activity. They also found that the anesthetic technique used for surgery or the drugs used does not seem to have any role in the occurrence of the perioperative seizure, and most patients present with the same seizure profile which they had preoperatively. The usual antiepileptic medication regime should be followed to the core as long as possible and as closely as possible till the day of surgery. And if oral administration is not possible, make sure you give parenteral formulations of the same drug. Monitoring of blood levels of antiepileptic drugs is also essential to confirm whether they are therapeutically efficacious, especially if the patient gives a history of seizures within 3 days of surgery. Now, this was in patients which already had seizures, but what about them where the seizures are not present? Do we give AED prophylaxis? Now, there's a literature review by Jan Drapas in which they said that in patients without seizures, routine prophylaxis is not recommended. Even Cochrane collaboration concluded that there was no difference between placebo and treatment with phenobarbital, phenytoin, or valproic acid, and adverse events were more frequent when they started with anti-medication therapy. The only place where the recommended anti-seizure medication was when there were metastasis from the melanoma, and that too if there were multiple hemorrhagic and in supratentorial location. This is because this reduced the seizure threshold. So they do recommend that if it is in a high-risk group patient, anti-seizure prophylaxis could be thought of. Abdur Rahman Islim also studied only meningioma patients who came for craniotomy and had seizures perioperatively, and formulated this treatment plan. According to them, if the patient already had preoperative seizures, you need to continue their anti-epileptic therapy as described and continue it even after surgery for 3 to 12 months. But if the patient never had seizures, then you should consider to give them anti-seizure therapy if they lie in the high-risk group or they show one or more of the high-risk factors, namely if the meningioma was in a convexity location, or it is in the frontoparietal location, and in pre-op imaging, there was a midline shift. In these groups, if you start anti-seizure therapy, the incidence of post-op seizures were markedly reduced. However, if they do not fall in this high-risk group, routine prophylactic therapy again was not recommended. Similarly, Hassan Dorzi and Sami Ridwan again found whether preoperative prophylaxis was helpful, and both these studies again found that that was not helpful. They only recommended that yes, in high-risk groups they can be thought of because starting pre-op medications in high-risk group did bring down the seizure incidence in the post-op period by 41%. However, this was not statistically significant. They also recommended that if you were thinking of seizure prophylaxis, levetiracetam was turned out to be a better drug for prophylaxis with respect to drug interactions and adverse events. Also, it had more reliable pharmacokinetics. So in spite of every prophylactic treatment, if you still end up with an introp seizure, what do? You first initially stabilize the patient and maintain the ABCD. You rapidly try to terminate the seizure by giving anticonvulsants and also prevent further seizures by exploring metabolic, mechanical, electrical, or drug-induced etiologies. So initially, if the patient is still on the Mayfield clamp, immediately remove the clamp to prevent further injury and place a support under the head. However, don't try to restrain the patient. Of course, do apply the safety strap so that the patient doesn't fall off the table. You maintain a patent airway by turning the patient lateral and try to suck out all the secretions. However, don't forcefully try to push in anything through the mouth if the mouth is clenched. Provide 100% oxygen by bag mask ventilation, and if the patient is still intubated, of course, you continue ventilation. However, do not hyperventilate the patient, as this can further trigger seizures. Maintain hemodynamic stability, and if outline is in C2, collect blood for investigations, namely electrolytes, magnesium, calcium, glucose, and blood gas analysis. Sometimes by the time you do this, the seizures subside on their own. If not, you need to progress towards drugs. The first line being benzodiazepines, which enhance the inhibitory effect of GABA. The drugs commonly used are midazolam intravenously, 0.5 to 2 milligram increments, maximum up to 10 milligram. Lorazepam intravenously, 1 to 4 milligram increments, maximum up to 4 milligram. And diazepam intravenously, 0.1 to 0.3 milligram per kg, maximum up to 10 milligram. If the first line of defense again fails, then move towards anti-epileptic drugs. The most commonly used ones are the phenytoin and levetiracetam. If the patient is already on one of these drugs, make sure that the dose has been given and repeated intraoperatively. If not, give the dose now. In spite of giving the scheduled dose, if the patient still has seizures, you need to add up the drugs. So if your patient was on phenytoin, you add up levetiracetam. Kapoor et al. Did a study to find whether the safety profile and efficacy of the 3 commonly used drugs, and found that there was no significant difference in the rates of seizure cessation or in their safety, and all 3 were equally effective. He also found that levetiracetam showed more of neuropsychiatric complications, valproate more of hepatic, and fosphenytoin had cardiovascular complications, namely hypertension and supraventricular tachycardia. So how do you choose? So either fosphenytoin or levetiracetam, both can be used as your first choice of drugs, depending on whichever is available. However, when you're using fosphenytoin, give it slowly, otherwise the risk of hypertension is present. Revacitaram, be careful if in renal insufficiency patients and in neuropsychiatric disorder count. In spite of anti-epileptic drugs, if the seizures still continue, you have to move to the third step, which is anesthesia. First of all, if there's difficulty in ventilating the patient, administer a short-acting muscle relaxant and intubate the trachea. You may need longer-acting muscle relaxant to continue aid in ventilation and also prevent complications because of the excessive muscular activity. One needs to start propofol infusion, 30 to 200 mics per kg per minute, and inhalation agents can be continued if the seizure activity persists. All this finally will control seizures, and once that happens, monitor the EEG to confirm that it is a post-ictal phase and not non-convulsive status epilepticus. On your way to the ICU, do a CT or MRI to rule out the cause, also to check the damage caused because of the seizure. The most common complications encountered are hypoxemia, aspiration of gastric contents, cardiac arrhythmias, electrolyte and glucose abnormalities, pulmonary edema, hypertension and respiratory depression mainly from anticonvulsant therapy, and neurological injury ranging from prolonged hypoxemia, impaired cerebral autoregulation, and intracerebral hemorrhage. Most dreaded complication is sudden unexpected death in epilepsy. It is defined as sudden and unexpected, which is not contributed to trauma or drowning, and in an individual with epilepsy with or without evidence of terminal seizure, and excluding documented status epilepticus, and in which investigation and postmortem examination shows no cause, not even toxicology, as a cause for death other than epilepsy. The incidence is 2 to 18% of all seizure-related deaths. The risk factors range from history of generalized clonic seizures more than 3 in a year, age between 18 to 40, association with congenital long QT syndrome, subtherapeutic anti-seizure medication levels, alcoholism, long duration of epilepsy, structural lesioning, or neuroimaging. Now, why does it occur? Ictal bradycardia, atrioventricular block, and even E-systole are observed in some patients with epilepsy. The reason could be because of changes in the QT interval and autonomic instability, which predisposes to malignant arrhythmias. Release of catecholamines during seizure may also lead to cumulative cardiac injury, like those seen in aneurysm patients, and makes it susceptible to arrhythmias or sudden hemodynamic compromise and even cardiogenic shock. There is respiratory dysfunction in the form of ventilatory failure with ictal hypoxemia and hypercapnia, which is again centrally mediated. Frank apnea also is sometimes observed. Other causes of ictal respiratory compromise are laryngospasm, asphyxiation, aspiration, and neurogenic pulmonary edema. Neurogenic cardiopulmonary dysfunction is mainly seen when there is prolonged post-ictal generalized EEG attenuation of more than 50 seconds. It, along with a combination of central apnea, severe bradycardia, and transient or terminal EA systole, can lead to sudden death. These changes typically peak between 1 and 3 minutes after the seizure. Now, once the patient is, the seizure is subsided, in the post-ictal phase, you need to continue care of the patient. Keep the patient on one side to prevent aspiration and make sure the airway is patent. There's usually a period of confusion after a grand mal seizure, or a short apneic sleeping period, which may occur during or immediately after a generalized seizure. The patient will be generally disoriented, so orient him, and if they are agitated, use calm persuasion and gentle restraint. Follow up the labs and find the cause so as to prevent further episodes. To summarize, incidence of post-op seizures, though rare, complications are devastating. You need to be more vigilant in the high-risk group, namely of meningioma, glioma, extremes of age, suboptimal resection, and history of preoperative seizures. Continue anti-epileptic drugs as per routine schedule preoperatively and give intra-op dosage as per schedule. Consider anti-epileptic prophylaxis in high-risk group of patients. And lastly, good teamwork between anesthetists, neurosurgeons, and neurophysicians is a mandatory for a successful outcome from a post-operative seizure. Thank you.
For that excellent presentation.
Thank you, ma'am. Now I'd like to request Professor R.S. Chauhan, sir, to introduce our next speaker, Dr. Priya Goel. Over to you, sir.
Hello, am I audible?
Yes, sir.
Yeah. So for the next presentation, I'm inviting Dr. Priya Goel from Fortis Cards Hospital, Jaipur. Dr. Priya is a consultant anesthesiologist, a BLS and ACLS instructor and course director. She is also a regional faculty of American Heart Association. Dr. Priya is an instructor in Airway Management Foundation, and she happens to be executive member of Jaipur Society of Anesthesiology and also member of ISNACC and NCSI. She will be speaking on a very common scenario in neurosurgical, like pediatric neurosurgical operation theaters. 10-year-old patient posted for excision of craniopharyngioma, the perioperative management. So, Dr. Priya, please start your presentation.
Hello and greetings to all. Today my topic is perioperative management of a 10-year-old child with craniopharyngioma. Craniopharyngiomas are rare and benign epithelial tumors innervating along the path of craniopharyngeal duct, seen commonly in children with ages of 5 to 14 years and have 2 to 6% of all pediatric primary intracranial tumors. Effective perioperative management of the craniopharyngioma needs a multidisciplinary team, which will include an endocrinologist, oncologist, neurosurgeon, anesthetist, and an intensivist. The key concern in the management of these tumors are the size of the tumor and its effect on the intracranial pressures, the vicinity of the tumor to the nearby neural and structures and the vessels, the hypothalamic involvement, endocrine derangements, the compressive symptoms due to the tumor, involvement of the visual pathways. Then comes the pediatric age group, which itself poses a lot of challenges. Then the high recurrence, undesired effects of radiotherapy, high mortality and morbidity. Coming on to the classification of craniopharyngiomas, based on etiology, it is of 3 types. The first one is adamantinomatous tumors, which arise from the epithelial remnants of the craniopharyngeal ducts. This form is common in children. It has a high recurrence and are very locally invasive. The second one is the squamous papillary, which are common in adults. And the third is the transitional or the mixed type. The other characteristic feature of these tumors are that they are avascular, then they are rarely malignant, and they are locally invasive. Depending on the invasive nature of the tumor, they could be cellular, supracellular, paracellular, retrocellular, infracellular, or even multi-compartmental. In this slide, we can see that how the tumor is in close vicinity with some of the important structures, as we have already talked about in the last slide. Now, the clinical presentation of this tumor, it depends on the size of the tumor, the site of the tumor, and the compression of the vital structures that it might do. So, it may have neurological symptoms leading to headache, cranial nerve palsies, motor disorders. Because of the close vicinity of the optic chiasma, it may lead to the homonymous temporal hemianopia or optic atrophy. Endocrinal derangements because of the involvement of the pituitary is very significant. Because of the growth hormone deficiency, the children may have growth failure. There could be diabetes insipidus. There could be hypogonadism and the diabetes insipidus, hypothyroidism, and sometimes precarious puberty might be there. Then because of the hypothalamic involvement, the patient may present with aphasia, obesity, somnolence, and sometimes the autonomic dysfunctions. Brain parenchyma involvement leads to the cognitive dysfunction. Ventricular system involvements leads to even to the decreased consciousness level. And the other concern is because of the involvement of the major blood vessels. Coming to the treatment part of these tumors, the first part is the medical management, which will include the hormonal replacement therapies for all the endocrine abnormalities. The second one is the surgical approach. Surgical approach could be for the taking up the biopsy, for subtotal excision or total excision of the tumor. So endoscopic transnasal transsphenoidal approach can be used for small cellular tumors, or a craniotomy and excision for supracellular large tumors. Then comes the radiotherapy, which can be done after biopsy, after subtotal excision, or in cases of recurrent tumors. Other modes are the intracystic radiotherapy, chemotherapy, aspiration, and sometimes an emergency Umayya reservoir or biventricular shunt in children with giant tumors. Talking about the preoperative concern, yes, the PAC always has a large importance in management of any patient. The first point would be the history taking. The clinical presentation and neurological assessment is important. Now, how do we diagnose these tumors? On the MRI, these tumors vary from small, solid, well-circumscribed mass to large multilocular cysts that may invade the sella turcica and displace the cerebral structures. T1 weighted images may show hyper-intense for cystic component and iso-intense for solid component. T2 images, however, shows both cystic and solid component as hyper-intense. In cases of CT scan, it appears as heterogeneous tumors, cystic component being hypodense and solid being isodense. Presence of any calcification is suggestive of diagnosis of craniopharyngioma. Here we can see the MRI scan and the CT scan showing the craniopharyngioma. The third important point is we must do an endocrine evaluation of such patients. So the test conducted would be the thyroid function test, the growth hormone levels, cortisol levels, sex hormones, ACTH and prolactin. In cases where hypoadrenalism, diabetes insipidus or hypothyroidism is found out, then they have to be corrected preoperatively. For that, if the cortisol levels are low, a supplementation of steroid with hydrocortisone to be started. Diabetes insipidus to be treated with fluid management, vasopressin or desmopressin, and hypothyroid patients, for them, the tablet thyroxine has to be supplemented, targeting the free T4 levels. Next point will be the evaluation of any other current medication, maybe the anti-epileptic agents, hormonal therapies. And so we must make a note that all the morning doses of steroids, thyroxine, and anti-epileptics to be given on the day of surgery. Another assessment will be the ophthalmological assessment, visual acuity, field of vision, and retinoscopy for papilledema to be done. Because as we already know now that such children may have maybe have obesity. So a thorough airway examination should be done. Short stature and obesity may pose challenges in airway management. Obese children may have OSA and they are categorized as high-risk candidates. A proper counseling should be done about the extent of the lesion, anesthesia technique, complication, post-op ICU stay, NBM status should be notified, and a written informed consent is mandatory. Coming to the intraoperative management, the monitoring part would include the oxygen saturation by the pulse oximetry, ECG, capnography, temperature, urine output monitoring, and of course an arterial cannula, which will help in beat-to-beat BP monitoring, in identifying the fluid deficit, and we can send the blood gases and may know about the electrolytes, osmolality, glucose, hemoglobin. Central venous cannulation, of course, that is important. It might be needed for rapid replenishment of the acute blood loss or inotropes administration. Then CVP monitoring can be utilized for diagnosis and management of diabetes insipidus. The anesthesia part. Of course, balanced anesthesia is a prerequisite. Goal is to maintain the cerebral perfusion pressure and avoid any increase in ICP. Intravenous induction is ideal, but inhalation induction with sevoflurane can be preferred in the children who are uncooperative and have a difficult IV access. Multimodal analgesia can be provided in form of IV fentanyl, paracetamol, and scalp block. Sympathetic response to the laryngoscopy should be blunted, and preparations for difficult airway have to be undertaken. Mannitol, of course, 0.25 to 1 gram per kg may be given in cases with increased ICP, and maintenance is accomplished by total IV anesthesia with use of propofol and dexin, or a combination of IV and inhalational agents. A continuous infusion of neuromuscular blocking agents should be done to ensure a motionless surgical field. Normovolemia is the accepted criteria for the perioperative fluid management, and normal saline is the fluid of choice. However, now balanced salt solution may also be used, as they have shown to have better control over acid base and electrolyte status. Then glucose monitoring is another important point, and it is crucial. Continuous supine position with head tilt is commonly advocated. The Mayfield frame is used to fix the head with pediatric pins, or the head is supported in the horseshoe frame. Application of skull pins in pediatric patient, we all know that there is danger of intracranial hematoma, dural tear, and skull fractures, so it should be taken care of. Next comes the careful positioning should be done in view of the airway compromise, so that we have to look that there is no kinking of ET tube or endobronchial migration. There is no venous congestion of the neck. The IV access, monitoring cables, arterial line tubings, nothing to be kinked. Padding of all the pressure points and protection of eyes to be done. Now comes the intraoperative concerns and the risk that we can find during the surgery. So it could be adrenal insufficiency. So a perioperative steroid placements with IV hydrocortisone as per the endocrinologist recommendations to be started. There could be significant blood loss. So preoperatively, we should calculate the blood volume and allowable blood loss and keep blood in hand. Closely monitor with the intraoperative hematocrit and hemoglobin. Sometimes hypotension, which is not responding to vasoactive drugs, may be seen in cases with severe hypoadrenalism. In such cases, injection hydrocortisone 1 to 2 milligram per kg may be beneficial. Then the next could be the next possible one, and the most common one, I would say, is the diabetes insipidus, for which the details we'll see in the next slide. Then comes the hypothalamic disturbance, which could lead to temperature dysregulation. And in patients in whom such temperature dysregulation is there, they have a bad prognosis. Brainstem injury, if it is rare, but if it occurs, then may lead to the comatose state. Seizures may be common. Cerebrospinal fluids leak is another complication that could be seen after transsphenoidal approach. So try avoid bucking and cuffing on extubation of the trachea. Then injury to the adjacent neural structures like to the optic chiasma may lead to the deterioration of the vision. So the most common diabetes insipidus, the most common intraoperative complication, most anticipated one, the incidence is around 60 to 70%. And this occurs because of the injury to the pituitary stalk or hypothalamus, which leads to decreased ADH secretion, resulting in diuresis and electrolyte imbalance. Coming on to the management of intraoperative diabetes insipidus, it could be if the urine output is more than 4 ml per kg per hour, the serum sodium levels is more than 145 milliequivalent, serum osmolality is more than 300, and urine osmolality is less than 300 milliosmol per kg. Or we can say there is a presence of polyuria for more than 30 minutes. Of course, the other causes of polyuria have to be excluded. So fluid management is the key factor for the maintenance, the control of diabetes insipidus. Do not try to chase the urine output with IV fluids, and replace fluid deficits and blood loss with normal saline blood and blood products. ABG sampling has to be routinely done for serum sodium and the osmolality. Then a vasopressin infusion has to be continued. You start with a dose of 1 milliequivalent per kg dose, and it could be escalated to a maximum of 10 milliequivalent per kg per hour, so that as to target the urine output to less than 2 ml per kg per hour. The post-operative care has to be carried out. Keep titrating the vasopressin infusion. A dedicated ICU care is needed, and continuous regular monitoring of serum electrolytes, osmolality, urine output, and blood glucose to be done. Coming to the post-operative concerns. Patient undergoing uneventful intraoperative course can be extubated at the conclusion of surgery. But if the patient develops severe dyselectrolytemia, hemodynamic instability, hypothalamic injury, changes in osmolality, and acid-base disorders, then may require post-operative respiratory support. Another thing to be kept in mind is a good analgesia plan to be discussed with multidisciplinary team. Then post-operative seizures to be kept in mind and continue the anti-epileptics. Other intraoperative problems can be carried out in the post-operative periods also. So DI, hyponatremia to be managed. Continue steroid replacements to balance the hypothalamo-pituitary axis. In children undergoing radical surgery, hypothalamic dysfunction such as hyper or hypothermia, behavioral, and other memory changes may be evident. These children with loss of temperature hemostasis, they usually have a bad prognosis. Then the other concern is there might be a residual tumor. So MRI scan is to be repeated to see it, and it can be treated by radiotherapy. So the conclusion is preoperative evaluation and proper planning with the knowledge of the extent of symptomatology are the keys to right surgical decision and optimal anesthetic management. An anesthesiologist plays a major role in directing perioperative management, which is critical to help improve the outcome. And success of the outcome depends on proper identification of the patient, preoperative optimization, surgical decision, awareness of complication, timely intervention, and optimal post-operative care. Thank you.
Thank you, ma'am. Thank you for this wonderful presentation. Now I would like to request Professor Vijay Ramesh sir to introduce our next speaker, Dr. Bhuvana Ahuja ma'am. Over to you, sir.
Dr. Bhuvana Ahuja is an assistant professor from Lok Nayak Hospital from New Delhi. So she is going to speak on the hemifacial pain management. So she has done the fellowship in pain medicine and a fellowship in regional anesthesia. And she has published more than 10 publications and about 7 chapters she has written. And she has a good experience in the neuroanesthesia and neurocritical care. And her interests are in the interventional spine procedures and critical care. Over to you, Dr. Rajan. Please start that talk.
And organizers of ISNACC 2022, especially Dr. Ghosh, for giving me this opportunity today at such a prestigious platform. Now, my topic today is hemifacial pain. I'll be starting with a case. A 45-year-old female patient came with history of right side facial pain for 5 years. Her pain was sudden, severe, brief, intermittent, and was electric shock-like. Was radiating to right lower cheek, behind the ear, and lower jaw. It was triggered by brushing teeth, eating, washing face and swallowing. There were multiple episodes in a day which was lasting for a few seconds to few minutes. Her pain scores were 10 on 10. She visited dentist, but she had no relief. She was a known case of hypertension. Later, she was put on carbamazepine, followed by gabapentin and pregabalin for her pain. With carbamazepine, she had some relief initially. Now, allodynia was present in the distribution of 5th cranial nerve, mainly in the 2nd and the 3rd division, and her MRI brain was grossly normal. Now, this was the patient, and she had pain in the maxillary and the mandibular divisions of the trigeminal nerve. Now, once we see the history of the patient, most likely diagnosis, which we could consider as trigeminal neuralgia. Now, this is a very specific type of facial pain, critical to make diagnosis because treatment for trigeminal neuralgia is different compared to other types of facial pain. According to International Classification of Headache Disorders, it gives certain criteria based on history and clinical examination for a hemifacial pain to be classified under, to be diagnosed as trigeminal neuralgia. Now, the first point is that it should be, the pain should be recurrent paroxysms of unilateral facial pain in the distribution of trigeminal nerve with no radiation beyond. The pain should be lasting from a fraction of seconds to 2 minutes, should be severe in intensity, and should be electric shock-like, shooting, stabbing, or sharp in quality. Also, the pain should be precipitated by noxious stimuli within the affected trigeminal distribution. So, our patient's character of pain does fit into this criteria, but also the last point says that it should not better be accounted for another ICHD3 diagnosis. So, what are the other differentials for hemifacial pain we can consider? Now, another point I want to mention here is that at times patient will say that the pain is constant, aching, not always triggered by non-noxious stimuli, but there is also sudden, sharp, severe pain in the region of trigeminal nerve. So this may be accounted, or this may be considered as atypical form of trigeminal neuralgia. Now, the first consideration in the differentials could be that there could be a trigeminal autonomic cephalgia. This includes cluster headache, paroxysmal hemicranias, and SNACC syndrome. The pain is sudden, sharp, excruciating, especially in the 1st division of trigeminal nerve. But the important catch point here is that the pain will be associated with certain autonomic features. Now, isolated 1st division involvement of trigeminal nerve is also seen, but this is very rare and autonomic features will not be present. Now, next, this dental pain can also cause hemifacial pain, but these pain are localized, may be associated with hot or cold food sensitivity and associated with certain dental abnormalities. Now, it often happens that trigeminal neuralgia is misdiagnosed as dental pain. So one has to be careful while diagnosing trigeminal neuralgia. Next is giant cell arteritis. In this, jaw claudication is seen, persistent pain is present in the temporal region, and it is often bilateral. So none of this differentials, our patient's features doesn't fit into these differentials. Now glossopharyngeal neuralgia pain will be similar to trigeminal neuralgia. It will be similar in features, but the pain will be present in the distribution of glossopharyngeal nerve. Now, intracranial tumors may also cause hemifacial pain, but it will be associated with neurological signs and symptoms. Migraine migraine will also cause hemifacial pain, but this pain is longer lasting, and photophobia and phonophobia will be associated with it, and patient will give a family history of same. Now, otitis media pain will be localized to ear. There will be abnormalities on the examination of the ear. So next important differential is post-herpetic neuralgia. In this, patient will give a history of zoster, and once the rash goes off, patient will start developing an excruciating pain in the first division of trigeminal nerve. The pain will be continuous, and there will be tingling sensations. So in this, important point is the history of herpes zoster and first division will be mainly involved. Now, sinusitis pain will be persistent pain with nasal symptoms. Next differential could be the temporomandibular joint syndrome. In this, the pain will be persistent and localized to teeth, gums, and jaws, and certain jaw abnormalities could be present. This is mostly associated with more common in diabetic patients, and pain may set off by moving jaws and talking, but this is not so with trigeminal neuralgia. Now, if in case there is a damage to the trigeminal nerve due to accident, surgery, or any multiple dental procedures, we'll term it as trigeminal neuropathy. And in this, there will be sensory, the pain will be associated with sensory losses. There would be numbness in the region and burning. So these features will not be present in case of neuralgia, but in trigeminal neuropathy. Then occipital neuralgia pain is mostly associated, mostly present in the posterior headache. So our patient doesn't fit into these criteria. Then ticked convulsive can be considered as a differential, but the prominent feature here is that there will be a hemifacial spasm. Now, multiple sclerosis is associated with trigeminal neuralgia, but in this, it is the features is mostly bilateral. First division is involved, and there will be other neurological symptoms. Also, if a young patient is coming to you with a trigeminal neuralgia, then this has to be, multiple sclerosis has to be ruled out. Now, once we have ruled out the other causes of hemifacial pain, we gave this patient maxillary, mandibular, and a mental nerve block, and she had more than 80% pain relief. So we come to the conclusion that this is a case of a classic trigeminal neuralgia. Now, one important point is that what is the importance of MRI as far as the diagnosis of trigeminal neuralgia? Now, MRI is the imaging modality of choice to visualize the entire course of trigeminal nerve. And when we ask a patient to get an MRI, we should mention that that MRI with trigeminal neuralgia protocol has to be performed. Now, what we will see on what will be the radiological findings in this? The diagnostic signs, there will be neurovascular compression present, and the diagnostic signs would be that there could be loss of intervening cerebrospinal fluid between the nerve and vessel. Second is that nerve displacement by the vessel can be seen, and atrophy of the nerve in the trigeminal zone due to focal demyelination can be appreciated. mostly it is the superior cerebral artery which is involved or is in the proximity to the trigeminal nerve. Now this is the scan of this patient with the trigeminalgia protocol. Here these white arrows shows the neurovascular compression over the sensory root of the trigeminal nerve, and this is the axial, coronal and the sagittal scans. Sorry. Now, what will be the first step in management of such a patient? If a naive patient comes to you, our patient was already on certain drugs. Now, the first step would be pharmacotherapy. Now, American Association of Neurology gives certain evidence for using certain drugs for cases of trigeminal neuralgia. Now, there is a strong evidence for support of carbamazepine, and there is a good evidence for oxcarbamazepine. So both these drugs are considered to be the first line therapy in case of classic trigeminal neuralgia. Also, if these drugs they are not very effective, then there are certain other drugs which could be used, but the evidence is weak. So these drugs like baclofen, lamotrigine or pymoside can be used as an add-on therapy with the first line of drugs. Now, there is a little evidence to guide the clinicians on the treatment of trigeminal neuralgia patients who failed first line therapy, and only some evidence supports add-on therapy with lamotrigine or a switch to baclofen. Now, in case of symptomatic trigeminal neuralgia, there is insufficient evidence to support or refute the effectiveness of any medication in treating pain. So the effect of other drugs commonly used in neuropathic pain is unknown, but there are certain drugs commonly used along with the first line drugs for the treatment of symptomatic trigeminal neuralgia. In clinical practice, it is seen that these drugs are effective to a certain extent. Now, if there is an acute exacerbation of pain, the intravenous route, the efficacy of intravenous route, we do not have sufficient evidence to support. So, if there is such a patient with acute exacerbation, IV administration is generally, I have not seen giving IV administration for patients of trigeminal neuralgia. Now, with carbamazepine, one should be careful with monitoring of blood counts, sodium and LFTs and HLAs, because it causes certain fatal or certain diseases. First is that it may cause severe hyponatremia. It may cause suppression of the bone marrow, liver failure, and serious problems like Stevens-Johnson syndrome. So monitoring in case of carbamazepine is very important. Now, oxcarbamazepine, it's same that monitoring has to be done, but the safety concerns with oxcarbamazepine is comparatively less. Now, baclofen, lamotrigine, both these drugs is associated with sedation. So with these drugs, one has to start low and go slow. One has to follow it so that the side effects can be minimized and patient will adapt to the dosage. Now, it is seen that lamotrigine is the patient can tolerate lamotrigine quite well. Now, pymoside is not popular with the clinicians because of its severe side effects. One is QT prolongation. So, strict ECG monitoring is required. Also, extrapyramidal symptoms is seen. So, this is generally not prescribed. Now, gabapentin and pregabalin, one has to be careful with the side effects that it may cause sedation and dizziness to the patient. So again, one has to start low and go slow. So this is a common combination which is used in patients of trigeminal neuralgia, that is carbamazepine, gabapentin, baclofen, and nortriptyline. So our patient is at this stage. So now what further management or what further options we can give to the patient? Now, when surgical intervention is required, now if in case there is incapacitating symptoms of trigeminal neuralgia despite a trial of at least 3 drugs in sufficient dosage, or when medications caused unacceptable adverse effects, or there is relapse of symptoms, in these situations one should go in for a surgical intervention. Now there is a whole list of surgical interventions, but there is certain important ones which is commonly there is more evidence for it, and the more RCTs are available for these procedures. I'll be discussing the first 3. The first is microvascular dissection. In this, the comparative study of all these 3 procedures were done, and it was found that with microvascular dissection, more than 90% relief from pain was there, and 70 to 80% people will have a long-term pain relief, and the mortality was 0.2 to 0.4%. But there were with any open surgery, there are major risk factors involved. So in this, first is infarct. That patient may develop infarct, hematomas, sensory loss or hearing loss, or aseptic meningitis. So the second in the list is the radio frequency thermocoagulation. In this also, it was seen that there was more than 95% pain relief. The long-term pain relief was seen in 57 to 75% patients, and the mortality was low. It could be associated with the sensory losses, corneal numbness, keratitis, dysarthritis, or anesthesia dolorosa. Now, percutaneous balloon compression therapy is usually done for first division of trigeminal nerve because this protects the corneal reflex. So this is more commonly used with the first division of trigeminal nerve. And the third, that stereotactic radiosurgery technique is not very commonly used. The reason being that it causes delayed pain relief. So if a patient is having excruciating pain, that patient will want immediate pain relief. So with the patients, this is not very popular. So now for this patient, we gave an option for radiofrequency thermocoagulation because one, it's a minimally invasive procedure, and if you see this immediate pain relief, it is almost similar. Also, there's a paper published in 2021 which says that though microvascular dissection is the first line treatment for for classical trigeminal neuralgia, but there is an increasing number of clinicians which would prefer for RFTC, and the reason being that it can be used in emergency where patients are not fit for surgery and can be used for other types of trigeminal neuralgia. The complications can be reduced by precise cannulation, and hence it is safe and effective as a minimally invasive method of pain relief. So this RFTC is, the principle behind it is that it blocks the pain signal conduction by high temperature up to 90 degrees Celsius to destroy the nerve, or modulation of the nociceptive nerve fibers of trigeminal nerve with temperature not exceeding 42 degrees Celsius. Now in this, the cannula is placed under fluoroscopy, and this stellate is replaced with the thermocouple probe. Now, first we'll do the sensory stimulation and motor stimulation. And then after doing the stimulations, the 3 or 4 lesions are made in the gassalian ganglion. And the lesions are of 60 seconds each. Now the major side effect is facial numbness, but the patient, once the pain is not there, so this is the numbness is it is seen that it is tolerable to the patient and gradually it decreases. Now this is a video I want to show of how the RFTC was done for this patient. Now I'll be showing one more video wherein the focus is just on the motor stimulation, how motor stimulation is done and the contraction of the muscle. This is a picture of foramen ovale. You can see the needle inside the foramen ovale. This is an AP view. This picture is also an AP view, but of a different patient. I'm showing this picture because here you can easily appreciate the position of the foramen ovale. Now this is a lateral view of the same patient. Here you can see the position of the needle. That is all I want to tell about the hemifacial pain. Thank you for this algorithm one can follow for treating or managing a patient of trigeminal. Thank you for your patient listening. That is all. Thank you.
Thank you, ma'am. Now I would like to request our chairpersons to open the session for question answers, but due to lack of time, we can only take up 1 or 2 questions. Over to the chairpersons.
Okay. Thank you, Navanita. And I think the last deliberation is very prolonged one. Anyway, so I'm very thankful to all of you that I'm sharing the chair with Dr. Ramesh and Dr. Chauhan. So now we'll ask questions open for the first speaker, that is Bhumika. Dr. Bhumika, she has very elaborately discussed everything regarding the seizure, prevention of seizure and everything. Any question in your chat box, Navanita?
Oh, ma'am, I don't see any question, but I see Professor Amna Goshami. She has raised her hand, so we can go to Professor Amna Goshami, ma'am.
Okay, Amnaji, please. Any question to the first speaker?
To the lady who spoke about post-operative seizure.
She's not responding. So I have
no, ma'am. Ma'am is responding. Amna ma'am is asking the question to our second speaker.
So any question for the first speaker?
No, ma'am, I don't see any questions for the first speaker here.
So may I ask one question, 1-2 question to the first speaker?
Sure, ma'am.
So Dr. Bhumika, so very good and elaborative, and you covered everything, all the issues for this thing. But when for the you said prevention,
Yes,
and when we have very small tumor, and if it is there was no convulsion before, no preoperative convulsion, any time that patient hasn't any convulsion, and it is either in the temporal lobe or in the frontal lobe, very small tumor. So without any history of convulsion and any temperature or infection or anything, so in that case, what you will do? You will go for preventive measures.
If the tumor is a meningioma or a small grade glioma, yes, they recommend that in those cases, the patients do need preoperative prophylaxis. Or if it is a MET, especially from a melanoma. Apart from these scenarios, generally they don't advise a blanket rule for preoperative prophylaxis. So it will based on the histopathology of the tumor.
Another question that risk factors. These are you have already told, but whether a obese patient is at risk or not.
Yes, it is. One of the study did show that the risk increases in obese patients from 0.5 to almost 20%. Namely, again, they say that because of the anti-epileptic drugs, if the patient has an episode of seizure earlier and is already on anti-epileptic drugs, due to interaction and drug interactions causing insulin resistance, the patients generally tend to be obese, and in these cases, the risk increases for the post-op seizures. Yes. To almost 20%.
Already that patient is having anti-epileptic. So you will increase the dose or just continue the same dose?
Continue the same and also give intraoperatively. Just before you are going to awaken the patient, give the routine dose as a dose. Like if the patient was on a levetiracetam dose given at 6 in the morning, you're finishing your surgery at around 3. So give again a repeat dose of 500 milligram before at the time of dura closure is recommended in such high risk.
Very good. Another is if the patient is with history of obstructive sleep apnea.
Okay.
There also you have to give preventive one.
There is no literature or saying that increases the risk of post-op seizures. So no.
Okay. And a pregnant patient without any history of seizure.
Pregnant patient itself can have, because of magnesium and other changes associated with pregnancy, they are at risk. And you need to give prophylaxis again if they are in high risk category. Yes.
Okay. Thank you very much. It was very excellent. Thank
you so much.
Now,
Ma'am, there is one person has raised his hand. Devoshri Roy, Dr. Devoshri Roy. But he's in the attendees. There is he wants to ask a question, but I don't see him here. So if he has any questions, you can write it in the chat box.
Okay. Then we can go to Professor Amna Goshami for